is having obstructive apneic spells during night and with this disturbance of sleep. And the indication for this patient of adenotonsillectomy is obstructive sleep apnea. And now the indications has been changed recently for last few years. It is the first indication for adenotonsillectomy is now obstructive sleep apnea in case. And the second indication, as usual, it was earlier recurrent adenotonsillitis. So we are going to start the case.
So can you just show us the patient picture? How you position it?
Pardon? Hello?
Miss, position of the patient, your
Position of the patient is tonsillar position.
Good morning, sir. Nice to see you in the morning. Now, sir, would you like, we'd like to know the settings of carburetor and all the
Yeah. We will be showing that.
Okay.
For tonsillectomy, coblation tonsillectomy, we are having the company setting 7.3. And for adenoid, we change the setting to 9.4.
Okay. What is the rationale for this, sir?
Pardon?
Like, there has to be some reasoning or logic for all this setting.
Yeah. So we know that coblation is a plasma-driven technology. So this 4 is 1, 2, 3, 4, 5 is coagulation technology, and from 1 to 9 is coagulation technology. So we have to increase the coagulation part whenever it is required, and in adenoid surgery we usually take 9.4 setting. वो लगा ना
सर आपने बोला ये स्लीप स्टडी से लिया है, तो हैव यू इवैल्यूएटेड द चाइल्ड फॉर स्लीप स्टडी, लाइक वेदर एपनिक स्पेल्स या कुछ देखा था कि अपन को क्लिनिकल हिस्ट्री पे वी हैव टेकन दिस?
साउंड नहीं जा रहा है, ले लो माइक ले लो।
So what about the position of the tube? हेलो सर, गुड मॉर्निंग।
यार इसकी आवाज बढ़ाना यहाँ के स्पीकर की।
दोनों हाँ।
ये इधर ले लो आप।
हेलो
हेलो जस्ट वी आर सेटिंग द स्पीकर्स। इसको इधर कर दे। हेलो
हेलो
यस प्लीज।
यस सर, वेरी गुड मॉर्निंग। उद्धव दिस साइड।
हाँ उद्धव, डॉक्टर।
Yes sir. Sir, what about the position of the tube?
Position of the patient is like we do routine tonsillectomy. That is the same position.
And the tube position, the tube.
Pardon?
The tube.
Tube position is central.
Okay.
Tube is in the center. You can focus the patient, cameraman. Hmm? इसको on. हाँ, इसको on कर। और on कर। हाँ देखो यहाँ से निकालो। क्या ना नेक्स्ट केस का है? हाँ प्रेस का।
Sir, have you used any shoulder bag or anything?
Pardon?
Sir, have you used any shoulder bag?
Oral pack. Yes, we will do. We will be doing throat pack.
Sir, shoulder bag, like
Okay,
behind.
okay. मेरे को ना ड्रेप कौन सा है, कट शीट कौन सी है और दूसरी कौन सी है? टॉवल है, टॉवल। हेलो 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 कैमरामैन। Are you having the picture of the patient?
Yeah, we are having pictures here.
So this is the endotracheal tube which is in centrally placed.
Right.
Okay.
Okay. देखते हैं। हाँ। You keep the eyes open, sir.
Eyes are open basically.
Like we don't need to cover them.
Oh yeah. You used to cover this. There is some leakage है थोड़ी। Uncuffed tube है ना? Hello.
Hello, yes, sir. Hello, yes, sir.
Now I am getting you. So we are going to pack the patient. The throat pack will be there, and I will show you this in under microscope, the tonsillectomy part.
Okay.
So I will be using Coblation EVEC 70 band.
Okay. Yeah, can you show us the band?
Yeah, I will show you everything. Just a minute.
So any special settings for the section or any special section you have got for the coagulation?
No, this is high power suction basically.
Okay.
You can use routine suction also. It is there is some learning curve there. Are you having the picture of the microscope?
Yes, sir, we are getting. Slightly blurred, but we are getting it.
Okay, I will set you for that.
A bit of zoom out, sir. Yes, better.
Yes, sir, better.
Okay.
Yes.
Back काटा था.
Sir, they are almost like kissing tonsil, grade 4.
हाँ, it's grade 4 tonsil. So just packing a small pack is there. इसको on कर. How is the picture?
Excellent.
So we are using Leica microscope and we'll be using 0-degree endoscope from Smith and Nephew.
Okay.
Cable तो नहीं
Sir, kindly focus the picture a little bit more.
Okay, okay. I will do that. Just let me know when it's okay for you. It's okay now?
Sir, it can be done even better, I think.
Okay.
So you routinely
Yes.
do with a microscope, Paul.
Essentially, we are seeing the posterior wall more clear than the tonsil.
Okay. Now
Yes, sir, much better. Yes, sir, now.
it's okay.
Yes,
You
yes,
can
sir.
see the
Now we can see
vascularity of the tonsil also.
Yes, sir, now it's good.
You prefer doing tonsillectomy under microscope always, or today just for demonstration?
This is more for demonstration purposes,
Okay.
but routinely we can do with simple headlight. So I am also decongesting the nose with cotton pledgets. उसको नहीं करना अभी चेंज नहीं करना हाँ Hello audience.
Hello? Yes, sir.
This is the coagulation band EVX 70 with 3 electrodes.
You want to
Okay.
centralize the image, sir? Half image is coming,
we are-
like we're not getting the good image. The probe is also not seen. Now we are better.
Okay,
But
okay.
I think you need to like zoom out, sir, if it is possible.
Zoom out. I can do that.
Not be there.
Yeah,
Yes.
actually, we can focus more on the tonsil part.
This is better, yes, better.
Okay. Now it's okay.
Yes.
So
You have given any pre-medication or you are going with the local you have not given?
no.
Not
Local is
required.
not required.
Okay, sir.
So I have just increased
Sir,
one step.
sir, please focus on the tonsil.
Okay. Now it's okay.
Sir, you are going for the right side first?
Yeah.
Yes, sir.
Okay.
Yes, okay.
Right is okay then.
Right is okay, sir. It's fine.
So this is the normal setting is 7.3 for this coagulation EVX 70 van. उसकी ना वॉल्यूम कम कर दो coagulate और इसको इसका सर बढ़ाओ, चलो आगे। Can you focus this? So can you see this is the just I'm checking the one.
Yes.
So after checking, just holding the tonsil as usual, as we do in conventional surgery, pulling out medially.
Okay.
You can see some folliculars, these are visible because it is a magnified picture.
Yes, sir.
So we can start at any point. We can start from the upper pole, the lower pole, or at mid region. Picture is clear?
Yes, sir. Yes, sir.
Picture is very good. Sir, you protect the mucosa over the tonsils for better healing and
Mucosa over the tonsil.
yes, sir. In dissection method, we protect
It is
the
already
maximum.
no, it is already protected. See, this is having the thermal injury is very low,
Yes.
so the healing is quite fast. I'm just marking the incision line like this.
Okay, sir.
Sir, we, by coagulation mode or ablation mode, you use it.
This is ablation mode.
So the teach about the using the probe, touching or distance from mucosa or direct touch the mucosa. Or
No, we are not touching the mucosa. It is around maybe 1 millimeter away from the mucosa. It is the plasma which is doing the job.
okay.
See, I'm not touching the mucosa. Can you appreciate that?
Yes,
Yes,
sir.
yes.
Sir, the whole technology behind coagulation is when you are touching it, it will automatically go into the coagulation mode, and when you are just near to it, it will ablate.
Okay. So you create
So-
that tonsil
Yeah.
plane.
nice, sir.
This is the plane.
Dissection plane.
Yeah, this is the dissection plane.
Very nice, sir.
Again, we can hold it a bit more and medially. So this is the plane you can see. Is this clear?
Yes, sir.
Yes,
Very
very
clear.
Okay. Now you can see the plane and the tonsillar fossa.
So very lovely technique. Minimum charring we are seeing.
There is no need to touch any tissue over here.
Yes, sir. Yes, sir.
So bond head should be upwards.
This has to be medially.
Okay.
You can re-hold the tonsil again just to pull it medially.
Wonderful, sir.
See, there is no bleeding.
So that's what I'm seeing. No bleeding, and even no charring. So your dissection method is too good.
And this is the routine section which we are using.
Yes.
We have to be cautious here at the lower pole. And the beauty of the microscope, using microscope, is that we can remove the lower pole quite easily and without bleeding.
Sir, can you focus on the lower pole with the
Yeah, I will do.
and sir, if possible, you can zoom out a bit so that we can see the whole concept.
Yeah.
Yes, sir.
Is it visible?
Yes, sir.
Yes, sir.
Yes, sir. Now it's very
Now,
Yes.
better, sir. Better. It's okay.
so So that's why we are calling it a bloodless technology. See, you can see the vessel here.
Yes, sir. Yes.
Yeah.
Yes.
So we have to be away from this vessel. See,
Yes. Yes.
okay, this is the lower pole.
Whirlpool.
See. So again, we holding the tonsil again. Keep the vent away from the uvula
Yes.
because many times it comes in your suction code. So this is the posterior pillar.
Yes.
Is it clear?
Yes, sir. Yes.
So I'm through.
Wonderful, sir. Beautiful.
Very nicely, sir.
Very nice, sir. One of
No
the
need
finest.
to tie any vessels or
No, no.
any, nothing.
Sir, one of the finest population tonsillectomy I have seen.
Beautiful dissection, sir.
So no,
Thank you.
No gauze piece, nothing required.
Nothing required.
so it's a piece of art.
Yeah. Piece of technology.
Peace of mind.
Peace of mind. Yeah. After surgery at least. So what I'm doing now, I'm going to the left tonsil. Okay.
Yes.
I will try to demonstrate this with my left hand.
Okay.
Using coagulation well with my left hand because it is more comfortable.
So people used to tell it is extracapsular, intracapsular. What is that concept?
No, this, no, there is nothing. Big
Why
deal.
people confuse it?
No, there is no need of confusion. Be simple. ये थोड़ा सा तार इधर करना ये
Sir,
ये बेटा तार इसके नीचे करना बस okay. So now I am holding my. Can you position my?
so we are getting it. It's,
Okay. Now am I holding my tonsil, holding forcep here with my right hand and my wand is in the left hand. Again the same, pulling out medially.
Shift the PIP to other side, please.
उनको बोलना यार.
yes, sir. Yes, sir.
So picture is good.
Yes.
Yes. So you can zoom out a bit. We are actually not getting the whole tonsil in the view.
Okay. अब आ रहा है?
Yes, yes.
So again the same incision line over here with the wand itself. So this is the left tonsil with my left hand. Re-holding the tonsil again, pull it medially. Is it clear?
Yes, sir. Yes.
Now in sleep apnea patients, what we are doing when we are doing palatoplasties, specifically expansion sphincter periodoplasty. We are removing the tonsil, the similar procedure
Yes.
with coagulation. Hello, Udbhav?
Yes, sir. Yes, sir.
Okay, okay. So, during expansion sphincter palatoplasties, we have to pull out the palatopharyngeus muscle from the tonsillar bed.
Okay.
Okay.
Wonderful, sir. You have seriously mastered the technology. It's not about the technology, it's about the how you handle it.
Framing the,
See, there is so many controversies, like we are having varia and posterior tympanoid, it is same with the other technologies
Yes,
also.
sir.
That is the technique, this is the technology. So, it's not the technique or technology, we have to learn everything.
Yes. So the person behind the tool. What's the most important?
Man behind the machine, that is important.
Yes.
Man behind the technique, that is important.
Yes. So there are long-term debate going on about the post-op bleeding and pain we get more in coagulation tonsillectomy. What's your opinion on that?
Again, there is a myth over here. See, we have done so many tonsillectomies. The post-op events, they are similar.
Yes.
And rather the technology you can see, there is no blood at all. The
Yes.
blood, there is no ooze at all.
It's like even no charring. So the chances of fibrosis and all those things are minimal.
Yeah.
if there is bleeding, what will you opt, coagulation or you
Yeah,
take the
but
backward?
then we will use coagulation part.
Okay.
So just to demonstrate, I will do for you now I am using coagulation. Okay.
Yes.
So this is the normal tissue. See,
Yes.
for coagulation, many times you have to touch the tissue to coagulate.
Okay.
But in ablation, there is no need to touch the tissue. The plasma is doing the job. So picture is clear?
Yes, sir. Very
Very
clear.
nice.
Wonderful, sir.
Now I am shifting to my endoscopes and the position is same.
Okay.
Okay. My position will remain the same as for tonsil. I am using 0-degree telescope.
Good morning, Khanna boss.
Good morning, Ji.
Why you want to keep the same position? Why not just remove the
See,
sandbag for adenoids?
Why not using?
Why not just remove the shoulder extension for the adenoids?
Just I will tell you. See, there are 3 ways to do adenoidectomy with coagulation. Just a minute, let me put a catheter over here. We are putting a infant feeding tube just to pull out the pellet
Yes.
outward. You can see the infant feeding tube.
Yes, sir. Yes.
This is small. So I am tying this. Picture is clear?
Yes,
No.
sir.
Let me
So you can focus.
zoom
on that.
out.
Yes.
Yeah.
It's clear.
So this is the picture. It's clear?
Yes, sir. Yes.
Okay. So I am tying this to pull out the pellet.
It will allow you to get even more space.
Yeah.
Quite freely.
See, this is great for adenoid. So we have to be cautious. And for doing adenoidectomy, we have to bend a bit this coagulation band. Are you seeing this?
Yes, sir.
So you have to hold it like this with the 2 thumbs and the index finger here opposite to the thumb. You can bend it like this.
The same
Very
one.
light pressure.
The same one.
The same one.
So only the setting you will change now.
Now the setting will be 9-4. You can see the curvature.
Yes, we can see it.
Okay. No चार कर देना. कर दिया. So I am switching to this endoscopic picture now.
Khanna boss, you are using the same wand for adenoid.
Yeah.
So what recently I've seen is that this wand EVAC 70 goes off very, soon when we are dealing with grade 4 adenoids. So it hardly lasts one case. So what's your take on using Precise Max in adenoids?
So it's your choice, basically, how comfortable you are. Press P. Okay, chalo.
So you will do it standing on the head side of the patient?
Yeah, I'm standing. Usually my position is sitting, but today I am standing for the first time.
Like any particular reason?
No specific reason. So I am putting my scope into the nose. You can see the hypertrophy of the inferior turbinate also.
What we can see is that you are also standing on the head side of the patient.
Yeah. So this is
it you feel that this is difficult for you?
No, this is not difficult. Let me
standing on the head side.
No.
Because generally we stand on the, facing the patient.
Yeah.
When
Now I will be using, इसको नीचे कर दे टेबल को जरा. इसकी ऑन कर दो उधर ऑन है नीचे करो. Now let me show you the normal position. Okay, बिल्कुल नीचे कर दो, इसको ऊपर करना. Okay, now I'm sitting.
Yes.
Yeah, done. So there are three ways to do adenectomy with coagulation. This is the one way. The another way is we can use 0 degree and then we can use 70 degree for through the oral cavity.
Khanna boss, in your practice, how much cases your wand lasts generally for adenoids?
You can say we can do 2 surgeries if you are having some expertise.
In your hands, you are the most expert person, so I would say.
Two. So you can see the wand here. Hello.
Yes, sir, we can see it.
See, this is the adenoid. Picture is clear?
Yes, sir, we are
Picture is clear, so you have to tell us what to start, where to start.
Yeah. Everything I will show. See, you can see the posterior part of the septum here. Saline डालना ऊपर से. I will show you the normal anatomy first.
And you don't need a accessory section.
No, not at all. See, my trolley, एक मिनट trolley दिखाना यार मेरी. See, my trolley is having only 3 instruments.
That is amazing.
Okay.
Can you see?
Yes,
Yeah.
sir, yes.
Just 3 instruments, one
Holding.
simple,
Yeah.
one tonsil holding, one forceps,
Right.
and other is this technology.
So brush is to clean the tip of the wand.
Yeah. In case there is a. So you can see the hypertrophy of the inferior turbinate also, which I am touching. Okay.
Yes.
So what we can do at the same time, we can do turbinate reduction also, the posterior part of the turbinate. See,
Coagulation.
with the coagulation,
The coagulation. Okay.
not coagulation, it will bleed. With the coagulation mode, and just to create more space over here. Can you appreciate?
Yes, sir.
Can you appreciate?
Yes.
This is the posterior part of the septum. Okay. This is the posterior part of the septum. This is also slightly edematous. So we can coagulate here also. Can you see?
Yes.
In the posterior part, you are also having some lymphoid tissue. So many times you have to see, you have to decongest this also, just to avoid bleeding. So this is just to demonstrate. So this is the inferior part, the posterior part of the inferior turbinate. So I am coagulating this and creating more space for me for visualization.
So, I think to orient this, the picture is upside down, no?
No, it is not upside down. It's perfect. So this is the position. You can see the throat pack over here.
Yes, yes, but boss, because you have put the scope from, you are sitting at the back of the patient.
Head of the,
Yeah,
at
to the inferior part, we are seeing in the superior part of the picture. So,
see, this is,
so inferiorly at 6 o'clock is the roof and at 12 o'clock is the floor of the nose.
yeah, this is the 12 o'clock. For me, it is the 12 o'clock position where the wand is. Hello?
Yes, sir. Yes.
This is the 12 o'clock. This is 6. This is 9. Okay?
Sir, we are getting it here in the reverse direction, but it's okay. It's fine.
Huh?
Okay, sir. It's fine.
Is there any confusion over here?
No, it's perfect. You can start, sir.
Okay. So you can see the eustachian tube orifice here. The
Yes.
bubbles are coming out,
Right.
right? So this is the lateral end of the adenoid.
Okay.
This is the tubal torus. This is the inferior part of the eustachian tube opening.
Good morning, sir.
Good morning.
Sir, one question, sir.
Yeah.
Will you consider that complete turbinate reduction or turbinoplasty in such case, which have?
No. Just I'm coagulating it just to reduce it. This is turbinate reduction from the posterior part. See, whenever there is obstruction, usually the turbinates get hypertrophied.
Okay. So in such a large turbinate, sir,
You can see the adenoids from the nasopharynx into the nasal cavity also. Can you appreciate this?
yes.
So I will be starting from 6 o'clock position. This is the coagulation mode. Picture is clear?
So you start from the roof of the nasopharynx first.
Yeah, roof of the nasopharynx.
So generally, we start at the floor so that the blood
See,
doesn't trickle down. So
Yeah. See, again, there is methodology can be different, technique can be different, result has to be the same. Can you appreciate?
yes.
This was the दस मिनट हाँ कर दो नहीं सुनो इधर ही लगे Can you see the plasma over here?
Yes, very clear.
So what we have to do in adenoidectomy with coagulation and endoscopic coagulation adenoidectomy, we will go till the perimarcium, periosteum of the nasopharynx.
Okay.
And you have to be away from the tubal torus also.
Right. So you will expose the periosteum here in the roof and
till the periosteum
in the nasopharynx.
So now picture is more clear. We have more space now. This part of the adenoid has been removed, which was entering into the nasal cavity from posterior part. Okay.
Yes.
So my movement is horizontal like this, or it can be vertical like this. Okay,
Okay.
from 12 to 6, 6 to 12, or 3 to 9. So this is 3 to 9. See, I am using the same EVEX 71
Yeah.
with 9-4 setting.
Boss, what if when many a times this torus tuberous is also very edematous?
Yeah, I will come to that. What I will be doing after completing this, I will just brush this area
Okay.
so that there is some fibrosis and there is eversion of the eustachian tube, this tubal torus area.
Okay.
Okay. So this will come medially slightly because of the fibrosis, and this
Just to
will
reduce
open up.
fibrosis here.
Yeah, yeah. This will open up the eustachian tube orifice. See, again, my concept is again slightly different. For so many years, I haven't done grommet incision if there is adenoid hypertrophy. Just doing adenoidectomy with coagulation, we are opening up the eustachian tube orifice, and within few months, the patient is fine with no ear symptoms.
Okay. So any,
Picture is clear?
yeah, picture is
So
absolutely clear.
I am approaching the periosteum over here.
So any difference when you do use this coblation in children and in adults when doing adenoid?
No, there is no difference. The procedure is same. See how much space has been created now. So this is the other part, the right side. I'm going from the left side. This is the left side. This is the right side. You can see the yellowish area over here. This is the periosteum. And I am feeling the bone of the nasopharynx. This is the bone.
Dr. Sanjay, Dr. Surinder here.
Is sir?
Yeah, yeah.
Good morning.
You were mentioning grommet. That was for type B or type C, you leave it.
Pardon, sir?
You don't put grommet for type C or type B impedance patients.
In both the cases, sir.
Both the cases.
Hmm.
That's good, I think. Patient can be without any tube and all those problems, swimming and all those things can be settled. That's a good thing.
Good morning, Dr. Sanjay. Good morning, Dr. Preetham Arora. Sir,
By coagulating the medial surface of the torus, have you ever come across a patulous eustachian tube?
no, never. I will show you. I will just brush with in the coagulation mode like this. See, just this much. Can you appreciate this? Hello.
हाँ जी.
So I'll just brush it out so that it gets everted.
And that's only in case of hypertrophied or edematous torus.
You can do in every case. So this is the inferior part. From me, it is for me it is the inferior part, the 12 o'clock position.
So there is no need to hold it, retract it, just keep on doing it there.
Yeah. Till now, my endoscope is in place and it's stable, bilkul. It's not moving in out.
Sir, during ablation near the perimysium or periosteum, we can injure the periosteum or ablate this, and
we will do coagulation mode when we are. This is the passive and ridge area.
okay.
So when I will reach here, I will switch on to coagulation mode
Okay.
and will not touch the perimysium over here, the muscle, the passive and ridge area. You can see the yellowish tinge over here.
Yes.
So this is the periosteum. This is the upper limit. This is my lateral limit of adenoidectomy. So with endoscopic coagulation adenoidectomy, we can remove nearly 90 to 95% of the adenoid tissue. This was the posterior part of the septum. Now I am switching to the right side. Okay.
Sir, in periosteum is a mucosa is yellowish.
40% से ऊपर थी
Yeah.
है ना और इसमें मैं तो पेशेंट को कहता हूँ यार देख बुक्स लिखती हैं 3-4% पर मैंने कभी किसी की रिपीट नहीं करी मैं मतलब मैंने ब्राइडर के साथ ये मेथड स्टार्ट की है
Sometimes we come across with slight DNS over here. So many times it's difficult to use 0° 4 mm scope. So we switch over to 2.7 mm scope. But I will try to negotiate if I can.
Sir, we can use angled scope through mouth or.
Yeah, you can use. So I am switching to 2.7 mm because there is slight DNS over here. See, I have done adenoidectomy in 10-month-old patient also because of obstructive sleep apnea.
इसमें भी तो बहुत डालते हैं हम लोगों ने जब शुरू
So this is you can एक मिनट शोर नहीं बचा यार.
मेरा बेटा उस साइड पे था वो उल्टा ब्लेड यूज करता है मैं ब्लेड यूज करता हूँ जिसकी कटिंग एज पीछे है तो राइट
Can you see the adenoid tissue?
वो यूज करता है जिसका आगे है
Hello.
Hello? Yes,
See the adenoid tissue into the nasal cavity.
yes.
Do you give any steroid or something like that before
I
operation?
think NSS has already given.
Okay.
How much?
What is the age of this patient?
4 mg dexamethasone. यार ये पिक्चर इधर ठीक नहीं आ रही, क्या चक्कर है? उधर ठीक है क्या पिक्चर? हाँ नहीं कौन सी ट्रॉली?
Passenger, what is the age of this patient?
हेलो, एज कितनी है? 4 years. 13 kg, 4 years.
I mean, going by the size of the adenoid, which we could see, was this patient having any middle ear changes?
No, not at all.
Was tympanogram was done?
I'm sorry, मेरे ख्याल नहीं हुआ. But there was no ear complaint as such. And TM was normal.
Okay.
So no need of audiometries.
आपको आना था सर.
So we are pleased to welcome Dr. S.P. Dubey, sir.
Good morning, sir. ये pull करना जरा, catheter pull करना. So I'm slightly asking my assistant to pull out the catheter so that. Slide down. बस. नो 4 पे.
Karna boss, in cases of significant DNS where you cannot negotiate your 0-degree endoscope,
Yeah.
so have you ever used 70-degree endoscope?
Never.
So then how, or 30-degree, 0-degree from the opposite side then?
No. If there is severe DNS,
Yes.
then we have to switch over to 70-degree.
So you,
But
yes.
in kids, usually there is slight DNS or maybe small spur is there. So there is not a problem.
All right.
99% I could negotiate the nasal cavity.
Okay. And what is the minimum age of the child that you have done adenoid?
10 months.
10 months.
See, that's why I'm saying indication has been changed.
Yes.
There is no need to wait according to age. You have to see the patient complaints, the examination part, and apneic spells with sleepless nights.
Your experience with the channeling wand for the inferior turbinate reduction, have you used it?
Pardon?
Check the wand that they have come up for the inferior turbinate reduction only. Turbinoplasty band.
Actually, there is so many people speaking now. I could not hear.
पहले होता था कि जब होना चाहिए अब तो दूर है पड़ता है खराब है तो
So no.
So basically you start dissecting laterally and make them come in the medial.
Yeah. You need some space, no?
Superior and lateral and then the central mass is here.
Yeah.
अरे चलो इम्प्लांट का पेशेंट है आपको भोपाल के लिए
Meanwhile, Dr. Satish can discuss the MRI.
So we are enjoying it.
Okay.
This is also part of learning.
Yeah.
Right.
सलाइन पुश करना और नहीं उधर से करना सलाइन देना सुरिंदर So this is the adenoid tissue which was left earlier. You can show the MRI. हाँ बस हो गया मेरा. Okay. लैपटॉप में ही है सारा. So this is the area of fossa of Rosenmuller. Okay. So this is the inferior most part of the adenoid. If at all there is slight bleeding, we can switch over to coagulation mode, and I will brush again this part. You can see there is a broken electrode over here.
Yes.
So just brushing the again tubal torus area. Okay. यार वैंड चेंज करना पड़ेगा. See again, this whole band is finished, nearly finished because of the grade 4 adenoid hypertrophy and more for this demonstration purposes. Usually we can do 1.5 to 2 cases in one. So this is the passive and ridge area. So I will just coagulate this part.
Okay.
This is my lower limit.
Sir, your experience with the bridle in case of adenoidectomy, have you used it?
I can't hear you, doctor.
Hello?
He is asking your experience with debrider in the adenoid.
Dr. Satish will show you tomorrow.
Okay. Actually, now Miss, after seeing the debrider, the coagulator, the Benwell, so those so many techniques being involved by people. So many people use debrider followed by coagulator. Many people use only coagulator. Many people use only debrider. So that is a.
So it's up to you.
You have your comfort.
It's up to you what you want to do, what you are comfortable with.
This much of adenoid you leave inside.
So this is not adenoid.
This much of the tissue.
This is not the adenoid tissue. Sir. This is the muscle, passive and ridge. I am just creating some fibrosis over here later on. Just brushing the mucosa over this. See, there is no bleeding at all.
Yes, yes. Ultimate.
I am through now.
Superb, superb.
Very nice, sir.
You can see the picture. This is again.
So what is the earliest age, minimum age you recommend we go for adenoid or tonsils?
It's again the complaint of the patient, the disturbance in sleep, the desaturation part. If the child is older, more than 6 years, then we can do sleep study also.
And in tonsillar diffuse grade 4 tonsillar hypertrophy with adenoid, have you gone for unilateral tonsillectomy to give the air passage or with adenoidectomy?
I'm not getting you. Actually, your mic is quite closer to it, so there is.
Hello, now it's okay?
Hello?
Now it's okay?
Now it's okay.
Okay. Suppose in Miss obstructive apnea and sleep disorder in children or adult, if you have diffuse huge tonsils or kissing tonsils with or without adenoid, so to relieve the obstruction, would you recommend to go for unilateral tonsil in children?
No place of unilateral tonsillectomy in obstructive cases.
Can you show the passive switch from the oral cavity? How much
Yeah,
you
if
left?
I will be using the 70-degree, I can show you. So this is the oral cavity.
It seems that it was very much elevated.
See, this is the oral cavity and this is the palatopharyngeal muscle.
Okay,
Yes, yes.
okay.
Which is used for palatoplasties in sleep apnea patients. So what we are doing in sleep apnea, this whole muscle is pulled out, dissected out partly, and the thick part of the muscle is, this is the incision line, the 2/3 portion. See, this whole is 100%. Up from this is the area where this is 2/3 portion. This is the incision line. We cut the palatopharyngeal muscle here. We pull out and pull out to here, so that there is a space created over here. Okay.
Okay.
So this is the palatopharyngeal muscle. We make a tunnel over here in the palate, soft palate. We pull out, stitch this muscle over here. Hello.
Yes, sir, yes.
It will be very nice to watch this.
So this will create more space in the nasopharynx and the oropharynx area whenever there is lateral collapse or circumferential collapse.
If the time permits, do show us any video of yours.
Yeah. Okay. Now there is no bleeding, no need of keeping the pack over here.
Can you stitch anterior and
You
posterior
can-
pillar both?
You can
To
see,
increase, widen the space there in place of pulling the muscle through the tunnel.
okay? 70.
Yeah. Means for means to get more space, do you stitch both the pillars?
आपकी आवाज क्रैक हो रही है, आप माइक थोड़ा दूर रखें प्लीज.
माइक हल्का कर. So means to get more space, you stitch both the pillars of the tonsils.
No need of stitching because only the upper pole is stitched. While doing palatoplasties, especially the expansion sphincter palatoplasty, ESP, what we are doing is we are pulling out the palatopharyngeus and stitching to the making a tunnel and stitching to the soft palate, that area. After removing the supratonsillar pad of fat, we are stitching that muscle over the under the mucosa of the peritonsillar fat area.
Other OT is ready?
Yeah, other road is ready.
Sir,
Okay.
Sanjay,
Yeah,
sir, you doing evacuate the torus tuberous by brushing by coagulation method.
yeah.
You this technique can use another indication of eustachian tube dysfunctions or in allergic rhinitis patients or other.
Yeah, this can be used if there is indication over there.
Ever you
No, I haven't used this.
okay.
Good. Superb case. Superb demonstration. Dr. Sanjay.
बेटे गाउन देना उनको.
Can you go to other OT?
हाँ निकाल दिया. उधर केस स्टार्ट कर देगा.
क्या नाम बताया था आपने उनका?
Hello? Other OT?
Hello.
Yes, Sanjay.
Yeah.
So are we ready?
Yeah, next case is ready. Dr. Satish will show you the MRI of the next case.
Okay.
She is a lady of 40 years of age
Okay.
having chronic rhinosinusitis and bilateral nasal polyposis is there. So Dr. Satish will show you the MRI scans.
Hand over the mic.
Yeah.
ये इधर है यार, केस इधर ही है. अच्छा कंफर्म. ठीक है. तो वहीं जाएगा. ये है मास्क.
So
बस ले रहे हैं, आप
OT2.
rest करो, ले रहे हैं आपको. हेलो.
Yes.
sir.
Dr. Satish, where are you?
कॉलर माइक वो ले गया.
शाम को ही ये हाँ हाँ जी हेलो यस यस
Hello?
we can see the slide
Okay.
hello Dr. Satish
Good morning, boss. Good morning, everybody.
Hello, sir. Good morning.
So what a fantastic start of the day.
yes ultimate case done by Dr. Sanjay Khanna.
So, our next case is going to be a case of bilateral sinonasal polyposis. Are you getting any MR?
Yeah, we're getting the MR picture CT picture.
Okay, so we have CT scans on DICOM. This is 1.3 mm sections. And as we always discuss, we need to have a complete three-dimensional information of the area we are operating. And that is given best by a fine section CT scan on DICOM, where we can see the dynamic imaging and 3D imaging. We can correlate the CT in every anatomy, every required anatomy in all three planes. You can see here. We can reconstruct. Any single thing you want to see, you can see. See, yesterday we saw the pterygoid process. See the pterygoid process. What happened to the pterygoid process here? Just for example, this is the pterygopalatine fossa. See this. Or let me show you. Yeah. In the axial section. Can you see the pterygopalatine fossa on both sides?
Yes.
Right.
The medial part of the this medial part is the pterygopalatine fossa and the lateral one is the infratemporal fossa. We have seen yesterday in detail
Yes.
in the cadaveric dissection. And behind the pterygopalatine fossa is the what? Pterygoid process.
Yes.
See the pterygoid process on this side?
Yes.
And pterygoid process, this side pterygoid process is mimetized. See this?
Yes.
Right.
Mimetized pterygoid process is known as lateral recess of the sphenoid sinus.
Beautiful.
Okay.
Yes.
Okay.
So this side pterygoid process is mimetized, which is considered as a lateral recess of the sphenoid. The right side sphenoid is a bigger one. The left side is a smaller one, but the left pterygoid is mimetized and known as lateral recess of the sphenoid. Is that clear?
Yes, sir. Very clear.
Yesterday, to extrapolate the anatomy, I'll come to the relevant CT for this patient after this. Yesterday we saw from the pterygopalatine fossa lot of anatomy we explored. From the pterygopalatine fossa behind this canal is going. Can you see this?
Yes, sir.
Yes.
This is median canal.
We can get.
From the medial end of the pterygopalatine fossa, this canal is going median canal. And what is this? This is carotid artery behind. This is the horizontal petrous carotid which becomes, this is horizontal petrous carotid which becomes foramen lacerum carotid over here. So this median canal opens at the level of the foramen lacerum. Can you see?
Yes, sir. Yes, sir.
That's the level of the foramen lacerum. And that is the sphenoid sinus proper then. So we need to know all this anatomy from skull-based perspective. That's the pterygopalatine fossa again. This is pterygoid bone, this is maxillary bone, this is pterygomaxillary fissure.
Yes.
Which leads to infratemporal fossa from the pterygopalatine fossa. Any anatomy endoscopically we discussed yesterday, want to see on CT scan, we can discuss, this is the right time for that. We have 10 minutes for the next case to be induced. So this is the right time.
So I think Dr. Satish, Dr. Dubey here.
Yes, sir.
So in place of asking for CT plate, now you always recommend DICOM image along with CT.
Yes,
so that
sir.
we can have a panoramic understanding of the CT scan.
Dynamic view and three-dimensional.
So please elaborate for knowledge of us that how we order the CT scan
Yes,
and
sir.
what we should say our radiologist to give us.
Very, very relevant question. Come from the master. Dubey sir, first of all, welcome.
Thank you, sir.
आपके मेरा quorum पूरा नहीं होता है.
Yesterday I have seen your all dissection through my computer. Even today also during my journey, I was searching for you.
Thank you.
Now I find you.
So your question is valid. What kind of CT we should order? We should order fine sections, 0.5 mm axial sections. That's it. And we need to have a DICOM to reconstruct into all planes. So this CT was shot in axial plane only, both bone and soft tissue windows.
Right.
So you can have complete anatomical details of the bone and soft tissue in the area you are going to operate. And now, with your DICOM, you can reconstruct into all planes. This data can be preserved for future reference. You can see dynamically which printouts cannot show you. With the number of slices in bone and soft tissue in axial, coronal, sagittal, to carry for a patient is impossible. And that too for a surgeon to see them on printouts, all those printouts is impossible.
Right.
So the best is to order on DICOM because we cannot see dynamic, otherwise I mean, we can miss a lot of things. Like I had shown you all these anatomy, this median now going to the foramen lacerum, this and that. This cannot be seen on printouts so easily. Secondly, there are certain anatomy which is visible best on axial. Certain details are given best on axial, certain on sagittal like frontal sinus and skull base, and mostly on coronal from sinus surgery point of view. So we need to have a complete 3D information. Secondly, this kind of CT scan gives you, our junior colleagues, a great opportunity to understand CT scan three-dimensionally. Any anatomy seen on axial, coronal or sagittal, you can correlate in all planes. Like for example, I showed you, this is lateral recess. You can see lateral recess in all planes, where the lateral recess is going to be.
Yes.
See, this is, we saw yesterday Greater Palatine Canal. See this?
Right.
That's the Greater Palatine Canal going to the palate. That's the Greater Palatine Canal emerging from the pterygopalatine fossa medial part and going there. So all this anatomy you can very well appreciate. This is supraorbital cell.
Right.
See this? See the cell about the orbit, supraorbital cell, and you can see this posterior anatomy to the frontal sinus. So every possible anatomy you can explore in all three planes. This cellular sphenoid relationship is best seen on sagittal plane, the level of the sella, the sphenoid sinus. The frontal sinus, most important view for the frontal sinus is the sagittal one, to give you picture in the right plane you need, and secondly, it gives you, to understand the opportunity how to access the frontal sinus in difficult situations. And you see, I will show you during surgery as well. See, when we come from this side, we are coming from this side to address the frontal sinus, the biggest obstacle is this beak. Can you see?
Yes, yes.
So the beak is a very, very important landmark. And you can use this as a landmark also to identify the frontal opening. See, I am coming from here, follow the beak, where the beak ends has to be frontal.
Right.
It cannot be anything else.
Yesterday you were shown in cadaver very well.
Yeah, so it is a fixed landmark. Even in the multiple revision surgeries, generally the beak is not disturbed. And you can utilize it as one of the best landmarks to enter into the frontal. So frontal is a bony cavity. See, all around bone is a frontal bone which is pneumatized and drained through the frontal recess. And this recess, see, this frontal sinus is bounded anteriorly by this frontal bone.
Yes.
Floor by this frontal bone and the beak. And where the beak ends in the frontal sinus, opening, drainage.
Right.
So this drainage, if you come from anterior to posterior, this is the posterior most part. So frontal sinus drains from the posterior most region. See, I am coming, see in the coronal section, this is the frontal bone, beginning of the frontal sinus. This is the nasal bone, going behind, this is the beak. See, this was the nasal bone, this is beak. This is beak. Now, if I go further behind, where the beak ends, the frontal drainage starts.
Right. at the posterior part.
So frontal sinus drainage is from the posterior most part of the frontal sinus, then the anterior roof starts. Now, as we go behind, the cribriform plate starts that demarcates the anterior roof. And as we go behind, see still the cribriform plate. At the posterior most part of the cribriform plate, that is the beaking of the orbit. At the posterior most part of the cribriform, the anterior artery leaves the orbit. And where the anterior artery leaves the orbit and you go behind, then the posterior starts.
Right.
So, see this, the level of the anterior artery here. That's the level of the anterior artery. See in the sagittal plane, where the anterior artery level is. So, when we work for the frontal sinus from here, when we work for the frontal sinus in this direction, our anterior artery is miles away. You don't need to bother and frighten from the anterior artery from the beginning. The artery is far behind at the level of the skull base from the frontal sinus. So once you work with the frontal with a 70-degree, your artery is automatically far behind.
And if you are following an intact bulla technique, then definitely you are not going to hurt it.
Yes. So the advantage of the intact bulla is see here in the sagittal, this is the bulla.
Right.
This is the bulla going to the skull base. So as long as you stay anterior to the bulla, your artery is always protected. So once you remove the lamina of the bulla, then you will be able to see the artery in the skull base. I will show you during surgery as well.
So please tell how to
fix anatomy which we need to exploit.
So also tell how to identify supraorbital cell and frontal bullary cell in CT scan. Hello?
Hello?
Sir, am I audible?
Not really, sir.
Hello?
Volume bada.
Hello?
Yes, sir, now.
Sir, how to identify supraorbital cell and frontal bullary cell in CT scan?
Supraorbital cell and bular cell.
Yes, sir. Frontal bullary.
Supraorbital, I have already shown you. Let me tell you. See, this is bulla ethmoidalis. The cell anterior and above the bulla is the suprabular cell. That is the suprabular cell. See here on the sagittal.
Yes.
Supraorbital, let me show you in all planes. First go in the, see this is frontal sinus.
Yes.
So beak is there means you are in the proper sinus so far. Now as you go behind, the beak has gone, it is the sinus drainage system now. There is no more frontal sinus now, it is the frontal drainage pathway now. And all this pneumatization above the orbit, can you see this?
Yes, yes.
Yes. After the frontal sinus is over, we are far behind now. See in the sagittal, the frontal is over here.
Yes.
We are far behind, and this pneumatization going above the orbit is the supraorbital pneumatization. See this in all planes.
Yes.
So that is when the beak has gone. When the beak has gone and you have gone far behind. How you can additionally, have an idea about this? See, this is anteriorly the frontal sinus and the beak in place. And this is too anterior so that our maxillary sinus are not in view.
Yes.
Right. Now I am going behind. See, the beak has gone. Beak has gone. Maxillary sinus have started appearing. Imagine the level on the coronal scan when you see the maxillary sinus. When maxillary sinuses are visible, you don't see the frontal sinus. Whatever you look like frontal sinus is actually a structure behind the frontal sinus, that is supraorbital pneumatization.
Yes, sir.
So there are many ways to see that. And once you see the supraorbital pneumatization, go behind. See, this is the cribriform plate in place. That means anterior throat is there. See supraorbital pneumatization.
Yes.
See this. Until the supraorbital pneumatization. See now. Now the supraorbital pneumatization ends and is the level of the anterior artery.
Yes, sir. Very nice.
See now, how far behind the anterior artery?
Yes.
So whenever you see the supraorbital cell, the anterior artery is always behind, caudal to it.
Okay.
more the supraorbital cell is pneumatized. See, this anterethmoidal artery runs through the thickness of the anterior skull base. Anterior skull base, anterethmoidal skull base is usually already thin. So most of the time this artery traversing through the thickness of the anterethmoidal skull base, it is visible as a prominent structure. Now, if the anterethmoidal skull base is more pneumatized because of the supraorbital pneumatization or any other region, this artery becomes more prominent. So more the anterethmoidal skull base is pneumatized, more the supraorbital cell is pneumatized, you are more having chances of anterethmoidal artery into the mesentery,
Yes, sir.
becoming more prominent. So all these structures are interrelated. So once you are working in the frontal, that's what I am going to show you. See this, I am going to show you the frontal sinus work immediately anteriorly. Will come with the 70 degree from here, follow the beak, where the beak ends will be in the frontal. While working this, imagine the anterethmoidal artery is miles away. You don't need to think of it.
Yes.
That is far, far behind, and that too right at the level of the skull base. See the level of the skull base?
Yes.
The anterethmoidal artery traverses through the skull base. You don't need to frighten yourself unnecessarily all the time for the anterethmoidal artery.
And sir, please also explain how to differentiate between the posterior ethmoidal cell and the sphenoid sinus.
Okay, let me go behind. That's a very good question. See now, let me first tell you, this is cribriform plate.
Yes.
Now, I'm going behind, the cribriform is over.
Yes.
See the posterior skull base, thick posterior skull base. Let me show you on here. Can you see the thick posterior skull base?
Yes.
See here earlier was the cribriform. When I am going behind, that is the thick posterior skull base. Clear?
Yes.
Now, as you go behind, see the orbit is narrowing. And this roof of the ethmoids is formed by frontal bone. That's how the top cells of the ethmoid are open from above, and that is roofed by the frontal bone and known as fovea. They give impression. Fovea means impression. They give impression on the frontal bone above. So this ethmoidal roof, maybe whatever ethmoid, the ethmoidal roof is formed by frontal bone all the way. You see this frontal bone from pterion to pterion. Now, as you go behind, when the sphenoid sinus comes, sphenoid is what? Sphenoid sinus is what? Pneumatization of the sphenoid bone.
Yes.
And sphenoid bone is a complex bone having two wings, the lesser wing and the greater wing below. So you saw the greater wing below yesterday forming the floor of the temporal lobe. I had shown in dissection.
Yes.
Now see, I am going behind. As long as this roof from pterion to pterion is formed by the frontal bone, it is postethmoid. Whatever sinuses here are postethmoids. The moment this roof of the frontal sinus goes off from pterion to pterion, the sphenoid starts. Let's see. See this? I am going behind.
Yes.
Behind. Can you see the roof is going?
Yes. Yes. Yes.
Now see where the roof is. There is no more roof laterally. This is the temporal lobe of the brain, and this is the middle cranial fossa. And see, this roof in the center is formed by the lesser wing of the sphenoid. So whatever pneumatization below is the sphenoid sinus.
Perfect.
Let me come back. See now, until now, see the complete bone from lateral to lateral.
Yes.
This is frontal bone and this is postethmoid. As I go behind, now the frontal bone is disappeared. See the changes. See the broadening of the septum here.
Yes.
Forming the rostrum.
Yes.
Rostrum is forming the anterior wall at the level of the anterior wall. See the orbital apex reducing. See the rostrum. That is the sphenoid sinus, beginning of the sphenoid sinus. Now, as you go behind, see the sphenoid sinus proper and the lesser wing of the sphenoid forming the roof. And as you go behind, see the sphenoid sinus, the orbital apex, that's the level of the pterygopalatine fossa on either side. Pterygopalatine fossa, inferior orbital fissure on either side. The sphenoid, body of the sphenoid pneumatizing into two sinuses. And as you go behind now see the pterygoid plates coming into place.
Yes.
On either side, the pterygoid process is coming into place.
Yes.
And now see the nasal septum is gone. It is not extending from top to bottom.
Yes. Wonderful, sir. Sir, any tips for identifying ONOD cell on CT scan?
Hello? Sure?
Hello?
Hello?
Yeah, we can hear.
Yes, boss.
Hello?
And how to identify the ONOD cells?
ONOD.
Yes.
See, ONOD is what? One of the post-it model cell grows behind and above the sphenoid sinus. Grows behind and above the sphenoid sinus and beyond the anterior wall of the sphenoid behind. Yes, boss. Hello?
Sir, am I audible?
Yes, yes.
Yes. So your question was regarding the ONOD cell. See, I am going behind to the posterior and show you the sagittal part. ONOD can be viewed in any plane. See, this is sphenoid sinus.
Yes.
This is the anterior wall of the sphenoid sinus. Now, any posterior cell growing beyond the anterior wall of the sphenoid sinus is ONOD cell. And how it will appear in the coronal sections? See, this is posterior.
Yes.
This is sphenoid, pure sphenoid.
Yes.
Had there been any ONOD cell entering into the sphenoid, this sphenoid would have a transport septa, the upper cell being the ONOD, the lower cell, the sphenoid being pushed inferior-medially.
Wonderful.
If you see in the horizontal septa and the sphenoid, that means the upper cell is continuation of the posterior, which has pushed the sphenoid inferior-medially, and in that situation, the optic nerve comes to lie in the wall of the ONOD rather than the sphenoid sinus.
Yes.
Is that clear?
Yes, sir. Very much clear.
This particular patient has as far as the positive, anatomical findings are concerned, has a reasonable size frontal sinuses, not very big. Frontal recesses, hardly any pneumatization. Has complete white out, picture of the sinusitis. Complete white out, bilateral pansinusitis with a lateral recess of the sphenoid on the left side.
Yes.
See this?
Yes.
That's a lateral recess, which is at the expense of pneumatization of the pterygoid process.
Sir, is there any role of CT scan in angio-DCR surgery? Like, should we
In the
angio-DCR, while doing angio-DCR surgery, is there any role for CT scan?
CT scan, rules out any other diagnosis, any mucocele, any other abnormality. As far as the diagnosis is concerned, it hardly has any role.
So sometimes this lateral versus pterygoid mimetization can also be diseased. So you'll approach it through the sphenoid sinus.
Yes. See this, madam. See where the lateral recess is. This is lateral recess.
Good morning, Satish boss.
Yes.
Satish boss, these days you are getting MRI for paranasal sinuses surgeries.
Yeah.
So can you tell us the advantages why instead of CT you are getting MRI
See,
for paranasal
MRI
sinuses?
has its indications. For inflammatory disease of the paranasal sinuses, generally you don't need MRI unless you have a doubt on diagnosis, unless you have a doubt on having some sort of tumor, unless you want to confirm about the fungal disease, or you want to rule out anything else, or the disease is extending beyond the confines of paranasal sinuses, intracranially, intraorbitally, anywhere beyond the confines of paranasal. Unless then the CT is good enough, otherwise the MRI is indicated. So MRI has its indication. MRI has versatility of giving number of different sequences. Every sequence has a value and identifies certain particular thing. You can easily differentiate between soft tissue masses. See, here you can see only opacity on CT scan.
Yes.
Whether it is a fluid, whether it is a fungus, whether it is a mucosa, whatever it is, you cannot differentiate. MRI can exactly differentiate if it is a fluid. If it is a mucous fluid or it is a pyocele, MRI can differentiate by means of different protein content. If it is a fungus, MRI can differentiate whether it is a fungus or not. Whether it's a regular sinusitis or a fungal sinusitis, MRI can differentiate.
Yes.
So MRI has a value in terms of differentiating into soft tissue masses. For a pure inflammatory disease of the paranasal sinuses, generally you don't need, MRI unless I have told you the indications.
Okay, boss.
Satish sir,
Yes, sir.
is there is any role of navigation system in sinus surgery? Because a lot of big institutions are buying navigation system.
Yes. See, navigation systems have the value in improving anatomical localization. What do any navigation system generally do? The CT scan is registered with a navigation system and the patient head, and wherever you point out a navigated instrument, that will exactly tell you CT scan where exactly you are working.
So we'll have
Now-
real-time CT.
Yeah, so it improves your localization, and now with the more sophisticated navigation systems have come in, the accuracy is within 1 millimeter. So it is more important when you are working close to critical structures. So in the present scenario, if you are experienced for a regular sinus surgery, generally you don't need navigation. It is not, something about the anatomical details of the surgeon, but it helps in orienting in difficult situations, like in unusual anatomy, unusual cellularity, and in a revision situation when the anatomy is distorted.
Right.
In tumors or disease close to the critical structures like carotid artery, optic nerve, dura, orbit, and you really want to know where exactly you are working to improve your localization and avoiding complications. If you have a tumor or something, you are removing close to the carotid artery and you want to know exactly how far you are from the carotid to protect that, you can use the navigation system.
Right.
So navigation system has a role in improving your localization in difficult situation, not in every case. Yes, in revision and more extensive cases where the disease has gone beyond the confines, navigation definitely has a value.
So you have a neuro navigation system at your place. How often you use this navigation system?
Me, once in 3 months
Months in 3 months. Okay.
on an average. I've been using for
But
almost.
you are getting lot of revision cases according to our information.
These are straightforward cases, you don't need navigation. But you see, it depends upon the surgical experience as well.
Right.
But I am not against it, and this is a good teaching tool in the institutions.
Right. Right.
See, if your resident is working using the navigation system, you can monitor
Yes, yes.
all the time where exactly is working.
Valid
You
point.
can ask him to point out where exactly you are working and you can see on monitor.
Right, sir.
So he adds on to the safety when you are, teaching.
Right. Thank you, sir.
So we're discussing the drainage of this sinus. So we'll do by sphenoid sinus route only.
Pardon?
So this sphenoid recess drainage we'll do by exposing the sphenoid sinus only.
Yes. So this is basically, this is basically a inflammatory disease of the sphenoid sinus.
Okay.
What we need to do in this entire surgery is to remove this inflammatory load and establish the ventilation and drainage and wide opening for future, introduction of topical steroids. This is not a tumor, this is not a CSF leak, this is not something else.
Right.
So in this case, you don't need to reach out that area.
Okay.
Just through the natural ostium, you widen the sphenoid wall, suck out the disease, or if it is a polyp, you can debride whatever and establish a good patency for future steroids to go inside.
Okay. Okay. Thank you.
Had this been a CSF leak, which is not uncommon from the lateral recess of the sphenoid sinus, in that scenario, you need a head-on approach. And what you can do, we had seen yesterday, there's a medial pterygoid plate.
Yes.
That's the sphenoid wall. You can remove this sphenoid wall and part of the pterygoid plate.
Okay.
And open head-on. Once you open head-on the lateral recess, you can close the CSF leak like a child's play. See, in CSF leak, wherever you are dealing with, the important thing is the exposure. If you get the exposure, the method of sealing is same. So in lateral recess leaks, you need a transpterygoid approach to deal with the lateral area.
Okay.
So our case is induced probably, and in a couple of minutes we are going to start. You can continue your questions during surgery also. Feel free to interrupt me anytime.
Sir, morning, sir. Hello,
Hello.
Satish, sir.
Yes.
I have a small doubt. Hello. Hello.
Hello. Hello.
Satish, sir. Kumar Raja here. Good morning.
Hello. Yes, sir.
Sir, good morning, sir.
Yes. Can you raise your volume, please?
Sir, सुनाई दे रहा है सर अभी?
Hello.
Hello.
Yes.
अभी सुनाई दे रहा है सर?
Yeah. You're audible now.
Yes,
Please.
sir. Sir, एक बात पूछनी के when you are operating, can you just point out the transpterygoid where all you are going to do that while operating? Just show me the.
Okay.
Next
Okay.
one.
How to go by the transpterygoid approach?
Yes, sir. Yes, sir. Second thing I wanted to ask you is if there is a thick tenacious fungus in the lateral recess, can we use hydrogen peroxide to wash it out?
Opposite side.
No, no. Tenacious fungus is there in the lateral recess.
Yeah,
Can we use hydrogen peroxide to wash it out?
not really. Hydrogen peroxide is something not to melt the fungus. You can use the hydrodebrider,
Okay.
which is a jet. You can rotate 360 degree
Okay.
and you can flush it out.
Okay. Okay. Just wanted to ask.
By and large, for
Sir.
sinus surgery, we must have a high power suction,
Yes, sir.
like a liposuction,
Yes, sir.
to enhance your visualization,
Sir.
to prevent the repeated clogging of the suction.
Sir.
At the same time, to improve the, durability of the microdebrider motor.
Yes, sir. Thank you.
Hello. Hello.
Yes, sir.
Dr. Satish.
विनय डॉक्टर सतीश को माइक लगाओ.
Hello.
एक मिनट सर, एक मिनट.
वही पूछ रहा हूँ. हाँ. हेलो. 10 मिनट. हेलो।
सेंटर के यूटी यूटी के अंदर यूटी के जो है जैसे पंजाब है की जो पॉलिटिशियंस हैं या जो ब्यूरोक्रेट्स हैं उनकी तो इंटर है पॉलिटिकल आपके
नहीं, हमारे इसमें ऊपर ही है कि जैसे आप देखते ना हो ना तो सीधे सबसे को फोन कर
मतलब वो जो न्यूसेंस
और वैसे नहीं कि मेरे को तो ये सर्विस करवाना है या मुझे करवा दो बस तो करना है सर्विस करना है ऐसा कुछ नहीं पर वो न्यूसेंस है ऐसे यूज करती है ना यूज करती है आज और हुआ है तो हमारे घर में लोग एक थ्रू कर सेम ऑफिस है या बनाने का दुकान है बर्गर हाउस है
हर जगह हमारे
जब हमारा काम है
तब कहते सेशन कोर्स सेशन कोर्स है ना सेशन कोर्स है फिर जब आउट ऑफ टर्म के दो तीन दिन पहले से बच्चा का लड़का था 20 साल का acute tonsillitis था difficulty in swallowing pain everything fever मैंने एडमिट कर लिया एक टेबल पे और पे डाल दिया रात तक तो उसकी मदद हो गई रात की होगी अगले दिन सुबह में पता नहीं फोन आ गया उसका सुबह सुबह 8 बजे कहते जी इसकी फटाफट डिसास्टर बना दो हमने इसको लेके जाना दिल्ली लेके जाना पता नहीं कौन ले आया और उसकी मदद कल कह रही थी कि हमने किसी ने ट्रीटमेंट कर रहे थे 3 4 दिन नहीं फर्क पड़ रहा था तो किसी ने रिकमेंड किया क्या वहां ले तो बंदा ना जी आपने उसने सवेरे सवेरे कर दिया हंगामा कर दिया 8 बजे हम भी घर थे हमारा पहले मैं हॉस्पिटल ऊपर रहता था हम लोग वहां नहीं रहते तो कैसे डिस्चार्ज मैंने अपने बंदे से बोला मेरी बात कर कहता है पहले तो मेरे बेटे से बात करी कैसे डिस्चार्ज मैंने कहता है हम लोग 10 बजे आए क्या जी आप क्या इसकी फाइल जो है वो बेडरूम में लेके सोते मैं कहता हूँ मैं आपको ना बंदे की शक्ल दिखाता हूँ फोटो दिखाता हूँ मैंने ना अपने बंदे से पूछा मैं कहा यार बंदा कौन है कहते जी है तो वो बड़ा पोलाइटली बोल रहा पर मैं कहता जी मेरे पास उसकी मैं कहा यार उसका तो नंबर पता करो क्या जी उसकी फोटो है ये उसकी फोटो 12 तो सुनना पाया मैंने मैं कहता हूँ जैसे बॉक्सर बाउंसर और एक बार तो और यूपी का एक बंदा उसके बेटे को सेटल है आ गया उसको मैंने एडवाइस किया कि उसे जीए में ट्रेनिंग करनी पड़ेगी कर दो काफी कर लो तो कहता है कि रात में यहाँ पे आके आता होता तो इतनी लंबी वो रखी वो गन कंबल के नीचे सर्दियों की वजह से इतनी लंबी गन डॉक्टर साहब हमें आराम से रहने को यहाँ पर आपने जो करना टेक्निकली
Hello, hello. The way was missing the कुछ technical problems are there for the transmission. In the meantime, we can discuss some. I think I have some videos over here. Okay, 1 second. Okay, we have some something different for. आ रहा नहीं आ रहा इस पे स्क्रीन पे कहाँ आ रहा है? No, not. In the meantime, we can have some good video discussions and there are so many presentations. I think we can some do's and don'ts in ENT. These are the video presentation and so it is a like a filler. We can for any intervention we can use this. So just surgical like we do so many surgeries per day and per week per month, and we have some ifs and buts, and sometimes we so like we go wrong on a long track. So each surgery has innumerable steps. Each steps have different many variations, and many variations have different modifications also. So that is our job, that we have to modify ourselves, we have to correct ourselves, we have to learn from the mistakes from our colleagues. So just aim of the presentation is to share the pros and cons at every level. Where would we do every surgery we do some wrong steps, we do some new steps. So we should learn from them, and few of them like I think these are these where we can avoid the thing like never play with your patients after seeing these such videos, because after seeing the videos, never try and do the surgeries on a patient, because at least like this case, you saw them in the morning, wonderful tonsils by Dr. Sanjay, and it doesn't come with the video, it comes with the experience, your surgical experiences. So just learn not through the video, but through your colleagues, your seniors, surgical skill, and then follow them, then do your mistakes, and then incorporate on your patients. So regarding we take the patient for the operation theater and we do some pre-operative preparation. But few things we have a protocol in our operation theater that we should do all these tests. But few more things I would like to share is that there are so many things we keep on our pre-op OT list. A few more are there that keep your OT, your atmosphere in a very light mood. Whatever way you like, you want to music, you want to play, talk with the staff, and you keep a very healthy atmosphere in your operation theater, because where you never know at what level you have to have a stress over there. So people ask your patient. That is, I think, this it is the very important point. Whether you're doing the case under local anesthesia or general anesthesia, ask the patient to go for the urination before, because it is one of the common cause of getting high BP during the surgery, whether patient is under local. If during surgery he has a reflex, then he or she will be in trouble. Even during GA, it is one of the commonest cause of high BP during surgery. And before starting any case, don't keep anything pending. Well, after 1 hour, I have to do this thing. Never ask your staff that how many patients are waiting in operation, for your OPD, because otherwise you will try to go fast. You will try to do things beyond your skill. So I think better not to keep these things in mind. Let's start with a few basic things like we do our ear surgery, nasal surgery. Nasal nowadays we are not putting any local anesthesia over there, but in ear case like stapes or like even perimeter triplasty, the main step is, especially in stapes case, main point is just how to give the local anesthesia. Start. Okay. So that's 1 second. स्टार्ट हो गया ना. So whenever needed, we'll come in between.
Hello.
अगर ज्यादा अगर आपको ज्यादा अर्जेंट है तो ओके अभी फिलहाल के लिए आप इसको वर्किंग दे सकते हैं फिलहाल, अगर आप ओके चलो मैं पूछ लेता हूँ अगर डॉक्टर आपके पास है तो वो एक बार एटलीस्ट कर दे नहीं तो थर्ड फ्लोर पे आई थिंक चलता रहता है तो मैं पूछता हूँ ठीक है अपना
इसी को लगा दो। जब स्टार्ट हो बता दो ना, नहीं स्टार्ट हो इनको बता दो। So best part is just you should have a single prick local anesthesia. Never try to poke the canal, otherwise you will get so many blood spots and oozing. That oozing may persist for later on, and that can be cause of infection around, especially in stapes. Especially in stapes, you have to take care of this thing. Never try to play with the canal. Just try to give a local 26 gauge needle local anesthesia, and that will make the. So second part is that sterilization of any surgery, like whether you are doing endoscopic surgery, whether you even because we used to say that in ear surgery you need a sterilization, but even in septoplasty or face or whatever you're doing, nasal cavity use, you have to go for proper sterilization. And here you have to be very particular, especially if you're doing plant or any process material like this. It is a real video, and this is my OT. Just see what wrong. And I took this picture because before starting case, my staff does everything, and I have a window in my theater, Dr. Dubey, and that was a real recording I did. Just see what mistake my staff is doing. Just see. It was real recording. In spite of whether your staff is 20 years with you, since 10 years, hello staff. Yes, Satish.
Hello. Hi, Dr. Satish. Wait.
Oh,
Hello.
able to hear you, Noti?
वो तो चलता रहेगा मैं
Hello.
Yes, sir.
Dr. Satish.
Hello, Dr. Satish, sir.
Image has
Hello,
come.
auditorium.
actually. Image has come.
Hello.
Hello, image has come, sir. We are getting the image.
Hello.
The audio.
Yes, Satish boss, you are audible.
Hello. इधर का वॉल्यूम बढ़ा दो.
Hello.
Are we audible in the theater?
Yes, sir. Yes. Hello.
Hello.
Yes, sir.
Dr. Satish. Hello.
Speaker. Hello. Hello. Wait a minute, sir. Wait a minute. Yes, sir.
Hello.
Hello, Dr. Satish.
Yes, sir. Yes.
Good morning. Hello.
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 Yes, sir.
Dr. Satish.
Yes.
Good morning, Dr. Surendra here.
Yes. Good morning, sir.
Good morning, boss.
How are you?
Good to hear from you.
Yeah.
So are you getting any?
Yeah, we are getting the image.
Okay. So what we have discussed until now is the CT findings, anatomical details of this particular patient.
Yes, sir.
We have seen 10 polyposis, we have seen bilateral disease, we have seen lateral recess on one side, and now is the surgical part. And for this we need lot of preparation. We all know this is surgery of landmarks.
Definitely.
And you know, in order to identify the landmarks, the thing which is most important is to have a good surgical field. And in order to achieve the surgical field, generally our preparation starts days or even weeks before surgery. This is inflammatory disease, we all know. See what I'm doing, I'm preparing intraoperatively with some adrenaline sponges soaked in this marrow cell. So pre-operative preparation is directed to reduce the inflammation by means of steroids. If there is secondary infection by means of adding on antibiotics and so on. So idea is to reduce the inflammation, reduce the mucosal edema and so the overall bleeding. So that is pre-operative preparation. See this, even a single application of Marocel has squeezed the polyp.
Yes, sir.
Can you see?
Yes.
Very right. It has opened up the nasal cavity. It has decongested the mucosa and see what I am doing. My Marocel is the carrier which is soaked in adrenaline, saline adrenaline, and I am applying all over on the mucosa.
Yes.
This adrenaline applied, a single application of adrenaline on the mucosa results in mucosal decongestion and it prevents further systemic absorption. So topical application is pretty safe.
So what is your pre-op
Topical
criteria?
application is pretty safe
Yes.
without the need of infiltration.
Yes.
Infiltration is something we have stopped years before to prevent systemic dissemination of adrenaline and further systemic complications, cardiac complication and so on of the adrenaline, particularly in mobile patients. This being an inflammatory disease, we can't take such chances of cardiac and other complications by systemic dissemination of adrenaline.
Sir, Dr. Satish, how about keeping the pack for some time in the nasal cavity?
Hello?
How about keeping the packs?
We can't hear you.
Hello? Hello?
Boss, आवाज नहीं आ रही इधर यार, उनकी.
Hello.
Yes, boss.
Hanji sir, sir, one question. Sir, I also do the same thing, apply this Marocel around all the mucosa.
Yeah.
Many a times anesthetists always tell ki BP is shooting upward.
That's what I'm telling you. That's what I was mentioning. We are using topical. A single topical application decongests the mucosa to prevent systemic absorption. So the topical application itself is protecting from systemic absorption of adrenaline, and see the systemic parameters in this case are unchanged. And here, regarding the intraoperative preparation, what I'm doing, in sinus surgery, the majority of the bleeding is from capillaries, and what we need, a surface capillary decongestion.
Yes.
This is not true arterial bleeding like JNA case we show, wherein we need hypotensive anesthesia, this, that, all those things. Here we don't need, we need capillary decongestion, we need reduced cardiac output, and here I am indebted to our anesthetist for giving us a reduced cardiac output by means of reduced pulse rate. Overall pulse rate is around 60, which has given us or going to give us a best field from anesthesia side. So there are a lot of things we expect from anesthesiologists to give us reduced cardiac output, to prevent vasodilatation. Of course, hypotensive anesthesia is something we no longer want. Nowadays, we operate under normotensive conditions, and this is not arterial bleeding, number one, and why to take a chance of, complications of hypertension in this benign condition. So normotensive, reduced cardiac output by means of reduced heart rate, topical decongestion, pre-operative preparation by means of steroid and all, gives us or takes us achieving a good surgical field. Yes.
So in the polyposis patient, what's your like the pre-op preparation? Like how many days of antibiotics, oral steroid, anything before surgery?
Yes. So pre-operative preparation is important. Now regarding the how much, many times it is not practical, but yes, if you are preparing your case thoroughly, you should give at least 7 to 10 days of steroids in a polyposis case. In a non-polypoidal case, yes, of course, antibiotics. In polyposis case, antibiotics are not warranted unless there is associated secondary infection.
Okay.
So pre-operative preparation is of immense value,
yes,
along with the intraoperative preparation.
So you use steroids in the tapering dose or the same dose continuously?
Tapering dose, we use plain prednisolone, starting 1 milligram per kg, then tapering after 3 days to half a milligram, then tapering further like this until the patient is posted. Sometimes, I told you why it is not practical sometimes for patients coming from long distances. Plan for surgery you can't keep for waiting, waiting for long, and you have to emphasize on other ways of reducing the inflammation or bleeding rather than keeping the patient waiting for long. So many times that is not practical, but by and large, your intraoperative preparation, a thorough intraoperative preparation gives you, good surgical field.
So what about serum IgE and eosinophil count? These things matter in the surgery, like the post-op management?
Yes, matters a lot. See, this inflammatory disease of the paranasal sinuses, we have understood a lot about it, and now there are lots of, phenotypes and endotypes of this disease. Each endotype having a different ongoing pathophysiological process. Like non-polypoidal disease is a different phenotype, different endotype, which is mostly eosinophil dominated disease, and steroids have hardly any value, and in those antibiotics have more value, and antibiotics particularly targeting the neutrophils, working as immunomodulators, the macrolides have huge value. In all non-polypoidal sinusitis, we must give a course of macrolides at least for 3 to 4 months,
yes,
in low doses to modulate the immunity, to modulate the course of disease, and many times you can, avoid the need of surgery.
Yes.
But yes, in polypoidal disease, there is no value of, macrolides. That's a eosinophil dominated disease. And in that eosinophilic dominated disease, in the entire cascade of pathophysiology, the only thing which works is the steroid. So this is my 5 to 10 minutes of topical preparation. And now moving on to the surgical part. And you see there are a lot of polyps occupying the nasal cavity. So the first is the luminal work. This is the Medtronic blade.
How about keeping the packs for 10 minutes of these decongestant?
It's not.
Will that help endoscopically put pack?
Yeah, which I have done.
Yeah.
See, this packing, there is a way of packing the nasal cavity for the optimum field. It's not that you pack it tightly. If you pack tightly, it is more counterproductive in terms of giving venous congestion. So we are not supposed to pack tightly, number one. Secondly, we are not supposed to pack for longer duration. Whatever our aim is to apply adrenaline, that's it, to the surface. If you keep the pack for 30 seconds and keep for 5 minutes, the effect is going to be same. So there is no point in keeping the pack for longer period.
Sir, how much concentration of adrenaline you are using?
Depends. In younger patient, we don't mind using even a pure 1:1000 because we are using only for topical use.
Okay.
In elderly, yes, particularly in, cardiovascular labile patients, you have to, dilute the concentration to prevent, systemic dissemination and systemic side effects. And mostly in those patients, we use 1:4 combination for topical use. No infiltration at all in any case.
Okay, sir.
See, multiple polyps have, distorted anatomy. Now, can you see something coming in the picture?
Yes.
That is middle turbinate. And see the important thing, lot of disease medial to the middle turbinate.
Yes.
Yes, sir.
You have to be very careful. See this. Above is the olfactory mucosa. Be conservative in removal of these polyps by means of not damaging the
Olfactory
mucosa. Yes. Because whatever these polyps, even if you stay conservative and push your topical steroid later on, which is the goal of our surgery, these can be taken very effectively without unnecessarily, damaging the olfactory mucosa and giving olfactory loss. So you have to be little conservative in the olfactory region. See, leave that, remove whatever surface you can debride and avoid fibrosis. If you give fibrosis, you'll end up giving probably a permanent olfactory loss. Because most of the time, this olfactory loss is conductive. What I mean to say, this olfactory loss is of two types by and large. Conductive and sensory neural. Conductive means your polyps blocking the air reaching the olfactory receptors. That is conductive olfactory loss. The moment you remove the polyps or allowing the air to access the olfactory region, then your olfaction reverts back to normal. Majority of the time it happens like that. But if you give lot of fibrosis by means of debriding in that region, you end up damaging the olfactory mucosa and that can be a permanent olfaction loss.
What debrider you are using and what are the tricks to be applied here?
Pardon?
Debrider, any tips for debrider use or what type of debrider you have to use?
Yeah, so this was the luminal component I was doing. So I was using the straight blade and keeping the blade in view so as to avoid the trauma to the surrounding. And see, I have given a small trauma on the middle, on the surrounding surface on the turbinate here on the septum, little bit. So I will coagulate it immediately. So always whenever you use debrider or coagulator, whatever, keep the blade, tip of the blade in view all the time.
What is the blood pressure, Dr. Satish?
Blood pressure is around 128/93.
And pulse rate?
Pulse rate, just now it has increased, but it was around 60-65. It is in 80s now, but probably it will settle down.
For you, pulse rate is important or blood pressure is important?
More is the pulse rate. The blood pressure is important in the sense, it's not that you are going to operate in hypertensive conditions. Obviously, then the overall bleeding will be more.
For the surgical field, you are concerned with pulse rate between 70 to 80.
Around 60, around 60.
Around 60, okay.
Now see, there is one thing which we always mention. In case of disease medial to the middle turbinate, it results in lot of issues. Lot of issues means, number one, it results in a floppy turbinate once you have a lot of disease medial to the middle turbinate. Makes your turbinate medialized and ultimately it becomes floppy. And a floppy turbinate needs to be managed by various ways. In the morning I was discussing with Madam Srivastav, a floppy turbinate can be managed by various ways. Most of the time, either you do a bulgarization or you do a suturing at the inferior edge. At the inferior edge to keep the middle meatus open like this. But see, our policy, when you have a massive disease in the olfactory region, we don't do, or rather we do a partial resection to allow the solution to reach freely to the olfactory region. So there we do intentional, partial resection to give free access to the topicals reaching the olfactory region. Got my point?
Yes, sir.
So in cases where there is a floppy turbinate with a disease medial to the middle turbinate in the olfactory recess, olfactory region, it is better to do a partial resection. Partial resection means a partial resection, not complete chopping of the turbinate. Because this turbinate is a useful landmark throughout the surgery.
So you will remove the lower third of the middle turbinate means.
Lower third is even more, but not the superior part which has which can have a probable, olfactory mucosa also medially. And secondly, it acts as a good landmark as well. See this floppy turbinate, it is falling laterally. Can you see it?
Yes, yes, it's falling back.
So if you don't do anything to it, what can happen?
It will
This is going to block the olfactory cavity and defeat the entire purpose of this surgery. Because our purpose of this surgery now is many pronged. In the sense, it is not that we all know this is a steroid dependent disease. The entire, the steroid works at the entire cascade of the pathophysiology of this disease. So the only weapon we have in the present context to deal with this disease is steroid. Now we can't give oral steroid. Topical steroid, looking at the profile of the disease, looking at the number of polyps, the sinuses blocked, the topicals are not penetrating unless you open up the sinuses. That's my point?
Yeah.
So the sinus surgery, number one role of the sinus surgery is to remove the inflammatory load. Number one. Number two, to open up the ventilation and drainage, to establish the ventilation and drainage of the sinuses for their health. And number three, to give avenue for the topicals to reach in the depth of the sinuses. So that is the third goal, and that is one of the most important goals now. So that since we have only weapon in the present context to deal with this disease, the steroid. In that situation, when the topicals reach freely into the depth of the sinuses where the disease is, where the mucosa is diseased, you don't need to give oral, and these topicals are pretty safe with hardly any systemic side effects in long run. So that is the whole goal of surgery in the entire, context.
Satish sir.
Can you see the picture? How is the picture overall?
Yeah, picture is good.
Very good, sir.
Yes, hello?
Satish sir.
It's very good, sir. Picture is very clear.
Hello, Satish sir.
Yes, sir.
Sir.
Yes, please.
Yes, sir. I just wanted to ask you, can you, you
Yes.
said that macrolides are no more useful in cases of eosinophilic and polyposis.
Yes, macrolides are not used because their main work is on the neutrophilic receptors.
Yes, sir. So, can you just state, I remember you telling that doxycycline being used for polyposis cases.
Yes.
Can you
So
just,
doxycycline is used for polypoidal disease, not as an antibiotic.
yes, sir.
See, in polypoidal disease, cascade of sinusitis, eosinophilic, there are a lot of, receptors where the doxycycline works, particularly the matrix metalloproteinase 9,
Okay.
which is an important part in the cascade of, polypoidal sinusitis. And this doxycycline is used as an immunomodulator to block the matrix metalloproteinase to give, inviting the eosinophil to the area.
So,
So doxycycline is never used as an antibiotic.
Yes, sir.
Immunomodulators. Similarly, macrolides are never used like antibiotics. They are
Yes,
used as immunomodulators.
So for how long we can give doxycycline?
So generally it is given for 3 weeks.
Okay.
See, if your inflammatory load is not so much and can be contained with doxycycline, saline wash and topical steroids, all are pretty safe. You don't need surgery. But if your load is too much serious, not getting control with all these conservative measures, then you have to reduce the inflammatory load by means of surgery. See this?
Yes.
Yes, sir.
Before going anywhere, now I am taking this, part of the floppy turbinate to give me good access to the olfactory and overall middle meatus.
So you use only prednisolone, don't use newer steroid like diflucicort or methylprednisolone?
For?
You use only prednisolone, not using diflucicort, these modern steroids?
Yeah, for the oral use.
Oral use, yes.
Yeah, mostly prednisolone. See, all steroids have their own potency. They have relative potency. Like methylprednisolone is relatively more potent than prednisolone, and diflucicort is relatively less potent in terms of dosing. So accordingly, you need to escalate the dose, and you can use. So all are steroids, all have same glucocorticoid activity. So by and large, they all are same. You have to adjust the doses according to the, potency.
Okay.
Satish, sir. Sir,
Yes.
can you show us in one of your cases, how do you reconstruct an axilla at a higher state? I mean, like how you have done in the last.
Reconstruct what?
Axilla of the middle turbinate, you elevate it to a higher state, no, sir, in order to make the steroids penetrate it better.
Yes. So reconstruct.
No, you actually not reconstruct. You take it to a higher level so that the.
Yes. So that the penetration to the frontal is improved.
Yes, sir.
I will show you.
Okay.
That is the concept of known as 0-degree visualization of the frontal sinus.
Yes, sir. Yes.
I will show that. That is good. We appreciate that. See now, I partially resected the middle turbinate to open up the olfactory region. See that?
Yes.
Had there not been any polyps medial to the middle turbinate, I would never resect it. I would rather bulgarize inferiorly or suture it. Once there are polyps, not to take chance, because now I want post-operatively my steroid to reach freely to the olfactory region. See that?
Yes.
See, every time keep improving your field. To minimize the complication, since this is a surgery of landmarks, every point of time you need to identify your further landmarks.
Sir, what about this high DNS which is obscuring the?
Yes, if it is really obscuring,
Yes, sir.
you must correct it. If you want to know how to correct, like yesterday I had shown you, I can show you today as well. With a
Sir,
conservative limited septoplasty.
So you can go for that also.
Okay, you want me to show that?
Yes, yes. Yes, sir.
And it is always a good approach. You know what happens? Intraoperatively, after decongestion, you feel like you have adequate space. And you can negotiate your instrument through whatever space you have created after decongestion. But instrumentation to the narrow spaces invites injury to the opposing surfaces and ultimately may invite synechia. So on the slightest doubt of, high deviation, narrow space, you can always, improve. You can either see this high deviation, I can reduce in a minute. See this?
Yes, yes.
If you want me, okay.
But I think your neurocell use is also causing very less trauma to the mucosa.
Yes. So it gives me a good decongested feel. So I can tell you, I can show you this high deviation since you have asked how it can be easily improved.
Yes.
See this? My incision to the opposite side. I have not infiltrated anything for that matter.
Yes. So why it is not bleeding in your hand? Satish bhai,
It's not my hand. We have to follow the protocols.
no, everybody is asking this only. That is bleeds in our hand. Why is it is not bleeding in your hand? It's a Hirosil Pocha which has done all the miracle or something else.
Yeah, so Maricel as a role, our anesthesiologist have the credit to give me this good field. See, this was a case where the septoplasty was done earlier.
Right.
I can see you have to be more careful now. Because you don't have, you can't expect that good surgical planes. Yes, but see this, I got the plane.
Yes.
And see, this is the high deviation. See, such things when it comes to your mind to correct, you must correct. See this high deviation?
Yes.
Yes.
I will correct it and that's it. It doesn't take time, hardly any bleeding, no side effects. You must do it to improvise. It helps you, your achieving your goal by means of introducing the post-operatively the topical steroid in the cavity. So this?
Yes.
Yes, sir. नहीं वहाँ समझ वही है reason.
That's it. Yesterday I had shown you a limited septoplasty in a different way. Today also in a different way. See now?
Yes,
Yes.
yes, sir.
No more high deviation now. So this. Hello?
Yes, sir. Yes,
Yes.
So you can, terminate septal deviation. All these are ancillary procedures required in almost every sinus surgery.
So ultimate goal is to reach the penetration of the
Topical wash. So you have to do everything. You have to make sure that the topical is reaching effectively. See now, with this high deviation correction, now see the field.
Yes, sir.
Yes.
Yes, sir.
Dramatic improvement. The goal is you can see your patient in your office in the post-operatively with a 0 degree, with all sinuses, and you can train your patient, for the topical steroid wash, and now it will penetrate like anything. See that?
Yes, sir. Very beautiful.
So all these inferior turbinate, middle turbinate, septum, and other things required to be corrected, we must go for that. So now coming to the sinus surgery per se. Now see, yesterday in the cadaver we had seen a lot of landmarks, the inferior turbinate, inferior meatus. In sinus disease, the most important area we are concerned with the middle meatus. See, it is all distorted. Can you see?
Yes.
Yes, sir.
It is all distorted because of the polyps itself. See, it's because of the polyp itself.
So how to identify uncinate at this moment?
Mobility. I always mention.
It is the only structure which
This is mobile in the lateral nasal wall.
Yes, yes.
the studies cadavers.
See this, the polyp?
Yes.
And see this opening, what is this? This cannot be natural ostium. This is a fontanelle. This is the fontanelle. This cannot be natural ostium. See, this is behind the uncinate. So it is a posterior fontanelle. See this uncinate?
Yes.
Always communicate this fontanelle with the natural ostium. Reason being, your secretions, your sinuses drain through the natural ostium. If you don't communicate with the fontanelle, whatever secretion come out of the sinus can re-enter through the fontanelle, back into the sinus. And our entire purpose is defeated again. So always give a wide opening and communicate these two things together.
Hello, hello.
Dubey sir,
Sir,
your questions are very relevant, most important for the benefit of everybody. Please.
sir, I am also getting benefited by every tricks which you shown and yesterday's dissection was excellent.
कर दूंगा आपकी प्रेजेंस से 4 चांद लगा दिए कर सेक्शन कर
Sometimes this inferior tablet is very high.
Yes,
And we
be
are not-
careful to avoid an orbital entry in that situation. Go just about, see the maxillary sinus mucosa?
Yes.
This is a sort of, you can say,
Cobblestone appearance.
cobblestone appearance mucosa. Don't be aggressive on such mucosa. Never be aggressive. See the goal of this surgery, this is functional endoscopic sinus surgery, wherein the entire function is going to be solved by mucosa.
Yes.
Yes.
If you remove the mucosa, you are defeating the purpose of sinus surgery. Then you are going to invite the fibrosis. That is not going to serve the mucociliary clearance, and the entire purpose is defeated. And then it is not going to be fast, it is going to be total mess.
Mess, right.
So never ever,
And how important is to remove these type of small spicules of bones which you are removing?
yeah, see, these spicules of bone, always use a sharp instrument. Separate the mucosa and pick them, remove. See why cobblatory, this debrider is so important. Because this is a sharp cutting instrument. It cuts the mucosa sharp. It doesn't pull anything. It doesn't demucosalize the area. See my maxillary sinus?
Yes.
A simple middle metal enterostomy. I don't intend to enlarge it much because I don't see any massive disease inside.
Right.
There are grades of maxillary enterostomies in case required. In case required means, had there been a massive disease, fungal or anything requiring a lifelong or long-term surveillance, I would have, created a bigger opening, a mega middle metal enterostomy for the future steroid introduction, future surveillance and all that. This maxillary sinus not having, you can see, not having a massive disease, you don't need to be very, very aggressive in doing anything over there.
So you will leave behind that mucosa, na?
Yeah, this mucosa has to be respected.
Okay.
Now, this is your bulla. See this?
Yes, sir.
And this is your upper part of the uncinate. Can you see?
Yes, sir.
Dr. Satish, if it was a fungal disease, AFRS, would you still preserve the mucosa?
No. That is non-invasive fungus.
AFRS, I am saying.
AFRS is non-invasive fungus. You are not supposed to remove the mucosa. AFRS is allergic fungal rhinosinusitis.
Yes.
That is the patient's reaction to the fungal antigen.
Yes.
That is pure type 1 hypersensitivity antigen antibody reaction. So the mucosa is secreting eosinophilic material in response to the fungal challenge. The mucosa is not invaded by the fungus.
Yeah.
Never ever try to remove the mucosa.
Okay. Sometimes what we have seen is if you don't poke that mucosa which is looking edematous in case of FRS, sometimes the muck is behind that edematous mucosa.
So it's not behind. You know what happens sometimes? In between the mucosal polyps, you can leave the fungal antigen behind. It's not behind the mucosa or invading the mucosa.
Okay.
In that situation, you need to have a thorough wash to ensure that no fungus is left behind. If fungus is left behind, it will behave like an antigen wash. In AFRS, the fungus is antigen.
Yes.
Don't leave the fungus behind. See the value of irrigation, mopping, all that to maintain your surgical field.
So only invasive fungal sinusitis is there, then only you will go for removal of the mucosa and removal of the bone.
Not really, sir.
Not really.
Invasive fungal sinusitis, on the other hand, is a medical disease.
Okay.
The role of surgery is just limited to confirm it by means of taking a biopsy. Suppose this patient is having invasive aspergillosis.
Yes.
I could have known by CT scan also all those distraction, bone destruction. And that kind of bone destruction is different than bone destruction you see in the allergic fungal rhinosinusitis. Then, because the sinuses are not full, even the small disease in the sinus can lead to bone destruction. And then in the invasive disease, you just take a biopsy and come out once it is proven invasive aspergillosis, where voriconazole is the treatment of choice. You don't need to do at all any extensive surgery.
Okay. In like in mucormycosis.
That is acute fulminant.
Okay.
Mucor is acute fulminant disease. Again, that is medical disease. Mucor is again medical disease wherein amphotericin is the treatment of choice. The difference is,
Remove all the dead bones.
yeah, it gives vascular necrosis. Mucor preferentially invades the vessel and gives vascular necrosis. Now, the areas which have developed vascular necrosis, where antifungals are not going to penetrate. So the goal of surgery is MRI based, the contrast MRI. Wherever the contrast is not going, wherever are the dead areas, we have to remove them.
Right.
The antifungals are not going to reach there. And wherever the contrast is going, in spite of being fungus over there, you can leave for the amphotericin.
Yes, yes.
Except the bones. If you have a disease in the bones and enhancing on contrast, you need to remove because the penetration of amphotericin in the bone is very poor.
And there is no role of any antifungal topical irrigation. No role. at all.
Just a feel good, nothing else.
Nothing else. Okay. And what about that ointment which was very much
Yeah,
popular
that's a
there?
feel good.
Feel good. Okay.
See now, this is upper part of the uncinate I am taking off.
Yes, yes.
This is a very, very important step in sinus surgery for all junior colleagues. Moment you remove the upper part of the uncinate, you reach out to your lateral limit of the sinonasal corridor.
Yes.
That is what?
Lamina
Lamina pepracia. So in a minute's time, see this. We have reached the lamina pepracia. See this?
Right.
This is lamina.
Yes, sir.
That is my lateral limit of the sinonasal corridor. That is in so beginning of the surgery.
Yes.
My medial limit is turbinate, which we have defined. My lateral limit is this. See this?
Yes,
My
sir.
bulla is intact.
Yes.
The maxillary sinus is here. This is axilla over there. Now, how to reach out the frontal? Having seen this?
Yes.
Yes, sir.
Through the beak.
Beak. Beak is the landmark, boss. See this. For
It was-
anybody practicing sinus surgery, intent to do sinus surgery, a beak is one of the best landmarks. See this?
Yes.
This is what Dr. Kumar Raja was asking, to clean the beak region thoroughly. See this?
Yes.
I am working far anteriorly. And how can you identify the beak so easily? Beak is the thickest bone in this region. With knowing my lateral and medial limits. See this what I am doing. Knowing my lateral and medial limits, the lateral limit being the lamina there, medial limit being the turbinate,
Excellent.
staying on the beak. See this?
Yes.
You can identify, see this is axilla and see follow this axilla with the beak behind. That is the beak.
Yes.
That is thick beak.
Floor of the frontal
And
sinus.
where the beak ends? Where the beak ends?
Frontal
You enter into the
That is the
frontal.
frontal sinus. See that?
Right.
So easily you can reach out the frontal sinus. Now let me elaborate this. This is the simplest way of reaching out the frontal rather than wandering here and there, rather than terrifying yourself with the frontal being a challenging sinus. You can reach out there easily with a single landmark, and that landmark is so reliable. It is not destroyed even in a multiple revisions because nobody is going to drill away the beak.
Would you like to raise a flap on the lateral side of the attachment or middle turbinate for lining the frontal pieces
Yes.
later
A
on?
lot of people do that,
Yeah.
but see if it is followed by the good irrigation, you don't need to do that.
Okay.
Now, at this point, what I am trying to show is what Dr. Kumar Raja has asked, and this is our, proposition also. See this projected bone
Yes.
at the level of the
Axilla.
axilla, I can remove only the projected bone. And now I will go inside with a 70 degree to show you something, and you are directly onto the frontal sinus. Your all terrifying things, the anterethmoidal artery, skull base, all those things are miles away. They are behind, they are miles away from this most anterior anatomy which I am working at. No, give me 70. So now switching to the 70 degree for regions.
Satish sir, how it is different from the axillary flap technique which was popularized by the Wormhole to identify the frontal very easily?
Yes. So that was initially, popularized by Wormhole. For the regions, not using the 70-degree. That time, people were not using 70-degree, not confident of that. So that is something to get away from using the, I would say, the appropriate.
Sir, can you pinpoint the beak once more?
Yes. See this.
Yes. And by doing this also, we can see the frontal in future and irrigate with 0-degree only.
See the 70-degree, the beauty of 70-degree is
Yes.
you can keep your all landmarks in visualization at one point of time.
Point of time, right.
Means I have my median limit in view. Why terminate at the median limit? If I transgress this median limit and go medial to it, I can easily destroy the cribiform plate and a CSF leak. See the cribiform plate there.
Right.
So I need to keep my median limit. This is my lateral limit, the lamina.
Yes.
If I transgress, I will be right into the orbit immediately. And if I stay in between these two, follow my beak. See, this is the beak.
Yes.
Follow my beak, I will be right into the sinus. That is frontal sinus. See now?
Right, sir.
So simple. Going in between these lateral and medial limits, far anteriorly, I am entering into where?
Frontal sinus.
It cannot be anything else.
Yes.
Lateral one, na? Lateral one.
That is your frontal sinus. So the best way to reach out the frontal sinus safely is the beak. If sometimes you find a projection in the beak, you need to remove that. Articulated.
That you remove with your stylus drill or with Garrison punch only?
Yeah, I have a special articulated punch for that. We'll show you. First of all, look at the frontal sinus.
Yes.
See, I'm working far anterior. That's what I am again and again emphasizing. Once you are working far anteriorly, you are away, miles away from all the critical structures. You can think of damaging. Nothing critical structure coming in, going to come your way. See this?
Yes, very clear.
What is that?
Frontal.
Frontal. So the moment you see your medial and lateral limit, go in between, go anteriorly, just below the beak, it has to be frontal, nothing else. You don't have to apply your brain or anything into it. It is always has to be frontal.
And where is your special punch, sir?
Yeah. Now see.
Very clear.
That is the frontal sinus.
Why?
That's wonderful.
Now, if you want to further widen this with this, beak or something, what a frontal it is, see this frontal. In no time, I didn't take into consideration any other landmark. Now this beak projection I can cut away.
So we can see the polypoidal mucosa inside the frontal sinus as well.
Yes, yes, yes.
This is my
Special punch.
special punch from Karl Stolz. And see, you know what it is going to help us? This will help the topicals reaching more efficiently into the frontal.
So all these polypoidal mucosa which are.
Yeah, no, you don't have to do anything aggressive to the mucosa.
Yes, yes.
Once the steroid start reaching there, it is going to go. See that?
Yes.
Wonderful, sir. So we can see.
So frontal, believe me, follow the beak, no challenge.
So whether you wash this with steroid solution right now or it will be for post-operative period only?
Post-operative.
Okay.
Post-operative. See the frontal sinus.
Yes. Yes.
If you want to remove further this beak, to improve the topical penetration, see that is the concept of 0-degree visualization. Remove this beak middle turbinate complex anteriorly to give a 0-degree visualization to the frontal. See this?
Yes. But very strong punch.
Yeah, very, very strong punch it is.
Can you show this punch?
Yes,
I mean, panoramic view of this punch.
Yes, yes, I will, sir. This is amazing tool from Karl Stolz.
Very wide opening now.
Right.
Hello?
Widest for this particular anatomy.
Right. Definitely now if we wash, it will go into the sinus only in OPD.
Further, I will further widen it to the maximum. And then I will show you a picture with a 0 degree.
Sir, people want to see the punch.
Yes, give me. So this is a articulated
Oh.
punch.
It is almost 90
Yeah,
degree.
Yes, this is Karl Storch. And it has multiple articulations to give it an angulation. And this is a very solid punch. You can
Must be costing lakhs of rupees.
over 2 lakhs.
2 lakhs, over 2 lakhs.
But amazing thing.
Achari is saying that Karalkar is also having the same.
No, but I've used that. Cannot beat Storch. The angulation is different, very different. The angulation punch is different.
And how long you are using? It's a definitely durable instrument.
Yeah, I've been using this for almost more than 8 years now.
Oh, so it's a worth.
Yeah, Karl Storch equipments that way are, I would
Value
say,
for
cost
money.
effective also. I know they are costly, but worth and cost effective in the long run.
Yes, yes.
What is the difference in a primary and a secondary?
See this widest frontal sinus exposure you can think of.
Sir, in the last conference, you rounded off the lower edge of the axilla with a small drill.
Yes.
Hello. Can you just show it here once again? Will it be possible for you to do that?
Lower end of the, I didn't get your question.
Last time when you operated, you rounded off the lower edge of the axilla, that bare bone where it was seen.
Yeah, with the drill.
Yes,
Just for the sake of demo. That's it.
yes.
You can in case needed. See what I'm using.
Lateral lamella where it is.
The so-called adenoid blade, which I condemn to be used for adenoids. They have written to the company to be banned for adenoid surgery as a rear facing blade.
Dr. Satish, could you show the location of lateral lamella in this point?
Lateral lamella?
Yeah, at this point.
Yes. Like I showed you yesterday in the cadaver.
Yeah.
Remember?
Yes.
Let me tell you. I will tell you once I come to the anterothoidal artery for sure.
Okay, okay. That means at this point we need not be bothered
See the
about-
area where I am working. Caudal to the frontal sinus is anteriorly.
Yes.
And what is this recess which is going up and laterally? See this?
Supraorbital.
This is supraorbital recess. This is caudal to the frontal sinus. See this?
Yes.
And see my bulla is still intact. Still, I didn't utter a single word about the concern for the anterothoidal artery because I need not to worry about that. That is far posterior. I had shown you on CT scan also. Don't need to start,
Sir, what is the care in secondary cases?
What is the
Care,
care?
yeah, during the surgery.
Revision cases.
Yes, sir.
Revision cases, the only landmark, challenge is the identification of landmark. Always. Any revision surgery in the body. Landmark, because your original landmarks are distorted then because by the previous surgeon. So you have to be more, experienced in identifying the landmarks. See my frontal?
Yes.
And see the limits.
Yeah.
See the limits. See my turbinate which I left here for identification. Can you see? In spite of partial resection of the turbinate, I left there, a part of the turbinate.
And how do you identify the frontal supraorbital cell?
Supraorbital cell is always caudal to the frontal sinus. See, the frontal is above.
Yeah.
And next thing going laterally, the supraorbital. So that is always lateral to it. Lateral and posterior to it.
Lateral and posterior.
Now coming to the bulla. See my turbinate in place? Middle turbinate?
Yeah, yes.
What I'm keeping is 70-degree in view all the time? My medial and lateral limit. This is my medial limit, this is my lateral limit. Anything you want to do, you can play around in between these two. And we took the third reference of the beak to enter into the frontal. See, so simple. This was the axilla, remember?
Yeah.
This is the beak. And where the beak ends, what is there? Frontal. When God has given such a straightforward anatomy, why not to exploit it and looking for here and there so many things for the frontal unnecessarily? Now see, this is your the bulla. Can you see? Hello?
Yeah.
This is your bulla. I am getting this bulla fractured. Go behind and fracture it. See this?
Yeah.
Go behind and fracture it, get rid of this bulla. See this? Reverse the concept.
Bulla is a garbage.
Now it is garbage. This goes up to the front, to the skull base. I told you, my anterethmoidal artery will be immediately caudal to the supraorbital recess. Oh. For you can see the artery. Can you see the vessel?
Yeah.
Now suppose, yes sir. ठीक है, perforation no? Suction. See, if you get slight puncture into the vessel, hello?
Yes,
sir. Don't need to clarify yourself. Give me a mirror cell. This is a sub-millimetric vessel, you know. The diameter of the vessel is less than a millimeter. Just apply your surgical, this mirror cell for a minute and it will stop. Don't need to worry about.
Still using 70 or 0?
70.
70.
70 is always a good telescope. So, is more versatile telescope. You can go anywhere. I can rotate my cable and see the maxilla there behind.
Yes.
I can rotate the cable and see anywhere.
Yes.
All around.
So suppose in these massive sinusitis cases, if sometimes we have one of the sinuses having no pathology like frontal or sphenoid, should we open it or we can leave?
One of the sinuses
is without any pathology like frontal sinus has no pathology or sphenoid is clear. Should we open it or we can leave it?
Yeah. Depending upon the disease. If this is an eosinophilic disease, and if you are doing a rest of the sinuses on one side, why not to open it to allow the steroid to reach inside?
Okay.
That's it. It will not harm anything.
Yes.
See my skull base there?
Yes.
That is caudal to the patla. Caudal to the supraorbital cell. Yes, now we'll be free in a minute's time. And now we'll look for the anterethmoidal skull base. Complete anterethmoidal skull base. With our skull base burr. Skull base burr is what? Adenoid burr.
Yes.
Wash. Yes.
Sir, in case we have an anterior ethmoidal bleed, what do you suggest, a unipolar cautery or bipolar?
Bipolar, always bipolar. A section bipolar. For a small rent or anything, you don't need anything practically.
Yes.
Yes, if it is a complete transaction, then it is advisable to use a bipolar. Give me reverse bleed. Reverse bleed. See this?
Yes.
See the entire frontal sinus and the ethmoidal skull base flushed.
Yes.
They're not leaving any cell uncovered so that your solution doesn't reach in future. बंद है यार ये। तो पतला दे, छोटा दे, इसका भी छोटा। The section is closed. छोटा। So always use adenoid blade for the skull base work. Clogged, blade is clogged. Open up. Don't leave any cell uncovered. If you leave any cell uncovered, your topical is not going to reach there and it can lead out to the mucosal disease again, maybe polyp or anything else. No. There. See now my skull base bleed. Under vision. Block है यार ये. Why don't you see? Block है जरूर block. The blade is not working. And this is how you can flush your entire ethmoidal skull base. See that?
Yes. So sometimes you do very good surgery, tell your patient to wash it regularly, but sometimes he forgets to wash, then subsequently he comes again to you after 3 months
Yeah.
with lots of polypoidal disease. Then what to tell him, how to console him, because he is always going and coming and blaming you that surgery has failed.
That's why the counseling, pre-op counseling is so important. चल नहीं रही यार, देना कुछ 10 बार कह दिए थे. See, pre-op counseling is so important.
What you should tell?
You are not supposed to tell your patient that we will operate on your sinuses and you will be all right.
Right.
That is the biggest joke you can crack for this disease. You have to tell your patient
Yes.
that this is a steroid dependent disease. You have two options now. Either to take the steroids forever. You take the course of steroid, it will improve. The moment you stop,
it will recur.
It will come back with the same problem. So the best is to open up the sinuses, remove this disease, and give the topical steroid to go inside. So you don't need to take oral steroids. That you need to counsel. The patient should understand why he was operated.
Sir, can't we bipolarize that bleed?
And how often he should come to you?
Depending upon the profile. That's why the lot of the series of investigations are required to ascertain the particular endotype of the disease, what kind of disease it is, how much eosinophilia it has. So this?
Yes, sir.
So what about tissue biopsy? Like, do you send any samples?
Yes, always a part of the. See, there is no bleeding. Hello?
Yes, sir. Yes, sir.
That's the mucosal leaves, nothing else. And see the entire anterior ethmoidal skull base completely flushed. So you have to counsel your patient that we will train you post-operatively how to push the topical steroids. In the present context, there is no other weapon with us to treat your disease than steroids.
So apart from washing it regularly, do you recommend some other, I mean, immunotherapy or any recent medication for that?
Yes, that's why I always share the list of investigations, number one, and the comorbidities which can be associated with these patients. Mostly, it is the localized suppressed immunity which has resulted into this disease. So, anything which improves the immunity is going to improve the situation, you know? Like for example, probiotics, prebiotics to improve the gut flora and nasal microflora. To improve the richness and diversity of the good bacteria is going to improve the situation. So we always add these patients for long term the pre and probiotics, number one. That is something which helps. If patient has associated allergic rhinitis, then you get the allergic testing, skin prick testing and immunization. Antihistamines have no role just to control the symptom as long as they take. Antihistaminics do not change the natural course of disease. Can you see the vessel?
Yes.
See the vessel?
Yes.
That is the supramular cell you are asking. Just anterior to it.
Yes, sir.
And then it is the supraorbital cell. Can you see very clear?
Very clear.
Yes, sir.
And above the frontal sinus, and this is 0-degree visualization of the frontal. See that? Because we remove this weak middle turbinate complex. Can you see?
Yes.
Removal of these weak middle turbinate complexes allow the topical to reach more efficiently into the frontal. So simple. No bleeding?
Yes.
So anywhere of vitamin D?
Yes. Second is vitamin D. Yes, those having extreme deficiency of vitamin D. See, marginal deficiency is very common. That doesn't affect, but extremely vitamin D deficient people should be replenished and it improves. Those who are smokers should be encouraged to curtail the smoking to improve the mucociliary activity.
Like any role of N-acetylcysteine?
N-acetylcysteine is nowadays more and more used as an antioxidant rather than, mucolytic. Mucolytics have no role. See now, we have done anti-ethmoidectomy, we have done frontal, we have done maxillary. Can you see all clear?
Yes, sir.
Now in order to enter the post-ethmoid, this is ground lamella. This is the maxillary sinus roof, the orbital floor. At this level medially, one can enter into the roof, into the ground lamella. Why at this level? This is maxillary line. Why at this level? If you try to go above this, you can enter into the skull base so easily. See this?
Yes.
So never ever. Stay below in the level of the maxillary line. One way. The moment you enter into the post-ethmoid, now we have two things left on this side. Post-ethmoidectomy and sphenoidectomy. I will not do post-ethmoidectomy first. I will do sphenoidectomy first. The reason being, post-ethmoid is followed behind by the sphenoid.
Yes.
And we never know when the sphenoid starts. If we are lost, you can damage the critical structures in the walls of the sphenoid like carotid and optic. So we should know where the sphenoid starts. If you know where the sphenoid starts, you can accomplish your post-ethmoidectomy under vision without any problem. So what I will do here, at this level, go medially. Since we have already removed the part of the middle turbinate, so our life is much easier. Can you see something below?
Yes.
This is your superior turbinate. I am taking away this part of the superior turbinate. Can you see?
Yes.
Yes.
This is superior turbinate. The disease medial to it. See the septum, and at this level you can enter into the sphenoid.
Yes.
Easily. This was a child's play. Straightforward situation for the sphenoid. But whenever you look for the sphenoid in difficult situation, the landmark is
maxillary line.
this maxillary line. Never go above the maxillary line.
Yes.
And go flush to the septum.
Septum.
Not flush to the turbinate. You can go into the one of the cell behind, go flush to the septum, it has to be the sphenoid. If you don't go in the maxillary line, try to go and go up here, you can enter into the planum sphenoidal and a CSF leak is likely there. So there are always safety landmarks. This is the surgery of, landmarks.
So maxillary line is the
Yes.
reliable landmark.
Yeah.
Now, boss, in cases where there is isolated sphenoid disease,
Yes.
so which approach is your preference? You
Pure
go-
medial.
Go medial to the.
Pure medial.
turbinate? Okay.
Pure medial. Now see, I have seen the sphenoid. Now I can accomplish my post-sigmoidectomy staying anterior to it. Staying anterior to it, I can do any damn thing. Keeping my orbit and the lateral limit, I can remove all these cells. Staying anterior to the ostium, as my carotid and optic and all those things are never going to come anterior to the ostium. So we have, what we have discovered, this sphenoid ostium is a safeguard.
Right.
This sphenoid ostium is a safeguard that you are not going to damage anything if you don't cross this limit.
Satish sir,
Yes?
supposing you have difficulty finding the sphenoid ostium which is closed by the mucosal overgrowth,
Yes?
can you suggest some tips and tricks in order to
Yes.
identify that?
Number one, I have already told, number one, in any given situation you look for, never go above the axillary line, this maxillary line.
Okay.
Never go above and use your suction periosteum sliding at the level of the maxillary line or below along the septum.
Okay.
Now I am removing this wall of the maxilla.
So Satish bhai, the previous teaching was that you follow the coena 1.2 centimeter above the coena, or you go from ethmoid to inferior-medially, or you cut the posterior 1/3 of the superior turbinate. All these three landmarks. In place of that, you said that the maxillary line is the most reliable landmark.
Most reliable, always works. See, landmark, science is always evolving. If something works for you best and is a God-given landmark, why not to exploit that? Now see, I have done post-sigmoidectomy
Yes.
and now the last thing left to me, widening
Widening of the
this,
sphenoid ostium.
just staying to the anterior wall, not going deeper with any sharp instrument.
So in this also, if you are going laterally beyond the septum.
See the disease, see the mucosal disease,
Yes.
see the mucin.
Sir, any role of CRP in backup investigations?
What?
The CRP.
CRP is a non-specific investigation of bacterial, inflammation. So, in case you want to give antibiotics,
Yes.
see, this is not infective disease, this is inflammatory disease. There could be associated bacterial infection as well. So, in case you suspect bacterial infection,
Then monitoring of the CRP is important.
yes, you can first of all judge whether there is bacterial infection. If the CRP is normal, it rules out bacterial infections
Yes.
for that matter.
Yes.
See, I am widening the sphenoid,
Yes, we are seeing the landmark.
staying on the anterior wall,
Yes.
nothing inside. See the wide sphenoid now. See the entire skull base flushed. Now coming to the Dubé-Sir's question. If the patient doesn't do douching post-op,
Yes.
Dubé sir,
Yes, sir.
having done this work, full house face. See the full house face?
Yes.
See the optic now.
Yeah,
Opticocarotid
yes.
recess.
Yes.
See, if you don't take this this sphenoid sinus as a landmark, if you keep on doing work inside, see, one can easily damage the optic now.
So how to handle onodi cell if we encounter like in this closed space?
Forget about it. Assume every case is onodi. Stay medially, widen the sphenoid and then go
Then
further.
come to.
Now, coming to Dubé-Sir's question, in case this side is done. In case the patient doesn't do douching and develop polyposis. You know?
Yes.
Having done this kind of a full house work to the limits, there is nothing left for the future surgeon as far as the sinus surgery is concerned. See that?
Yes.
What you can do, you can start the patient on oral steroid for a while and debride,
Yes.
and then topical steroid will take care again to the mucosa. Because practically you don't need a formal sinus surgery now.
Yes, because you have already, all the bony,
So this you can mention in your consent as an indirect guarantee. I am not using the word guarantee ever in science, but as a sort of indirect, to explain the patient that having done this, if you continue with the douching as explained, you will unlikely to have this disease again. But yes, in case in some unfortunate situation, if you are not doing that and develop polyps, still you don't need a formal sinus surgery.
sir, is there?
See now the landmarks everywhere.
Yes, yes, yes. Absolutely fine.
Can you see the full house sinus cavity panoramic view?
Yes, yes.
Fantastic. Sir, do you advise any medication for seasonal variation?
No, that is allergy. See, that is a comorbidity. If you have allergy, you have to treat accordingly.
Sir, during the surgery, what's your preferred solution, like for the washing, saline or ringer lactate?
No. With steroid.
No, sir.
Steroid mixed in ringer. Ringer is a much better, alternative to the normal saline.
And sir,
Ringer is more physiological as compared to the saline. It contains along with the sodium chloride, the potassium and lactate as well.
and sir, do you warm the solution during the surgery?
Pardon?
Sir, you warm the solution, you have warm ringer lactate?
No, not. See, in this disease, we want a good mucociliary activity.
Sir?
Wash kar.
Sir,
Yes?
can you show the posterior ethmoid artery and in the other?
This ethmoidal artery is generally not very prominent because it passes through the thick postethmoidal skull base. But yes, I showed you yesterday. You can anticipate that a few millimeter, 5 to 6 millimeter anterior to the optic now, which is more almost always visible.
Sir, if this sphenoid sinus is very deep, do you need any inferior widening also, inferior border widening?
Yeah, in case of doubts, in case of extensive fungus, there is no harm in doing that.
But sometimes when we take punch over there, there is a brisk bleeding.
Yeah, because the vessel running on the anterior face, that is the nasoseptal artery.
Right.
So in that case, you can elevate the flap first.
Okay.
Sir, one more query not related to this polyposis. In case of severe ANS, we encounter sometimes on the opposite side severe inferior turbinate hypertrophy. So once correcting the septum, do you correct the hypertrophy of the inferior turbinate or you leave it?
Yeah, it depends. If it is a bony hypertrophy, you need to core out the bone. If it is a mucosal hypertrophy, then you can ablate that and you can do a posterior nasal neurectomy. Let me tell you posterior nasal neurectomy.
Yes, sir. Where we have to ablate.
Yes.
You are
Let me
telling
tell
that.
you what is to be done for posterior nasal neurectomy. I showed you yesterday posterior nasal nerve. They emerge from the pterygoid bone, from the pterygopalatine fossa and come in the
Attachment of the
nasal cavity between this is middle turbinate attachment. Can you see?
Yes, yes.
Yes.
And this is inferior turbinate.
Yes.
Now, just about the middle turbinate attachment here is the sphenopalatine foramen. Here.
Okay.
It is coagulator. These nerves, they emerge in the vicinity of the sphenopalatine foramen and then they pass inferiorly toward the inferior turbinate through this flat area. Can you see?
Yes.
Yes, area between.
In the mucosa. To ablate these nerves, what you can do simple. See, this is coagulator.
Yes.
Okay.
Don't need to look at these now.
Ablate this area.
Yes, as a whole.
Bilaterally.
Yes, bilaterally.
Yes.
See this?
Yes.
Yes.
Rather than doing a video neurectomy, this is selective posterior nasal neurectomy. And it helps in, tackling the turbinate hypertrophy as well.
So in case of posterior epistaxis, how to identify sphenopalatine vessels, like if we
Hey, man, yesterday I had shown you.
Yes.
I had even clipped to show you.
Even sometimes, sir, the posterior most part of the inferior turbinate is very bulbous. So need to cut it?
Yes. So I told you there are two types of hypertrophy, bony or submucosal.
Yes.
In submucosal, this posterior neurectomy will work. But in bony hypertrophy, you have to reduce it.
Satish boss, instead of ablating, what if we just coagulate the mucosa?
This is coagulation only.
Okay. All right.
Coagulation of the mucosa carrying the nerve in that.
Right.
Now see, coming to the opposite side.
Yes.
Here we don't see too many, polypoidal disease medial to the turbinate. Don't see. See? Hardly any polypoidal disease medial to the turbinate. Yet turbinate is floppy. So here I am not in favor of partial resection. Because had there been disease medial to it, the partial resection will allow the steroid to reach the olfactory region. But here, since there is no massive disease medial to it, so I'll try to preserve the turbinate and do something else.
Boss, I agree with you, but just in case, even if this is a floppy turbinate, we resect the inferior part like in your
There's no harm.
like there's no harm, right?
No harm.
Right.
But see,
So
when it is not needed, you can preserve it. So that's why I told you, there are various ways. Now see the middle meatus, very clear. Now quickly, inferiorly directed, see this? Until you reach the hard bone. This part now I will go quickly, as we have already discussed. Anybody has any questions regarding the sinus disease, sinus surgery, please come forward, any suggestion.
So bilateral anterior resection of the middle turbinate, there is no issue of any anosmia or any problem?
Inferior part is devoid of olfactory, mucosa.
Boss, there's one question and one problem that I face is sometimes when the polyps are, very anteriorly placed or the region is anterior in the maxillary sinus. So in those cases, how do you?
So in those cases, you can use another avenue through the sublabial route. You make an enterostomy. You use your trocar cannula and make a 4 mm opening.
So, boss,
and then pass your debrider through that and 70 degree through the nose.
All right. So sometimes just removing the part of the inferior turbinate bone and just making the ostia a little more wider inferiorly, we can approach those polyps.
Yes, you can do that.
But invariably, we have a risk to injure the nasolacrimal duct also.
So why to disturb this physiology over here, unnecessary? Once you have an option, there is no harm. See, in this sublabial region, just make a 4 mm puncture with a trocar, push your blade through it with a 70 degree visualization from inside, remove. The moment you remove the blade, it fails in no time, without any side effect. Now see, this is the upper part of the uncinate.
Yes.
I am going little quick.
Yes, yes.
बंद हो रहा है यार. Section का कर.
So you are not in favor of inferior meatal window?
Not really.
Okay.
That is not physiological. Because it has been now very well understood, the ciliary activity in the sinuses takes the secretion to the natural ostia.
No, just to improve your access instead of making a sublabial. How about doing a inferior meatal window?
So there's a part of the agamazi.
Yes.
I'm widening the axilla. See this?
Yes.
That's the part of the agamazi. We have already seen our lateral limit.
Lamina.
And quickly we will be in frontal in no time. Frontal once again. The same exercise I will show you so that you will never forget. One डाल देगा ना.
But sometimes in revision cases, in this frontal area recess, along with the polyposis, there is fibrosis because the mucosa has been injured during the previous surgery.
Worse. That is very, very difficult to treat. And if you have, it's a revision situation, if you are in doubt that you are not able to give a patent opening, see the lamina laterally?
Yes, yes.
See the beak,
Yes.
the axilla, the maxillary sinus and the bulla. That will take 70 years. So in that case, Kapila,
Yes, sir.
if you are not sure, do a draft.
Okay.
Don't take a third chance for surgery. Draft has hardly any disadvantage. See now,
Yes.
what I am showing, see the level of the axilla. Over there, so, see the level of the axilla. What a long
Yes.
ball. This is the axilla section. Just to tell you everybody, simplest way of accessing the frontal. See, this is axilla.
Yes.
This is beak.
Yes.
This is the cell at the level of the beak. See the beak behind. I can feel the hard bone, hardest bone in this region. Hardest bone. Can you see the hard bone there?
Yes, yes, boss.
Where it ends. See this where it ends?
Yes, we can see.
That is the opening.
What can be the simpler way to open the frontal than this? Tell me. Tell me.
Yes, yes.
So you are using RAD 40 here or was RAD 60?
60, sometimes 120. 40 will not work.
Okay.
40 will not reach out. 60 may reach out. 60, 90, 120, whatever. So the idea is your landmark should be simplest one to be identified. Sometimes your landmark is so difficult to identify, then how to rely on it. See, simple. Anybody doing FAST can identify the axilla. Can you see?
Yes, yes.
Then underneath the axilla, can you see the beak?
Very
How
true.
can you identify the thickest bone? You can't break it easily. And go behind where the beak ends in the frontal. Simple. I hope you agree with me.
Yes, yes, yes. Every day we are finding easier and easier landmark by you.
So I am flushing laterally here.
Yes.
It is not only easier, it is safer landmark also.
Safer landmark, yes.
Because when you are working far anteriorly, you are away from all critical structures. And you can flush it to the limit. See, my median limit is turbinate.
Yes.
See, I flush with the turbinate. I can't go anything beyond that. My lateral limit, see the lamina? See the lamina?
Yes.
Reverse. I can't go beyond that laterally. See that?
Yes, yes.
And now I will flush it with the posterior table. Flush this posterior table with a ethmoidal root using my skull base blade. Reverse. See, this is posterior table
Yes, yes.
and flush with the ethmoidal root. This anterior-most part of the ethmoidal roof is very safe. See the beauty of the reverse blade. Can you see the frontal and everything so crystal clear? Hello?
Yes, very clear. Yes.
This is our work we have done on thousands of FES. And our every single junior guy working is able to do this.
Actually, Satish bhai, previously it was auxiliary flap, then Caroline window, then different types of other terminology. Now you have given the
All those
best
are
way of doing
good.
it.
All those are good. But why to make your life so difficult?
There's Jain's window also, sir.
Which window?
Jain's window.
No, I have no window.
Actually, it's a gents window. Okay, okay.
I have no window for that matter. See this?
Absolutely fantastic.
Skull base. Now, this is your bulla. This concept of intact bulla was earlier popularized by our own Dr. Sethi,
Yes, sir.
who was yesterday with us. And see what a simple concept he has brought out. This bulla, the anterior wall of the bulla goes to the skull base, anterior to the anterior artery. Keep this patent, keep the anterior artery protected, as simple as that. See this bulla? So next probably 5 to 10 minutes I will be through.
And what is the next case, sir?
Oh, I don't know. Dr. Khanna will tell you. What?
You were telling us that there is a JNA. Yesterday you announced.
Yeah, JNA, there are two interesting implants. One is a regular one.
And
One
one
is a
is-
cholestoma, subtotal peterectomy implant, same stage.
Good.
Satish, bro, just tell us about your nasal packing protocols also, post-op.
See the same gel foam pieces, you know? Same gel foam
Satish, sir.
pieces.
ये Merosil pieces.
No, Merosil pieces. You can pack, so again, steroid and pack into the cavity.
And you remove next day? Or
Day after.
48 hours?
Day after, 40, reverse. Day after.
Soaked with steroid solution
Yes,
or some ointment.
steroid.
Okay.
This disease requires steroid.
And when boss, you have done full septoplasty along with the FES. In those cases, I think the pressure over the
Can
septum
you
is.
see the anterior artery there?
Yes.
Yes.
See the artery?
Yes, very clear.
Yes, Karaji, you were saying something?
Sir, I was saying when we do full septoplasty also along with bilateral FES, what I found that even if we keep these Merosil pieces like you have told, sometimes it keeps on oozing again. Yes.
So, yeah, see, that is the nasal secretion which can, you know, which can weep, you can say, and make the packing wet.
And patient's attendant will come to you immediately.
Yeah, there is some bleeding.
So it is better.
What I do is
nothing
I
should
put
come out.
another full Merosil along the
What is
nasal
it?
septum in the that goes till nasopharynx along the inferior turbinate on both the sides.
So once you have seen the anterior artery, that means you have done the anterior roof work completely, because anterior artery is the last landmark in the or posterior most landmark in the anterior roof. See this once again. Can you see?
Yes, sir. Absolutely fantastic. Very good.
Very clear? And now I will switch over to the 0 degree.
0 degree.
That's the maxillary sinus. 0 degrees. So last work for the post-sigmoid and the sphenoid. This sphenoid we know has a lateral recess. We'll show you that with the 70 degree.
Sir, you promised to show us the transpterygoid.
Transpterygoid approach therapy, okay.
Sir, what are your limits for the sphenoidotomy? How much do you enlarge?
You are not supposed to enlarge too much inferiorly
Okay,
to avoid injury to the important vessel for the future flap.
okay.
Yeah, secondly, you can enlarge laterally till the lateral wall.
Okay. Do you need to see the vital structures all the time when you enlarge, or is it?
Yeah, stay on the anterior wall, that's it.
Okay.
See this pathological access.
Sir, have you ever used drug-eluting steroid stents or the injection of Malizumab?
Yes, those are in practice.
सामने parallelly
Those are in practice. Those are now FDA approved also. The first one was
part
the
of the maxilla,
Propel.
superior border.
No, they are now available in India also.
Yeah, but I have
They
never
cost
used the
around
first.
10,000 rupees.
No steroid stent is available in 10,000 rupees.
No, stents are costly, but Malizumab is by Cipla.
Maybe I am not aware.
It is 10,000 rupees per injection.
See this? In the post-sigmoid,
Sir, can you tell step by step what is the method of enlarging the sphenoid anterior wall?
anterior wall,
No, like opening, widening the opening.
widen the opening, I just told you, not to enlarge too inferiorly, superiorly. Because you first put your punch to see that you are not beyond the limits and then I'll punch out. I will show you.
Right.
Some polyp there, lower down. So this,
Yes.
lower down only.
So again, Satish sir, you are telling that we have to confine ourselves to the anterior border of the sphenoid sinus.
Yes, and see
And
this,
previous teaching was that you can go inferiorly and medially.
see this, yes. The maxillary line,
Yes.
go along the septum. You can widen medially to flush till septum. See this?
Okay.
Superiorly, you are not supposed to widen blindly because this is more close to the roof.
Yes.
Laterally, yes. Now, anything anterior to this sphenoid, I will divide. See this?
Yes.
Okay.
And widen this sphenoid laterally to the lateral wall. That is what your question is. See why I opened up this area. Medial orbital wall. See this?
Yes.
Many a time we miss the Heller cell over here. See this Heller cell.
Yes.
What you need to do is remove this party wall and flush with the maxillary sinus.
Sir, how much inferiorly can be widened the sphenoid?
Whatever, till the cell wall is flushed. See this?
And that's good.
You have to flush this with the maxillary sinus. See that? See this? See the Heller cell? One can easily miss if this orbital angle is not seen. Can you see this? Now this is flush with the maxillary sinus. I can see the sphenoid ostium behind.
Yes.
Anything anterior to it, I can see my anterior artery anteriorly. That's the post-sigmoidal skull base. This is all post-sigmoidal skull base. Lateral limit is lamina papracia. See that?
So do you join the both sphenoid sinus also posteriorly?
No, why?
No need.
See, all this postcoidal roof I am tackling, staying anterior to this opening. See this? See this? Staying anterior to this only.
Yes.
Block.
Boss, there is a question. Is there any Herzeral cell or retromaxillary cell?
This cell?
There's a question in the hall is about a Herzeral cell or retromaxillary cell.
Retromaxillary cell, people describe, is basically a lateral recess of the sphenoid. I don't know if any had such fancy name. See now what I have done.
Yes.
I widened the sphenoid a little bit to the anterior wall, not inside. So this disease, mucin.
So that is why the inferior opening is required or not to flush with the. इधर नहीं सर अंदर हो.
See this, now the medial orbital wall completely flush this Heller cell. This is important. One
Yes.
can easily miss this Heller cell. Now, your question was asking about widening the maxillary, the
Inferiorly.
Give me correction. I am widening it laterally. Punch is always a safe instrument because you define your safety with your prong. So this, give me 40 blade. And then I will show you lateral recess. The last thing to show you is the lateral recess. See sinus surgery done on this side. So this side, we can see the full house cavity now. Hello?
Yes, sir.
We knew there was a lateral recess this side.
Yes, yes.
Yes, on the CT
And
scan.
this is going behind the maxillary sinus. Let me show you. 70. And rest of the job is done. See, I am going with a 70 like this. Rotating the cable. And all. Yeah. See the lateral recess there.
Yes.
See the lateral recess there?
Yes, sir. Yes, sir. So lateral recess means pneumatized clinoid, pterygoid.
Yes. Pterygoid process. See this lateral recess? Can you see this lateral recess in the sphenoid?
Yes, sir, very clearly.
That is the far lateral recess there.
Yes.
So this? Pretty clear. Zero. So this side job is done. And now finally I will bulgarize the turbinate on this side. I told you I will not resect since there is no disease medial to the turbinate superiorly.
Sir, you said you will show us
you
the
will
transpterygoid.
See this?
Sir, सतीश सर, एक बार सर स्फेनॉइड साइनस में सारे लैंडमार्क को पॉइंटर से दिखा दीजिए।
दिखाता हूँ।
Optic carotid, optico-carotid recess.
See this, I am making the septum raw.
Yes.
It's just mucosal surface.
Yes.
See this?
Yes, yes.
Opposing area raw and just keep them like this to invite adhesions. That is vulgarization. Wash. Could you see? Such
Yes,
a
sir.
simple process will keep Marocell for a day or two and it will invite the adhesions. Dalpani. Now finally in the sphenoid.
Yes, sir.
Sir, Satish sir,
Yeah.
you said transpterygoid, you will just point
Yes,
out.
yes. Give me a calculator. 40 there. Late 40. Sphenoid since the mucosa is hypertrophic. See this?
उस तरफ.
But what I frankly see here, that's the prominence of optic now.
Yes.
That is planum sphenoidal. That is optic now. That is the optico-carotid recess here. And that is the prominence of the sella. Since the mucosa is hypertrophy, you can't make out much.
तो सर ये जहाँ pituitary, where you do the pituitary just below the optic chiasma.
Yes. Below the optic chiasma is tuberculum sella.
Tuberculum sella or above it planum sella.
Yes. And below the tuberculum is the pituitary fossa.
Okay.
My pituitary fossa is right here because this is the optico-carotid recess.
Recess, okay.
Now for the transpterygoid, see this is our recess here behind. You have seen there. So in order to go there, you have to remove this sphenoid wall, this entry wall of the sphenoid. See this?
Yes.
Elevate this flap, remove this entry wall of the sphenoid, remove this medial part of the posterior wall of the maxilla. Behind that is pterygopalatine fossa, the sphenopalatine artery. Most of the time you have to clip it. And behind that is a thin pterygoid bone now because rest is pneumatized. So you have to remove this almost 1 square centimeter chunk of bone. See this?
Yes.
And then here would be your, you see, that is your lateral recess would be here directly in front of you. Anything else you want me to show on this? Okay, again the posterior nasal nerectomy. Give me the
bilateral.
Yes. See, let me show you first the middle meatal enterostomy here. See this? See the inferior turbinate, middle turbinate both?
Yes. In the area.
This is the region of the sphenopalatine. See the posterior wall here. That's the region of the sphenopalatine foramen. That's the region of the perpendicular plate of the palatine bone. All the nerves are coming from here and going to the inferior turbinate. So all these mucosa, where the nerves are going to the inferior turbinate. See this?
Sir, can you show the exact area of sphenopalatine artery which coming out?
Yeah, sphenopalatine is few millimeters above the posterior edge of this turbinate. Attachment. So to me, the sphenopalatine would be right there. Let me show you. It will be right there.
Sir, so the landmark is again the posterior maxillary wall or the turbinate
Yes.
attachment?
The turbinate attachment, see this? The artery is coming from behind this wall,
Okay.
coming here. This is the inferior attachment of the middle turbinate and roughly it is here.
1.5.
See, I can feel this cresta, this bone,
Yes.
behind this bone. I can show you if you want, finally.
Yes, sir.
Okay. Okay then. Why to keep the confusion? I had shown again and again yesterday. Anyway. Can you see this bone cresta?
Yes, sir. Yes.
अच्छा yeah okay. That is the vessel. Just above the cresta, that is the vessel.
Yes, sir.
See that?
Yes, yes, sir. Very clearly.
वो लेके जा, section लेके जा वहाँ. Above. Short. That is the vessel. That
Yes.
one.
Yes, sir. Yes.
See the level?
Yes, sir.
That's the turbinate attachment roughly here. I can cover this. Leave it. Okay? So we come to the conclusion of this case.
Thank you, sir. Very nice demonstration. Big applause for you, sir.
Thank you. Thank you so much for your patience.
We enjoyed every bit of it. And there are so many concepts which was there previously in our mind, which has now become very easier with your demonstration. And we learned some new terminology also. Thank you, Satish bhai.
Thank you, sir. Disconnect the one.
There is a question. This floppy turbinate already you have vulgarized, no?
Sir. Sir, अगला केस क्या है? Hello.
Khanna sir.
Yes. Hello.
What is the next case, sir?
Hello.
Hello.
हाँ जी सर, नेक्स्ट केस पूछ रहे हैं सर.
Next case is ear surgery. She is a lady
Yes, sir.
having a central perforation with tympanosclerosis. Not very large perforation, small perforation is there, small to medium, and having mastoiditis in CT scan. So we got the CT scan done, which will be described by Dr. Satish. I have already taken the graft.
And what is the hearing status?
Just give me some time.
Okay.
She is having moderate hearing loss, conductive on right side, and left side is normal.
Okay.
Dr. Satish?
थोड़ी देर से अंदर पर्याप्त.
It is a dry central perforation with mastoiditis. कौन है ना? कौन है?
So in the meantime, we can have lecture by Dr. Kailas on cochlear implant. What is that? How I do it. Shiva? एक लेक्चर आएगा उसको निकाल निकाल दो लैपटॉप होगा ना आपके पास हाँ जी भाई हाँ कल इसलिए जेन कल करेगा जेन कल कर दोगे ना हाँ हाँ ऐसा सब पूछा मैंने कल ओटी में भी परसों गया था ना इसमें कि चलो भाई सेम पूछा अगर एक और लैपटॉप उधर लग गया हाँ बोल सकता है
Good afternoon, everybody. Audio. Hello. Good afternoon, seniors and colleagues. I have come here from Kolkata. Thanks for inviting me to Dr. Sanjay Khanna. I work in Southeastern Railway, Kolkata. And today I am going to present cochlear implant, how I do it. Here Dr. Dubey sir is there. He was one of my mentors. I learned barrier technique from him. And my other mentors are Dr. Amit Kishore and Dr. Deepak Dalmia. So cochlear implant is a device, electronic device. It has got two parts, one external part, another is internal component. External part is sound processor and internal component is having receiver and stimulator. These things everybody knows. So actually I was asked to show some videos. So I am going to present some surgical videos. This is our first patient. It's a prelingual severe to profound deafness and 3 years old child. This pointer is for looking for incus. We are doing posterior tympanotomy. We have to identify the stapedius tendon, round window niche, then facial nerve. Here we will find the facial nerve. We are widening the posterior tympanotomy, then removing the bony overhang over the round window niche. So round window is seen very beautifully here after removing the overhang. Now I am packing this area till the last. After doing the drill work for the well, I have fixed the implant. With 90-degree hook, the round image is reflected. And with the help of little bit of steroids being injected, it's an advanced bionics implant which I am using most. And the insertion should be very slow and smooth. And the whole electrode has gone inside. And little bit of hat packing, then repositioning the electrode array in the mastoid cavity. This is one case. This is second case. 2 years 6 months old child, prelingual severe to profound deafness. Here, short process of incus is identified. Then vertically downwards, we have to do posterior tympanotomy and widen it. Stapedius tendon is visible here. We can measure the distance for receiver stimulator placement. Niche is being drilled out. In this case, we have done little bit of extended round window insertion. round window membrane being reflected. And little bit of steroid injection is given to prevent any fibrosis, intracochlear fibrosis. And again, implant is inserted slowly till the blue line. This is advanced bionics implant. And this is the final position. You can put some bone dust also there to fix it. This is third case. First, identification of short process sphincters. Then we have to drill for posterior tympanotomy. This area. See, quadrant tympanotomy is visible here. Stapedius tendon. Then we have to identify round window niche. Drilling of bony overhang over the round window. And finally, we have to insert the electrodes by reflecting the round window membrane. All these videos are fast forwarded. Actually, I was supposed to finish this presentation 15 minutes time. So this is fourth case. Well pneumatized temporal bone, so many air cells. This is short prosoincus, stapedius tendon. This is the facial nerve. Here the round window niche was little bit ossified, so we had to drill it. After carefully drilling this area, we found the round window area. Cochleostomy is being done. And finally, membrane is reflected and electrode was inserted. This was the procedure we did in this case. And this last case, last presentation, this is 1 year, 9 months old baby. Here we used a metal concrete concerto implant. And the insertion part is real time, all other part is fast forwarded. So it should be very slow, one by one, and should go very gently. So this is the real time video. So these 5 videos I have shown to you. Currently, we are having 3 major players in the market: Advanced Bionics, Cochlear and Medel. There are other players also. Neolake is there. So cochlear implant, why, when and for whom? Cochlear implants are economically very costly, hence indications candidate must be precise and definite. Candidacy for CIE has changed gradually but significantly since the first multi-channel device were implanted in late 1970s. Due to increasing experience, improvement of technology and proven reliability, the selection criteria are broadened with shifting borders. Main extensions are related to age, additional handicaps, residual hearing, and special etiologies of deafness. The obvious goal for careful selection of CIE patients is to never have a single patient perform more poorly with their CIEs than they did with their hearing aids. So stages in patient selections are questionnaires: age, etiology, onset of hearing loss, whether it is peri or postlingual, duration, sensory deprivation, to cover up for the plasticity of brain, especially in children, hearing aid use. Then they have to do audiological investigations, language assessment, radiological examination. These are important parts for evaluation of candidate selection. Then we also need to do some psychological assessment to prognosticate the patients. Vestibular testings are also required sometimes. Medical and otological examination is must. Electrical stimulation of cochlea can be done And finally, big counseling, because patients are spending too much, so they will have a big expectation, but we have to counsel them beforehand, and after surgery they require a long AVT. For that we have to prepare them. There are some contraindications as well: hearing loss of neural or central origin, absence of cochlea, absence of seventh nerve development, active middle ear infection, psychological contraindications are there. Other contraindications of surgery: Michael's deformity, tympanic membrane perforation is a relative contraindication, severe organic brain dysfunction. These are contraindications. Patients need to undergo some immunization, especially for pneumococcus. And cochlear implantation is not only surgeon's cup of tea, it's a teamwork. It needs many professionals to come together for a proper outcome. FDA has approved for implanting children. In 1990, it was after 2 years, and recently in 2012 months is the FDA approved age, minimum age. Changes in implantation are due to better or early identification of hearing loss, increased public awareness, increased professional awareness, changes in technology, and electrode arrow programming processor telemetry is also improved. The literature has demonstrated that in terms of speech development and language acquisition, the best results come from children implanted under the age of 2 years, and it comes similar to normal hearing children. All cochlear implant devices can be safely indicated for children 12 months or older. However, implanting children younger than 12 months remains controversial. Further reduction in age at implantation are currently limited by nature of audiological testing in very young children. In cases of hearing loss due to meningitis or hereditary hearing loss, implantation should be considered before the age of 12 months also. These are audiological battery of evaluation. Most important is BERA test. For children aged 12 to 23 months, hearing threshold for both ears should be equal or exceeds 90 decibel. And for individuals older than 24 months, hearing threshold should be equal or exceeds 70 decibel. Speech detection with best fit hearing aid in a sound field equal to or worse than 55 decibel. Minimum 3 months of hearing aid trial is must. During hearing a trial, child should be making at least month-to-month auditory progress as well as speech and language progress. If this is not the case, then CI evaluation should be considered. Speech and language assessment should be done. Psychological assessment and IQ testing should be done. Counseling, family support, motivation, and realistic expectations should be explained to the patient and their parents. Medical and otological examination should be done. CT scan traditionally the gold standard imaging modality. Superior visualization of the bony structure of OT capsule and the course of facial nerve is obtained from CT scan. Can miss cochlear fibrosis, retrocochlear pathology, CNS abnormalities, and cochlear nerve hypoplasia are absent. And MRI is more effective at identifying cochlear fibrosis. It can find the presence or absence of cochlear nerve and its caliber. And its weaknesses are inferior visualization of bony anatomy, inability to detect the presence of the round window, oval window, or an enlarged vestibular aqueduct. Often requires anesthesia for young patients. Adult candidacy criteria is history. We have to take proper history. If duration of the onset of this deafness is very long, then prognosis may be not good. Etiology, whether it is fever or trauma, we have to anticipate if fever is there, if meningitis, chances of meningitis there, then fibrosis may be there. History of hearing aid use should be asked for. Means of communication, education, motivation and realistic expectations are the tendency criteria. When to refer an adult for a cochlear implant, bilateral severe to profound sensory hearing loss, limited benefit from appropriate hearing aids, that is poor speech recognition, telephone use is difficult, limited or impossible. Patient relies heavily on speech reading or not writing to understand speech. Patient is distressed by the inability to communicate efficiently on a daily basis, and there should be no medical contraindications. Then speech recognition testing is the cornerstone in adult CI patient selection, where the best aided scores on open chat sentence test of 50%, less than 50% the ear to be implanted, and less than 60% in the control letter ear is considered as an indication for implantation. Choose the most appropriate ear, audiological factors, and residual hearing. In the early years of CI, the audiologically worse ear was chosen so that expected iatrogenic cochlear damage would have fewer consequences. In the late 1990s, the better ear with the most residual hearing was preferred, as studies had shown that better preserved peripheral neural pathway would lead to better results after CI. Okay. Now I am passing all this. Bilateral implantation is always better than unilateral implantation, but it is costly. So wherever possible, bilateral implantation should be considered. Children below 12 months usually have poorly pneumatized mastoid bones, leading to greater intraoperative blood loss and risk of facial nerve injury, greater anesthesia risk, thin scalp care in drilling well for body of device, and increased incidence of otitis media. Fortunately, cochlear is level size at birth. Nowadays, hearing preserving surgery is also done. For that, hybrid implants are available. Thank you.
Good. So I think OT is ready. So meantime, we had one pituitary case, but somehow because of medical fitness, it is not, we are not able to conduct it. So I will request Dr. Rajiv Kapila to say something about pituitary. Okay, yeah, it's it. Yes. He has very wonderful videos and presenters, and he is doing regularly these pituitary cases. So we can.
नहीं आया निकाल दो
आया क्या? हाँ जी, आया आपके पास?
So good afternoon. I'll take you through the basic steps of the pituitary gland surgery first. Again, like all surgery, the foremost thing is the exposure. So one side middle turbinate generally we take out to make the wide exposure. So the middle turbinate has been taken out, and this is after proper decongestion on both the sides, as we want bi-nostril approach in the pituitary surgery. So after the middle turbinate has been taken out, so we go to the sphenoid sinus ostia and do a little superior turbinate resection, and we identified the sphenoid sinus ostia, and then the sphenoid sinus ostia is widened along with some part of the posterior septum is removed, and now we are raising the flap here. So this is an incision that is given to raise the rescue flap here, because here is where the pedicle for the head flap lies, and even if we don't need the pedicle, this pedicle should be preserved so that it can be used just in case it is needed later on in the surgery or in revision surgery, we don't know. So that is the sphenoid rostrum that is exposed. And then we go to the sphenoid on the opposite side and make it wide opening. So now you can see the owl's eye appearance of both the sphenoids. So you are getting the glimpse of the sella here. So that's the sella. You can see the opticocarotid recess on the left side here. And here is the opticocarotid recess on the right side. And this septum is attached to the carotid on the right side. So again, all these septa should be removed, and like this septa that is attached on the right side on the carotid, it should be used with blunt instruments like the true cut forceps, and never a debrider or a sharp instrument should be used, and it should not be plucked, as the bone over the carotid may be decent sometimes. So after this is attached, so that is the mucosa over the sella. The mucosa is removed over the sellar part of the tumor, and that's the sellar dura that is there. So that is the inferior along the floor of the sella that we are exposing. So it is very important to remove the floor of the sella, because removing the floor of the sella makes your instrumentation straight, and you can control the bleeding or any unadvertent incident if happens. So after this exposure has been done, then you coagulate the dura and give a U-shaped incision over the dura. And if the tumor is soft, it will start coming out immediately. You take the biopsy and then you start removing the tumor. So these are the basic steps that are done in every pituitary surgery. So you extend the dura, and then if the tumor is soft, it's a work of the suction tips and the curettes, blunt curettes, and the surgery is done. At this stage, generally the neurosurgeon accompanies us for the tumor removal. So I'm fortunate to have very good neurosurgeons associated with me in my hospital. So, but there are certain things which needs to be taken care. I'll take that in the further videos. The first is the preservation of the natural pituitary. So, like in this case, this was a dentist patient, which very young patient, around 24-year-old dentist, and she developed a pituitary tumor, and just see the normal sleeve of pituitary just anterior to the pituitary tumor and almost covering whole of the tumor. So we need to preserve this normal pituitary. So generally the normal pituitary is displaced laterally or posteriorly or to one side. So what we get is head on is the tumor, but in this case we directly head-on got the normal pituitary. And similarly, the same type of exposure we got a sometimes very rare to find this vein on the dura, or so we may encounter an arterial bleed while cutting the dura, what is known as Karnal's artery. So it was coagulated. And this vessel being coagulated. So what makes this case is that when we gave incision like in previously over the dura and we raised the flap, so again the U-shaped flap is being raised here. Now the yellowish thing that you are seeing here now is not tumor. Alright, so this is normal pituitary that you are seeing. So if the flap was raised over it, the dura was raised. See, so that's this is the normal pituitary, that's the dorsum sella, and this is the normal pituitary. So it was raised as a flap, and after raising this, the tumor was removed. And the post-operatively, the patient had normal hormone functions and she recovered well. And this was closed later on with the conventional closing techniques. Now, like any other surgery, even in pituitary surgery, the exposure is the key. Like this is what we get in routine surgery. But at the initial part of the step of the surgery, we are not clear about the landmarks. You know, the sphenoid ostia is not so widened. They are septa attached. So we don't know where our carotid is, where our optic nerve is, where our OCRs is. But as we slowly move forward in the surgery and we start delineating our landmarks, we come clear about the septum. So one thing in this case was very special. So now we have opened the sclera. So this is my divider, and see on the right side, this is a dehiscent carotid. So there is no bone on the carotid here. All right, and a very thin bone on the carotid, but the dehiscent carotid here with only the wall of the carotid directly on the right side. So as we widened the exposure, removed the septa again. So this picture came clear. So again you can see the intersphenoidal septa. Now this intersphenoidal septa, this ridge needs to be removed, as this needs to be made flush with the tumor wall. Now this keel or the floor of the sphenoid sinus should also be removed to make the instrumentation better. Now we are checking with the Doppler probe about the status of the carotid, and it showed that the carotid was dehiscent. So that is the point that we should not use debrider or any sharp instruments blindly in the sphenoid sinus, because we never know when a catastrophe is going to happen. You can see a very thin bone on the opposite side also. All right, so again after drilling, this ridge was drilled, and that is the area of the planum and the tubercular sella. So that area was drilled, and that is the final exposure that you get. So you can see the exposure at the end, and you could also see the exposure at the beginning. So that is the exposure. You must be able to see the panoramic view. In a single view, you should be able to see both the OCRs, both optic nerves, and the both paraclival carotids. So that is your ideal exposure, along with the sphenoid planum and the tuberculum. So again, just to show you the exposure also. So this case was a very different case. This patient presented as a pituitary tumor, but on opening the dura, what we found was it was a case of pituitary abscess actually. You see the pus coming out of the pituitary sella. Isolated pituitary abscess is a rare entity, but it presented to us as a pituitary tumor.
So now coming to more advanced cases, you see this case, which is going significantly up till the third ventricle with very significant supracellular extension. So we need a better exposure, because the ideal exposure that we do, we need a little more exposure for this case. So in this case is what Dr. Satish was talking about, transplanar approach. So we on the right side, because on the right side the tumor was going very high, so we want an exposure more anteriorly on the right side. So this the planar area was drilled to get a better exposure. And after this exposure, because of the bone is absent, the tumor falls down. The tumor falls down, your instrumentation is very easy. You can, with your suction, you can lift the dura and you can reach till the top. So that makes your tumor removal easy. So these are the cases where we need to go more anterior with the transplanar approach. Now, intercavernous sinuses, in very extensive cases, you may encounter some intercavernous sinuses that needs to be coagulated before we move ahead. So you see this, we have already opened the sella. This is the same case that I have shown. We have already opened the planum area, and in between is the cavernous sinus. This not working. So this is the cavernous sinus, superior intercavernous sinus. It was coagulated and then it was cut. After coagulating the intercavernous sinus, it was cut with the scissor to get the ideal exposure. So exposure again is the key, depending on the type of and extent of the tumor. So after this was cut, we got ahead with the tumor removal. You see again a very significant supracellular extension of the tumor. You can see the tumor going till the third ventricle again. And in this case, we tried to do extracapsular dissection, lifting the tumor extracapsularly, and you can see the brain tissues lying superiorly. And as we started doing gently it, you can see the anterior cerebral artery there. You can see the anterior cerebral artery there, and the tumor needs to be gently eased down in this extracapsular dissection without compromising the vascularity. So this is the post-op of the same patient. You can see the complete tumor clearance. Now, sometimes the tumor is more paracellular extension, significant paracellular and retrocellular extension. So in these type of cases, it is generally not easy to preserve the arachnoid, and the arachnoid is removed along with the tumor, and you get directly into the brain while removing the tumors like this. So before I show you the next video, you have seen the yesterday's presentation. So you must orient the pituitary gland, pituitary stalk, optic nerves, optic chiasm, the common carotid artery bifurcating into the anterior cerebral, middle cerebral, superior hypophyseal arteries, inferior hypophyseal arteries, and ACOMs. So you see in those case, in that case, after removal of the tumor, you see the pituitary stalk here, right? So that's the pituitary stalk. Next. Oh, okay. It's okay. So we'll continue later.
Yeah, we can continue in second. Right. Let's start with Satish is ready with the CT scan. Okay. Hello. Dr. Satish.
Hello. Yes, sir.
Yeah, is Dr. Satish. Yes, Satish.
Yes, boss.
Ready?
Yes, yes.
Okay, okay.
So basically, this is a case of safe chronic suppurative otitis media, having a central perforation, some temporal sclerosis probably. And since CT was done, I was just going through it. Though in safe otitis media, it is not mandatory to get a CT scan done, but it gives you certain information. You see, in CSOM, the kind of information, CT temporal bone has to be looked differently for different pathology. Like for atherosclerosis, For cochlear implant, we look at differently for different information. Here, in a safe otitis media, what all positive information we can get out of this is, see the ossicular chain looks intact. Can you see?
Yes, yes.
See the stapes? See the stapedial arch?
Yeah, we can see, boss.
The incus and the malleus.
Yes.
The atic looks clear. And the only thing is this editus and the, antrum has opacity, could be blockage, could be mucosal blockage, could be temporal sclerosis, fibrosis. You cannot differentiate, but there is something giving the picture of mastoiditis. See this?
Yes.
So the mucosal edema is definitely there. And that is, that substantiates our proposal. What we always do is to explore the mastoid to see the editus patency, which we are going to see this in this case.
Yes.
So we are going to do a tympanoplasty. We call it middle ear cleft reconstruction. Looking at eustachian and tube, middle ear, grafting the middle ear, seeing the ossicular chain, then opening the mastoid to see the patency of the editus. So because all these cells is aerated down the eustachian tube.
Can you tell the facial nerve course on this once?
Pardon?
Facial nerve course. Facial nerve.
Yeah, facial nerve course looks good. Let me show you. See, this is the intra-auditory meatus. This is labyrinthine segment. Can you see?
Yes, we can see the first.
Yeah, you saw yesterday this labyrinthine segment in relation to this. This is basal tongue.
Yes.
See, this is superior to inferior.
Yes.
I am going, this is axial cuts, superior to inferior. See the first appearance of the basal tongue.
Yes.
Can you see?
Only labyrinthine.
And see the relationship with the labyrinthine segment of the facial nerve. Yesterday, I showed you this upper basal tongue. This is uppermost as we are going upside down. This is the uppermost part of the basal tongue. How it is in close contact with the labyrinthine segment of the facial nerve. Then this is first genu. This is the horizontal segment of the facial nerve. Can you see?
Yes.
This is the second genu. Medial is the sinus tympani looking clear.
Yes.
And then you can follow this now right to the stylomastoid foramen. That is the stylomastoid foramen. See this facial nerve. So this is how you can see the facial nerve. So basically this is a perforation with mastoiditis. It looks like could be mucosal hypertrophy or whatever in the antrum, maybe editus blockage. We'll explore that. The ossicular chain looks intact, so we'll require only tympanic membrane grafting most likely. So this was just to, since we were having CT scan, so I went through it. Otherwise, the situation is straightforward. Do we go ahead?
Yes, boss.
So our protocol will be the most likely the same one. Let's see the perforation for the internal tympanoplasty.
Okay. Facial nerve बहुत thick है इस केस में. ये क्या दो लोग
तो बहुत छोटा ही था, मेरे पास तो वो एडिशनल लिफ्ट बना होता है, तो ये एक ही करता हूँ चिंता नहीं है।
Yeah, we are getting the microscopic picture now.
Analgesic भी तो है,
So you are
analgesic भी तो है.
hello, sir.
कभी आप लोग क्लोरीन यूज करते हैं फर्स्ट में?
We are getting the endoscope microscopic picture, boss.
चल रहा है क्या, पिक्चर जा रही है?
Yes. Hello. Yes, we are getting the microscopic.
Hello.
Hello.
हेलो,
हाँ जी सर. Sir.
हेलो.
Hello, Satish boss.
आई उधर जा रही है आवाज. Yeah, yes. Are you getting the picture?
Yes. Yes.
Okay, I thought you are not getting. So this is a large perforation. You can see.
Yes.
I have just made the margins raw. Those are a part of the any tympanoplasty procedure to facilitate healing. Though the technique which I am going to show you the interlay, wherein we are going to separate the tympanic membrane into layers. Dr. Karnal already started this case and he has already harvested the graft as well.
Okay.
So my standard flare for tympanoplasty is, see this, that's the superior margin of perforation,
Yes.
posterior superior margin.
Yes.
Hello.
Yes, boss. Can you just focus?
Hello.
Hello.
Hello, am I audible?
Yes, sir.
Hello.
Yes, sir.
See, my incision is few millimeters above the posterior superior margin.
So can you focus that?
Yes, is it not focus?
No, I will centralize it, sir. Just.
किधर आ रही है पिक्चर आ रही थी? Let me know when it is centralized now.
Yeah, it's okay now. No.
Okay?
Yes, okay. Yes,
Yeah.
sir. Can you zoom out a little, boss?
Zoom out.
Yeah, it's okay then, right?
Yeah. So this is the superior margin of the perforation. See this? This is my superior incision few millimeter away. Can you see?
Yes.
That's the inferior margin, and this my incision is not reaching up to the annulus. Yes, because I need to make it circumferential few millimeters lateral to the annulus to do interlay. Interlay means we'll separate the tympanic membrane into layers.
Yes. So we can see there is some TS plaque also on the residual TM.
Maybe we'll see.
So please centralize the picture.
See, once we separate in that plane between the mucosa and fibrous layer, if there is any TS plaque, will automatically come into picture.
Yes.
That is always in that layer. With this?
Yes.
And now I will circumferentially convert this to elevate the entire tympanomeatal flap. See this? This anterior flap a little relatively thinner. So this is an important procedure for our junior colleagues.
Yeah, very, very thin anterior flap.
Yeah, you can quickly, stay bang on the bone. See, I can reach out to the level of annulus in no time.
Yes, we can see the glimpse of annulus there.
See, to the level of annulus. That's the annulus. See that?
We can see now, yes.
Yes, sir. Focus. Actually, I don't have a screen here, whether that is good for you or not, for how the focus is going. Now coming anteriorly. This anterior superior incision is going to go few millimeters above the anterior superior margin of perforation. So that my incision and flap will be everywhere beyond the margins of perforation. See that?
Yes, yes, sir.
See, no time it has been raised.
Absolutely. So you have joined with the incision superiorly?
Not join.
Okay.
In case required, you can without any problem.
All right.
Now, do I increase the magnification?
So centralize the picture and focus.
Yeah. How is this magnification?
It is good, sir.
Too much?
It's little too much here, boss. Focus.
Okay, with the right angle. Okay, let me reduce. Now. Is this fine?
Better now. Picture is blurred, somewhat blurred.
Blurred?
Yes, sir.
Mine is clear. See, this is inbuilt camera in the microscope. You can't do anything, but I have a good picture here. Really, is it blurred?
No. It's okay, boss.
Okay, see, this is the annulus entering inferiorly.
Yes, we can see.
I have my, right angle hook. See this?
Yes, yes.
And elevate leaving this mucosa below.
Absolutely.
Can you see?
Brilliant, boss.
This internally means elevate this mucosal and fibrous layer. This annulus is condensation of the fibrous layer.
So, you have this blunt right angle pick, no?
Yeah, not exactly right angle, but yes, blunt angle hook.
Curved hook, okay.
This is for this purpose only. See some tympanosclerotic plaque coming?
Yes.
See this?
Sir, थोड़ा focus हल्का सा. Yes, sir. Better, sir.
See this tympanosclerotic plaque. If there is any tympanosclerosis, will automatically come in this layer. And see, this is anterior superior tympanosclerosis. No other technique would give this access, this good access to the anterior superior plaque. You have full access to the anterior superior region. See this? Can you see this plaque?
Yes, sir.
And you can remove it easily. See this? Sir. See this. And see this. Wherever is tympanous sclerosis, you can remove it. Simple. And yeah, that is the final tympanous sclerosis.
Yes, sir.
Can you see?
Yes.
Now, if I deposit everything back into the place, see the picture. I have separated inferiorly, anteriorly, anterosuperiorly. Only the posterior part is left. See this?
Yes, sir.
See, this contains two layers except the mucosa. Circular. See this? Annulus. So you have to literally peel this annulus off the mucosa. You are not supposed to cut it. See this? See this? Peel this annulus.
So little bit focus required.
Again, some focus is required.
Yes, sir.
Let me see this.
Yes, sir.
Because here the microscope is not in my control. See this tympanostatic plug behind as well?
Yes, boss.
See, wherever tympanostatic, it is going to come in the same plane. So, we can't leave any tympanostasis behind with this approach. If it is going to come in the way. You see this?
It's a little bit centralization required.
Centralize? Okay. I evaluated all over. See the ossicular chain I am focusing at.
Yes, yes, sir.
Some tympanous sclerosis on the promontory as well.
Yes, yes, sir.
Yeah, see the mobility of the stapes.
Yes, sir. Yes, sir. Very well seen.
So by and large, we have elevated the circumferential flap. We have separated the flap in layers. The two layers we have elevated. See this?
Yes, sir.
And the mucosal layer is left behind as a bed. As a bed for the graft. See this? And in between these two layers, we are going to place our graft. I hope it is clear.
Yes, sir. Sir, if somehow we don't remove the, we also remove the mucosal layer, not, we don't do the interlay, then how much advantages or disadvantages is that?
See, interlay means you are placing your graft in between the layers.
Yes, sir.
So it divides all the complications of underlay and overlay, number one. Underlay, your graft can fall, all that, nothing is going to happen as it is between the layers.
But central,
only all those complications of, only your graft can, you can leave the epithelium behind, all that can be avoided. So all the complications of only and underlay are avoided, and you place your graft in the most physiological plane between mucosa and the fibrous layer. Yeah, how to focus? For me, it is focus.
sir, it is focused now, but it is not central.
अच्छा पीछे आ जाएगा. अच्छा. Now I can see behind.
Yes, sir.
Better now?
Very well, sir.
So now two things are left for me. Though the physiological patency of the eustachian tube is ascertained to certain extent by the temporality test, you can assess both the ventilatory function and the mucociliary function of the eustachian tube. See the eustachian tube there?
Yes, sir.
Can you see?
Yes, sir. Yes.
Flush. Here what I can do, because in long-standing perforation sometimes we may have foreign body walls because of the infection, because of the mastic use, whatever. So I can flush it. Simple. You have checked the ossicular chain. Dr. Khanna has already harvested the graft, but generally in my practice, we harvest a fresh graft immediately before the surgery. Immediately before the need, bed-to-bed grafting. But anyway, you can use the wet graft also. You have harvested, but you have kept it wet. So now the most important thing coming to ascertain is the patency of the editus which is required for radiation of the mastoid hair cells. See, if we ignore this fact and graft, it may result in failure. Hello?
Yes, sir. Yes.
So it is always better. This is one of the most rewarding surgery, and we should do all this to, rule out any possibility of failure. It doesn't take time. If it is not blocked, you will find patency so early.
Sir, please zoom out a little bit. Yes, sir.
Okay?
Yes, sir.
So if it is not blocked, you will find the patency so early. My landmarks are same. To the spinal anteriorly.
Sir, thoda centralized, sir.
The inferior temporal line behind.
Yes, sir.
Still not found any patency. I am planning to go deeper. See the thick mucosa inside.
Yes, sir. Yes.
See no patency. So now this is a great case to show how to achieve the patency.
Yes, sir.
I am going towards the editus. Anterior superior towards the editus.
Yes, sir.
At the same time filling the canal. Now in this situation, suppose if you graft with this blocked editus, then it may not be a successful procedure.
Yes. And it is a great case because both the ossicles are intact.
Yes, now you have to achieve patency.
Yeah, with the incus in place.
See the simple sclerosis.
Yes, sir. Yes. It is sigmoid sinus, sir?
No.
No, that is bleed.
See diamond energy. See this see this little lateral oozing, what you can do? Okay, the dry diamond. See when the dry diamond is cut. See the oozing stop?
Yes, sir.
Do the cutting. Now I will slowly reach the level of the editus. See such a thick mucosa.
So basically it's a tympanosclerotic disease, boss.
Yes. No.
Can we assess tympanosclerosis on CT before the surgery?
No, tympanosis cannot be differentiated on CT scan. CT scan, all opacities are same. You cannot differentiate into soft tissues with CT scan. Take the diamond image. See this little easy laterally?
Centralized a little bit.
Now?
No, sir, it is gone. No, sir, it is not in the center.
Oh, yes. Now?
Yes, sir. Little focus, little fine focus. Yes, sir.
Now see, this is the level of the lateral canal. Slowly go anteriorly. Keep going anterosuperior and anteriorly into the canal.
Sir, what is this bony hair?
Some abnormal bone. This is some abnormal bone. लंबी है ना बस.
Incus has not yet come, na?
No. This is some abnormal bone.
There's little bit of fine focus required.
Little bit of fine focusing.
Yes, sir. Yes, sir. It is good now. It is very good.
So I will reach to the editors, will see the incus. चलो मेरी यार. घूम रही है बस. Dangerous. पटकी देना है. You can compare the level on both sides.
Yes, sir.
अरे गाइड अंदर नहीं जाती यार, गार्ड है इसका. You have to completely clear the editors. That is the challenge.
Sir, if there is some doubt from the posterior approach, can we go from the anterior part of the attic into posteriorly inside out?
क्या कर रहा है यार? चलो Yeah, anteriorly there are indirect ways, you know. A lot of people try the endoscope to look at the editors of patency, but you know, see there was a tympanoscopic clot behind. Your endoscope could have easily missed.
Okay, sir.
So all those are indirect methods, not direct ones.
No, sir, drilling the posterior superior canal from the inside.
Yeah.
We can.
But you can't see beyond the editors then.
Yes, yes. So from both the ways, if we can drill from inside also and from
I may require a drilling from inside also. I may require drilling from inside also. पतला भी नहीं. क्या चक्कर होगा मैं ड्रिल को लगा लो. Keep thinning the canal. Keep thinning the canal as you go anteriorly. See this?
Yes, sir.
See the thick mucosa. And I got the patency. I will widen it further. Look at thick mucosa.
Yes, sir. Yes.
Patli paper. What the patli do? This is the bony, obstruction, laterally and then mucosal hypertrophy. See this mucosa?
Yes, sir. Yes.
Now it is patent,
Yes, sir.
but I will get a free flow. Yeah, now it looks like a free flow coming. I can see the mood.
We haven't yet seen the incus, right?
Yes. Even I have not seen, I have not focused. I am still far behind. Top section was far behind only. See this? See this?
Yes, sir.
This is the area behind the editus. Now watch there. And there was a thick tympanostotic clog which was blocking it, which I removed, and I got the, see this?
Patency. Yes, sir. Yes, sir.
I will show you the free flow. See the free flow. So this is the same level?
Yes, sir. Yes.
See this?
Yes, sir. Yes. Centralized,
that is free flow. And see the most importantly, this mucosa in the floor of the editor.
Yes, sir.
Is
Yes.
good. Intact.
Yes, sir.
If I remove this bone, my incus is here.
Yes, sir.
Yes.
Can you, sir, show us that?
So I need to drill this bone, see this glimpse of incus here.
Yes.
Let me, no need to remove, since we got the patency, no need to remove.
Okay.
But that is a glimpse of incus.
Sir, sometimes when there is no ossicle, there are no ossicles, and we need to achieve the patency. So, what is the landmark for that? How much drill should we should drill?
Then there is no ossicle, then there is no problem. Then there is nothing to, damage. When there is no ossicle, but just follow the lateral canal. Stay in the floor of the lateral canal.
Yes, sir. Yes.
And just go ahead. Once the ossicular chain is intact, you are frightened to damage the intact ossicular chain. See my perforation? See my perforation?
Yes, yes, very clear.
Yes, sir.
See, everything clear?
Yes, sir.
Now is the time for grafting. See the ossicular chain there. Again, see the patency, integrity is good.
Yes, sir.
ये cotton ball कर रहे हैं. Now the final time is for
Sir, one question.
yes, please.
Sir, any tip required to prevent the facial nerve injury while looking for editors?
Yes, that's the important thing. So the best thing is stay close to the tegmen.
So can you show it in the mastoid region?
See, stay close to the tegmen. As you stay close to the tegmen, you are high up from the lateral canal.
Yes.
If you are not oriented, your drilling is inferiorly directed, you can injure the lateral canal and the facial canal. And we have got couple of cases also where the facial nerve is injured during this procedure. So be careful. The only point we always tell is stay close to the tegmen.
So drill anterior superiorly close to the tegmen.
Yes, always close to the tegmen. That is the bottom line. If you stay close to the tegmen, nothing is going to happen.
Sir, fine focus.
So now I am just looking at the bed, if any oozing or something, so that we can graft further. Give me a cotton ball, small oozes there. I don't want a ooze to be there for a hematoma to form between the flap and the bone.
Second, Bell's palsy during unrecovered facial nerve palsy. Which part do you decompress facial nerve?
See, in Bell's, if it is a proper Bell's, it is mostly the labyrinthine segment which is, compromised.
Okay.
And without decompressing the labyrinthine segment, in case you are operating, is a joke. Now, in order to see the labyrinthine segment is always a challenge.
Yes.
From the mastoid side. But your CT scan can tell you whether it is accessible from the mastoid side or not. CT scan will tell you how high the tegmen is, how the facial canal in relation to the tegmen is, the labyrinthine. In favorable condition, you can access through the mastoid side. And secondly, if your semicircular canal is coming in the way, because superior canal is something which is the obstacle if you go from behind, you can come from anteriorly by the transzygomatic approach.
Okay.
Same thing to the canal. Rather than I am sitting behind, I have to come from anteriorly. So my superior canal will not come in the way.
So no need to decompress the vertical part.
No, that is never a culprit. And if it is unfavorable, then you have to go by middle fossa approach.
Okay.
So now the final part we have reached, that is the grafting. In interlay, the grafting is never difficult because you have to spread the graft on the bed. Finish graft? Hello?
Centralize the picture, please, sir.
Not centralize? Yes. Just a minute.
Yes, sir.
So this graft, first is advancement. Advance anteriorly adequately to come over the intercanal walls. This?
Yes, sir.
Push it underneath the malleus. See this?
Yes, sir, yes.
And thirdly, spread on the canal.
Yes, sir.
Edge to edge. See that?
Yes, sir.
Now reposit the posterior part. Only posterior part.
Okay.
This posterior part you can make 1 unit, the graft and flap. They become 1 unit by surface tension. See now?
Yes, sir.
So now whatever manipulation you do anteriorly, it is not going to.
That is why you use wet graft or fresh graft.
Yeah, to take the advantage of surface tension. See now?
Yes, sir.
Now elevate the anterior flap. Elevate it completely and take your graft right on the bed. See? Place it on the bed like this.
Yes, sir.
Place it thoroughly on the bed and deposit your anterior flap.
Sir, you push it inside the annulus area?
Yes. Once I place it thoroughly, then we'll tighten from the periphery. Okay. See this?
Yes, yes. So the instrument which you are using, what is that?
A simple TM repositor, blunt one.
Blunt TM repositor.
See this? Everywhere.
Yes, sir.
My graft is between two layers.
Yes, sir.
See these two?
Yes, sir.
See, I don't keep anything in the middle here.
No gel form, sir?
No, never.
Okay.
Why to unnecessarily block the pathway to the aggregators? See the posterior layer? Similarly, you can check all the layers. See this graft? Graft and flap. See this, elevate this graft and flap. And this is mucosa.
Yes, yes.
See, this is the blood which I don't want.
So what's the post-op protocol after a tympanoplasty? Like for how many days you advise antibiotic, ear drops?
See, whatever is going to happen in initial first 10 to 14 days.
Okay.
It will set in. Till then, you can give broad spectrum antibiotic. See this? Completely under vision setting. See this graft?
Yes, yes.
Anterior superiorly also you can elevate and check. Everywhere the graft, see this graft? Graft is behind the flap and the mucosa is there. See this?
Yes, yes.
You will deposit these two units over the mucosa. Simple. So now the grafting becomes the simplest job. Because you have a bag there. Tighten at the periphery, what you are asking. See this? Tighten at the periphery. And now I have this, what I will do now. See again, if I elevate, see this graft?
Yes, sir.
This graft is sandwiched all around between the layers. And see, this is the middle layer space. See, this is mucosa over which the graft is sitting. See that?
Yes, sir.
So my graft is sandwiched between two layers above and the mucosa below. Okay?
Yes.
And finally, I am going to use some gel foam. I will mix this gel foam in the blood available in the field. First in the periphery. Periphery to the important areas. Antero-inferiorly, antero-superiorly. See that?
Yes.
Again, check your middle ear space. Final. See this good? See this?
Yes, sir.
Just I am placing at the periphery. This is advancing epithelium.
See, thyroid. So, one new concept or new surgery like total annular excision with T-plasty. What's your opinion?
Yeah, so that is the same idea. The idea behind that is the problem with mucosa. See, in underlay or any other technique,
Yes, yes.
if you leave the mucosa above the graft, that can keep on weeping, invite infection and post-operative troubles. So in order to prevent the mucosa, ensure that mucosa cannot come, the entire annulus along with the containing membrane is excised and the canal skin then comes over the graft. So this is again a technique to 100% ensure that the mucosa doesn't come. But that is a, lot of change in the physiology. This is very well popularized by Rohan, Dr. Suri Prabhu, Sudeep,
Yes,
a lot of
yes.
people are doing
Yes.
and claiming good results. I don't know with so much of physiology change with annulus removed, how are the long-term results going to be? But since they are doing, must be good. So there we go.
That's the best.
Wonderful, sir. Thank you.
So this technique is, since we endorse their concept that the mucosa should not come above, and in interlay same way, a graft is above the mucosal layer all around. So mucosa cannot come, and we find this is more physiological. We have done thousands and thousands of cases with amazing results. So no doubt about it. Still we are open.
Then Dr. Satish, do you wait for ear to dry before operating?
Not really, unless there is some acute fulminating infection.
And if some granulations are there, then
Some, discharge, but not looking like fulminating one, some mucosal discharge, all these things are not contraindications.
So what about automycosis? Like if we encounter automycosis, after how much time can we operate that ear?
Yeah, after a few days, what you can do, you can apply an antifungal pack for 4 or 5 days,
Okay.
and then you can do. Because what we pack in the canal here is the ciprofloxacin steroid combination.
Okay.
And we don't want to use this in already fungus there in canal. And it works very, you can put some quadrigram or something pack for 4 or 5 days. It takes care of fungus, the canal becomes dry, then you can.
Okay, sir. Very nice.
But mild inflammation, mild mucosal discharge are not contraindications, rather surgery helps in eliminating that once you open up the adductors. And give antibiotics later on.
and how to deal with the post-operative weeping?
Post-operative?
Weeping canal.
Many ways, first of all, culture-directed antibiotics. If granulations, then you have to cauterize them. You can pack with a steroid antibiotic solution. If it is fulminating infection, you sometimes pack with manuka honey. It works like magic. So many ways. It depends whether it is infected or not.
So do you use any dry preparation to pack the ear?
Yes.
Powder?
Yes, Neosporin at some time. There is minimal overall generalized inflammation in the canal. Then apply.
And left for how many days?
We leave and start eardrops over it.
Okay.
Sir, is the Manuka honey which is now available on Amazon, is that of any help or is it useless completely?
You have to buy from New Zealand because that is not medicated honey.
Okay.
On Amazon is not medicated. It is quite costly. You have to buy from New Zealand. It's amazing antibacterial. Wherever the infection is not coming under control, you apply Manuka honey. Lethal to any bacteria. Bacteria, fungus, whatever. We use extensively mucotimes also in the cavities.
And what about Castellani solution, which is very well marketed by Mumbai?
Which one?
Castellani solution. Castellani solution. It is phenol and very much used by our Mumbai colleagues.
I have no idea. Earlier people used to use
It's a violet color solution.
earlier people I remember used to use aluminum acetate solution.
There is a question from audience: how to accelerate the epithelialization of the mesoid cavity?
Epithelialization. See, if the cavity is adequately saucerized, good meatoplasty, and no infection, it epithelializes fast. If anywhere is problem in the surgical quality, in terms of not adequately concentrating the cells, high ridge, narrow meatus, all those issues on infection, they always give problem like a persistent discharging cavity. So once you are doing a canal down, it has to be a adequately well done canal down. Excentrate all cells, give a good meatoplasty and all that, not leaving the raw area, rather put the vascularized tissue from behind. From behind the ear, there is a lot of vascularized tissue. Rather than leaving a bare bone in the cavity, bare bone is going to invite infection.
So any role of acetic ear drops in post-op for?
Ear drops are better in cavity. You can pack on antibiotic ointments. That is much better option to keep in place for some time.
Okay.
Ear drops, they come out easily. They don't work much.
Thank you. Thank you, sir. Wonderful.
Now people are using mometasone cream for red angry canal walls.
Yes, steroid. So you can use antibiotic steroid combinations also.
Okay.
The Neosporin H has an antibiotic as well as steroid. And the best part is it is effective against Pseudomonas.
And sir, what about using vinegar?
Yes, that is also. So we use in cavities, I forgot to tell you, in cavities to wash out the cavities, to give patient 1-2% acetic acid and ask them to rinse the cavity. And it works very well because it acidifies the entire medium to prevent bacterial growth.
Yes.
So it is very good. Or like you have a mastoid cavity, not very angry, not very infected, yet to heal, little bit inflammation, which can acquire infection, it is best.
To wash how,
we tell patient to rinse the cavity, fill up the cavity completely, lie down, fill up and then rinse after a minute or so, twice a day.
Okay.
It is very good. And it somehow, I don't know, it helps in epithelialization also because it is irritant.
Okay.
And sir, one more thing, any tips to assess eustachian tube functions pre-operatively, like tympanometry, any tips for
Yes,
that?
in perforation, yes, it is always good to assess to prognosticate. See, there are two functions of eustachian tube. One is ventilatory, another is secretory. Mucociliary function, sorry. So ventilatory function means almost every minute, every other minute, the eustachian tube opens and drives the air in the middle ear. That air in the middle ear is absorbed by the mucosa, the blood in the mucosa, and as the blood is absorbed, constantly the pressure is decreasing, normally, in normal physiology.
Yes.
So, every time as the pressure decreases, eustachian tube drive air. The pressure decreases, eustachian tube drive air. That's the normal physiology. And every time when the eustachian tube, pharyngeal end pumps, the air contained in the isthmus is driven inside. So that is almost 2 microliters. That's how eustachian tube opens 1,000 times a day almost, and 2 ml of the air is delivered every day in the middle ear overall.
Yes.
That 2 ml air every day is vital to the optimal functioning of the eustachian tube. Now, how can you assess this? Tympanometry. You know, tympanometry, you seal the extraaortic canal with a probe. In a perforated ear, the middle ear is now communicated to the exterior only by the eustachian tube.
Yes.
Now, you raise the, tympanometry pressure by the pump, or raise or reduce whatever plus minus 400, whatever extreme pressure, and ask the patient to swallow. If the eustachian tube is adequately functioning, with every swallow, the pressure will equalize towards the normal side.
Yes.
If it is positive, it will come down towards zero. If it is negative, it will come up towards zero. So with every swallow, eustachian tube should open and neutralize the extreme pressure.
Yes.
Now, if it is adequately functioning, it will neutralize. If it is malfunctioning, it will not completely neutralize in spite of repeated swallowing, multiple swallowing. If it is non-functioning, there will be no change.
Yes.
So at least you can have idea that your second tube is absolutely non-functioning.
It's a wonderful practical tip which everyone of can follow.
Yes, you can prognosticate. Patient will ask you, how will my surgery fare in the post-op? Nothing is in your control because whatever surgery you are doing is a mechanical procedure.
Yes.
The physiology of the ear is something you have not seen. There are a lot of nasal causes, second tube causes you have to rule out to,
yes,
prevent problems.
So recently, Dr. Paga Bichi has come up with eustachian tube catheterization from middle ear. Have you heard this thing concept, sir?
That is mechanical patency.
Patency, yes.
It is the physiological patency which is required, not mechanical.
Also, is there any role of that?
Mechanical opening of the eustachian tube is never something useful. It is the physiological functioning of the eustachian tube which is important.
Okay, thank you, sir. Thank you.
तो सतीश भाई ये जितने एटिलेक्टेटिक टेम्परिंग मेम्ब्रेन आते हैं एडेसिव टू एटलीस्ट मीडिया होता है ये सब में इज देयर इज एनी रोल ऑफ यूस्टेशन टू डायलेटेशन आजकल नई मशीन आ रही है मार्केट में
मशीनें बहुत आ रही है but they will not be useful always.
Then what to do in those cases?
So those dilate the cartilaginous eustachian tube.
Okay.
They go up to the isthmus, the dilators. With unpredictable outcomes. You dilate and leave it. Now what is going to happen, you never know.
Then again we will do your test, whether it is.
So the natural physiology of the eustachian tube, but we are certain with that.
Okay.
I told you that 2 ml of the air driven every day by more than 1,000 time openings is the key to the optimum medullary functioning. So it is like our lung and trachea. The middle ear is like a lung and the eustachian tube like a trachea. So this ventilatory function is very important.
Sir, so can be Valsalva is useful to maintain this air entry to middle ear cleft?
That can be useful for the time being. You cannot do Valsalva 1,000 times a day.
Then what you advise to your patients who are having this kind of atelectatic tympanic membrane or with adhesive otitis media?
Give them, rule out the nasal cause first of all, why eustachian tube has gone malfunction, mostly nasal causes. Many of these patients have allergies, sinusitis, so many patients have cleft palate, so many other issues, adenoids, this, that. So that is the indication for ruling out the nasal cause, number 1.
Okay.
Number 2, only thing what we have seen which works is the decongestant and steroids, topical steroids. So we advocate the nasal sprays for long term. You can call them again and check the function. If it improves, then you can go ahead.
Okay.
Or sometimes you go ahead, graft, it may work. It's not absolute contraindication. It may work, but it may not work in long run.
So in these cases,
the negative pressure can develop later on.
So in these cases, we can use sliced cartilage in place of regular temporal fascia graft.
No, that is never.
That will give more strength for retraction.
See, if the negative pressure is developing,
okay,
the tympanic membrane is retracted. The tympanic cavity has what? Laterally is the tympanic membrane.
Okay.
And medially is the membrane is round window. If you put a bone laterally, forget about cartilage, which cannot retract.
Yes.
What will happen with the negative pressure? If that patient is subjected to extreme negative pressure, the tympanic membrane God has created to combat the negative pressure. You know?
Yes, yes.
How the tympanic membrane is combating? Like, let me give you an example. You send the patient to an extreme pressure change environment.
Yes.
The tympanic membrane becomes retracted. It becomes taut. The radial fibers are most important to make the tympanic membrane retracted, taut, and make the ossicular chain immobile.
Yes.
to prevent any further sound transmission, any further pressure change. And almost, beyond 400 millimeter of mercury, the tympanic membrane becomes like a wall. It cannot change.
Right.
It cannot retract further, it cannot do anything, and it can rupture afterwards. Now, if you have made the lateral wall, that is tympanic membrane,
Like a
bony,
Yes.
anything which cannot, even move for a micromillimeter. Extreme pressure change in the middle ear, what can happen?
It will burst the round window.
Yes, round window can rupture, it has been reported.
Okay.
So don't think that cartilage slicing will prevent the pressure solution.
So in your
mechanical solution cannot be an answer to the physiological problem. Aeration, whatever you do in the ear, you do ossicoplasty, whatever, the optimum functioning will be when there is aeration.
Sir, so in your practice, you don't use cartilage in tympanoplasty.
I am not saying that. But don't think that you are using cartilage as a savior for everything.
Okay.
You can put a cartilage as well as grommet both, so that aeration should be.
Thin cartilages people are using as a graft material. I am not against it. Thin, very thin slice cartilage. Those cartilage survive, like a vascularity longer.
Okay.
So, and it works. It doesn't mean that it is the solution to the pressure problem.
And so in case of revision tympanoplasty, you use fascia again or cartilage, you put a slice, small cartilage, then
No,
fascia.
the fascia is good. See, if your physiology, underneath physiology is working good, fascia is excellent.
Sir, grommet insertion is an answer for eustachian tube dysfunctions cases retracted drum membrane.
Time being, yes. So you are introducing a new tube.
For middle ear cleft ventilation.
Yeah, ventilation. That's why in children, it is so important to say, put a tube, converse procedure. Whenever there is, you find any evidence of lack of aeration, fluid or anything, put a tube.
सर नेक्स्ट केस क्या है अपन उसके बारे में डिस्कस कर सकते हैं सर.
Yeah, next is, let me ask, thyroid. Thyroid, I think. Let's go.
कैसे बचाएं?
आपको आराम नहीं करने देंगे.
I think just as a filler. क्या हुआ? यहाँ से कुछ हिला है। कुछ हिला है। अच्छा निकल दौड़ना पड़ता है। बोलो। ठीक है। So, you want quiz? Quiz करें? We can continue same do's and don'ts in ENT. We're just pointing out that you should never rely. Means you should rely on a staff, but keep watch on them regularly, like how they are scrubbing themselves, how they are cleaning the OT, how they are preparing the patient for the surgery. Like this, I just told you, this video is taken by me, and just let me know what exactly something is going wrong over there. Dr. Neha. Yeah. He was doing his job, but totally he was going from his opposite periphery to central areas. So you have to keep watch on staff, whether they are, even if you are there, medical, non-medical person, but keep watch on them for regular thing. And like few steps about the surgical steps, like today Dr. Satish shows us. क्या बंद कर रहा है? Okay. Always do, like if you're doing opening the mastoid, if you're not opening the mastoid, because there's concept whether few people open the mastoid in all the cases, or few not, but always do patency test. And there are so many ways to do it. If you open the mastoid, and if you're not able to clear the water, there's so many ways. You can use the cotton plug, you can use the gel form, but satisfy yourself before closing, before putting the graft in such cases. And it is one of the way, like using cotton. And one more way is that if you're not opening the mastoid, take a right angle and push the water lateral to the malleus incus, and just see from where the water is coming out. If it is coming very easily from the putting water from lateral to incus and coming out middle to incus, then it means that your mastoid is okay. So if it is well supported by the X-ray before, it is pneumatic mastoid and the water is coming out, then there is no need to open the mastoid in all the cases. And this is a very important time. Remove each and every bit of mucosa from the malleus handle, or because if you putting a graft underlay by underlay technique or overlay technique, you're putting graft lateral to malleus, but each and every bit of mucosa should be removed from the malleus. Otherwise, later on you can get some pulse or some whipping ear later on. So these things you have to keep in mind. Now what is it? Again, the same one. Try to have this in the long-standing cases. Our malleus get medialized because of the negative pressure, because of retraction by the ligament. So before putting the graft, try to lateralize it, so get a better medial space, and then put the graft. And that this is I think many people are doing now, and this been taught by Dr. Indorwala sir. His technique is different. He used perimeter approach, but the one point which I liked most was the putting the graft, making a sleeve in it and putting through the malleus. And so just tuck your graft under the malleus and give your 360 rotation covering. That improves your, you can say, result output, and even a chronic infection, a post-operative infection can be well managed by, can be prevented by this graft. So a strong tucking of the graft by the malleus is one more option. You can do it. There are many ways of doing osteoplasty, but there is controversy about using the homograft, means 70% alcohol preserved graft. But since I am using since many years, and I think Dr. Omi Singh sir is there, and so many people, they are using since 15, 20 years. Till date, I think we have never seen any problem in such case. So you can use preserved cartilage along with your, there are so many techniques or so many ways to do the osteoplasty. But I think it is a way you can use it. You can take autograft also, no problem. But I think this preserved cartilage is not an issue. This is not an issue. Some legal issues are there that you have to keep in mind. This, if you saw the interlay graft today, or if you're even doing underlay graft, but main point, because the issue comes after a few years of doing the surgery, like they get a pulse over there, some discharge from the aortic area, discharge from the grafting area. So always try to preserve that we call it golden medullary mucosa, and you have to preserve through all around. So once you put a graft over there, you get a well vascularized, well supported graft, and the chances of healing are very good, and your you can say acceptance rates are very high if you follow all these things. If you're doing hysterectomy also, you're doing malleolar hysterectomy, never try to put a graft if you have a secondary perforation, you're doing flap elevation. So try to put a graft or a cartilage, slice cartilage between your piston, whichever piston you are using, and your flap or graft over there. Never try to let the piston come in contact with your cartilage and your flap. Otherwise, you will get a beeping ear. There are so many issues do come later on. I will share with you right now. And this is one more important thing. If you have taken out the incus, like this incus is not healthy, and your malleus, before putting the graft, your malleus get, you can say, rotated anteriorly. So before placing the, you can say, graft, always try to visualize it and keep it in the proper position. So later on, your cone of light, your shape of the cartilage, your graft become normal. Few more tips like this that I always. Okay, this is one more thing which I have noticed, and in my personal experience before. That I always share. You see, sometimes you get a chorda over there. You see lots of granulation tissues along the chorda from its origin till its disappearance in the aortic part. So always just make it high, make a higher magnification. Try to remove these granulation tissues from the chorda without damaging, without retracting it, without pulling it, without pushing it. So these granulation tissues can create problem later on in your graft, in your post-op healing. So try to, without retracting it, without making any pressure on it. Just see, this is a recording, and some granulation tissue were there. Malleus incus stapes are intact, mobile, but something is wrong, is going over here. What exactly is the surgeon is doing wrong over here? He is trying to remove some granulation tissues or some sclerosis from this, and the mesh is intact. The incus is well attached to the stapes. This hypermobilization of this mesh is very, very risky and can lead to some SN loss in post-op period. So always try to dislodge your incus from stapes, then do your manipulation, then you deposit it back. So this intact misses and mobilization, excessive mobilization of miss is not good for your for the patient because it will lead to SN loss. Like we do the fascicular movement test in all the cases, and we can sometimes find that malleus incus stapes are not moving. So always, like Dr. Satish just mentioned now, because we should always open the mastoid in such cases and try to find out. Like in this previous case, in many of the cases we get some patches over there, sclerotic patches in the attic area, which are responsible for this impaired mobility, not the stapes or not the this thing. So always look for the malleal ligament also, attic area. Try to rule out as much as possible until we are very much satisfied with where exactly is the cause of this immobility of the ossicles. Now the things are clear. So what exactly? Okay. This was the case. I think when you drill out in very granular tissues with lots of infective mastoid cavity. So few things you have to, and it can happen to anyone, but never keep patients, keep gel foam in your open theater, keep surgery cell in your OT, always keep a surgery cell because these are the cases, you have nothing to do. Just keep it press over there, but surgery cell is the best material to surgery cell as well as gel foam. Keep it over there, give 4 to 5 minutes. By chance, my recording was on. That's why I just got it over there. Otherwise, it happens in many of the cases. In this, I think case, it was a case of some cholesteatoma. So recording was on. Just I kept surgery cell, followed by surgery cell, followed by surgery cell, followed by gel foam, and then finally, it took hardly 3 to 4 minutes, 4 to 5 minutes to control it. So if you're doing mastoid and mastoidectomy in chronic cases, it is going to happen, and never lose patient, never call. Means you can inform your senior, but you can do yourself. It is a very simple thing. Drill it out and keep it bone wax over there. So real time was hardly 3 to 4 minutes, and hardly there was loss of 50 to 100 ml blood. But bone wax is safer. You can take out the bone wax after doing the surgery, no problem. And while doing so many surgeries, Shiva, OT. Ready? Not here? कुछ तो कुछ लो रेडी यहाँ पे Okay, those who does this stapes regularly, again in learning phase, always take a proper flap length of 3 to 4 millimeter. 4 millimeter length is best. Otherwise, by chance, if you take a bigger length, bigger flap length, it will create problem during manipulation, during surgery, especially in stapes, and the things. So take care of proper length, flap length of 4 to 5 millimeters is maximum recommended. And if you are doing permeatal approach, many people do postural approach for the stapes. That is, just see this video is, I think I would like to share with everyone. Just see the second video. He is doing his trapeze, making space for the foot plate. Just see all the ossicles are intact. Malleus is, you can see incus, you can see trapeze, and one single step. Just see. It is a blind step. Now see, incus is gone. So blind curate can destroy your surgery. And now it is a hypermobile incus. And now you can assess, you can imagine what would be the fate of this case. And once it is, your incus is hypermobile, never try to play, never try to do anything. Wait for some times or take out the incus and do the other procedure, but it is not recommended to do anything in hypermobile incus until you are very expert in using two-hand technique or incus is very stable. Now see this. Again, it looks a wonderful surgery. Again, the Steffi's case is doing a wonderful job making the hole using the perforators of different size. I think most of us must have put place. The hole is properly made, and he would put a piston over there. His hearing would be normal. Patient's hearing would be normal. But again, after 2-3 years, he may develop this problem. What wrong this surgeon has done over there? Can anyone? You want to see it again? You can see incus, foot plate, size 3, size 4, 6 mm piston, 6 mm. Perfect hole, you can put a piston over there. The patient's hearing would be perfectly normal, and patient and doctor would be happy after doing surgery. What's wrong in this case? After 2-3 years? Anyone? No, actually, the foot plate is too thick. You should have gone for drilling of the foot plate until unless a thin foot plate, then you have to do the means perforation, because this patient is going to again the same problem, because it is a foot plate. It looks a perfect surgery, but foot plate is too thick. So drilling was not done. That is the main issue. Sir, your comment? Mike, sir. Mike, he is the maximum, I think he is the maximum step of surgery in this area.
By using skater, this should be thinned out.
Thinned out, because
making
foot plate is too thick, and that is not, that after few years the patient would come at again the same problem because of the, again the same fixity would be there. Sir.
The other thing is that you are just bypassing that fixation with piston, but the disease process is still there.
That's right, that's right.
It's going to grow again. Yeah.
So making hole and putting piston are not the step is actually. So again, main point is never compromise with the piston quality. Never compromise with the piston quality. Rajit, you निकाल दो अपना laptop. You can come to have your section. And 5 minutes only. And let's see. Of course, the piston quality should be good, like this piston. These are very important videos collected from different places, some of mine, some of my friends. These are, just see. It happens with everyone, but this, and it, most of the time, this thing goes inside your vestibule. But what it is creating, every step is creating 3 to 4 decibel loss, SN loss in. So at this level, never lose patience and relax. Take a proper instrument, whatever suits you. Then like this at this level, right angle, take it out and put it again patiently, because it is the inevitable steps if you're doing steppies for anyone. And this, I think, again, I would say, if you're doing steppies, these steps will be well known to everyone, like taking a vein graft, how to make it, how to prepare it, how to put it over on the foot plate, whether you're using very regularly in all the cases, in selective cases, or in emergency cases. But I think this is a step we all should know, to put taking a graft and preparing it over there. Again, if you are doing surgery, this patient was used very, because the surgery was good, but she developed sort of, you can say, vertigo, severe vertigo for a few days. It sorted out, but SN loss was there. An issue was that piston was cut with a not in a proper way, and you can see some sharp tissue or some sharp material was there, which was creating problem. It was taken out, and again it was.
You said vein graft should be put on cases, small small fistula also?
No, sir, because many times in, we suppose you're doing a study in 20% cases, your foot plate is out, or you make a big hole. So in there are many people who use vein graft in all the cases. So for emergency, if your foot plate is out and you have no, then you should know how to take it, how to prepare it, so you can use it over there. Means that technique should be known to everyone.
Yeah, very right, very right.
Again, frustrating point is that good quality piston play over here, because memory, a good piston has a good memory, and like a local piston, if you make it open, within second it closes out over there. So, and you have to fight at this level, and that is not good for your patient, not good for your incus, and that is one more cause of hypermobile incus, and it ruins this thing. So one of the best, one of the better step, if you can do it, cut. I don't have video, so I just that is the one more way you can cut the margin of the piston, and then you can insert it over there. Advice. This, I think, video, those, because one more thing which I think those who use very good quality piston, they have a company made measuring rod, and they can have a proper, but those who are using normal pistons, measuring rods of different company and the piston have different issues. So you are never sure that your piston is, in spite of proper calculation, sometimes you are not sure whether your piston is long or short. That's why it is always recommended to put a piston, you check it in very high magnification, in different magnification, use a right angle, check whether it is inside different, we see different videos from on our media, that anterior movement, posterior movement, and you check it in different and see whether your piston is out or in. Sometimes it looks that it is perfect, but if you see in high magnification, it is more inside. It takes hardly few seconds, take it out, cut it again, and put it over there. So it is not going to harm you. And if you keep it inside, and after 3 days, 4 days, 5 days, again with the vertigo, you have to open it again, that is not fair. So if you are not sure, do on the same setting. Yes, I want to say something.
Long thing is, I have kept 3 dummy pistons with me.
Different
they are
sizes.
autoclaved, and before that is the I measure the length of the piston, which is to be used by putting the dummy piston inside, and check what is the exact length, which piston to be used. Unless the foot plate is thick, if the foot plate you find is thick, then you add 0.25 millimeter.
0.25.
Okay, so there is no problem. 4 mm, 4.25 and 4.5 mm. So use to measure 4.25 mm in general. If you find it is short, then make it 4.5. Otherwise, 4.25 is usually normal.
So 70% cases, I think 4.25 is the length actually. But in the issue is with the few cases. 5% out of 100.
Yes. But it is always better to check it because I have seen using around
3.75 in many cases we have used.
3.75 also and 5 mm also.
So these 5% cases are the main cases, which makes your night because only out of 100 cases, 5 cases are very difficult. Measuring load is an issue because sometimes you have to use different.
That's what I'm saying. Distance.
So one thing I would like to share because now we are doing steppies very regularly. Try it. I think this is the case. I think we should try in our cases. We are doing steppies. Try to preserve this tendon because it is a God-gifted protection, which if we can preserve this tendon for our future stapes surgery, that will make your compliance very better because you do one side, and if you ask the patient to go for the step other side, he or she will remember the previous problems. So he may or she not go for second surgery because if you preserve the tendon, then that of course the hyperactivity decrease, better stability, better discrimination score, better tolerance to higher improvement sign, and better adaptation and wish to go for second year surgery. These are few points which I have noticed in our cases because now since very long time, I am preserving this tendon in most of the cases, if possible. So that is because just see, and there are so many ways. Stamp method, yesterday someone was saying it. So this is a step is minus piston. There's one more approach, and Dr. Suri Prabhu's technique is there. So many things are there. You can preserve this tendon. Just see, because just this poor sound is not here. On sound, the tendon is moving like this. So it has a natural protection for you, and we should try to preserve it as much as possible. And in stapes cases, never remove excessive attic bone in your stapes cases because it is my experience. This is my case, and I had to somehow I took out the attic bone very much and didn't use. I put this piston over there. And after sometimes I could see some collection over there, followed by discharge from that area, and finally after 4 or 5 years of the surgery, I had to take out the piston. I put it again, so now the piston is doing well, but the 2-3 years were very bad. Ready? वो कहाँ है सर? डॉक्टर देवे सर कहाँ है? राजीव तुम्हारा प्रेजेंटेशन है ना? सतीश थोड़ा सा वो एक हल्का सा हेडेक मेडिसिन लिए थे. Otherwise, you have to take out the piston like this, and you have to deposit it back. So again, this is no shortcut for anything. This is what piston I am talking about. The step implant slides are there. I will take it. I will skip all these slides. Okay. Again, there are other instruments. So instruments should be up to the mark, like there's again one issue, bubbling burr, and it can create problem for you. So check your piston burr, because the bubbling burr can, now the flap is gone. And once the flap is out, then again an issue. Pre-op preparation in all the cases is must. Again, cosmesis is an issue. Always try to give a better. Are you ready? Was is beautiful presentation on pituitary was disrupted, so I can do later on. हाँ चलता रहेगा. Oh.
Okay, so I think I was on this slide. So just to take you back again on the anatomy. So pituitary gland, pituitary stalk, these are the superior hypophyseal arteries, optic nerves on both the sides. Okay. So you can see the anterior communicating arteries, optic nerve, optic chiasm. So all this anatomy, sometimes when the tumor is very big, we can see, we get to see in our live surgical cases also. Just like in this case, you can see the optic pituitary stalk here. That's the tumor being removed, some residual tumor here. So that's the superior hypophyseal artery you can see on the right side, and the branches of the superior hypophyseal artery is on the left side. So that's a stalk, and see on the right side you can see this is the carotid artery, and it is getting bifurcated here. That's the middle cerebral artery here, and the anterior cerebral artery here. See how the optic nerve has been compressed and displaced. So that's the optic tract, optic nerve on the right side that is compressed and thinned out. That is the optic chiasm here. So that's the ICA again. So see now that's the anterior communicating artery, the anterior cerebral artery there, of the left side. So you will be able to see that that's the anterior communicating artery there. This small glimpse. So the optic nerve on the left side, again compressed optic nerve on the left side. So that's the anterior communicating artery here, like here. Okay. You can see the pulsation. You can also see the right anterior communicating artery here. You can see the toroid plexus, and so all the anatomy that we saw in that picture. Again, these are the same pics of the cases. So sometimes when the pituitary tumor goes posteriorly and erodes the dorsum sella, so you see the dorsum sella being eroded here, and see the basilar artery there. So the basilar artery bifurcating into the posterior cerebral branches. on the right and left. See the basilar artery and bifurcating into the right and left posterior cerebral arteries there. And so I'm sorry for this poor quality video, but we have seen what Satish showed us yesterday. So see the foramen of Monroe there, the mammillary bodies inferiorly on both the sides, the third ventricle open, and this was again a big tumor that was going suprasellar into the third ventricle. So after we have done the routine pituitary surgery, so the fall of, we see the arachnoid falls down, but the fall of the arachnoid does not mean that there is complete tumor removal. So we must inspect between the folds of the dura, and this anteriorly between the arachnoid and the dural fold. This fold is very common area for the recurrences. So it should be lifted and inspected properly so that there is no residual tumor here. So this is the first common site where the tumor is left. So even when you are sure that the tumor has been removed, spend some time for final inspection. Okay, see, we are lifting the fold arachnoid, and you can see this is the cavernous sinus wall on the left side, on this side, and then this fold between this cavernous sinus and the dural, this fold is also a very common site of recurrence. So these folds between this and this, so it should be inspected. So that final inspection saves us from recurrences. So see, you can see that I'm inspecting that fold. That's the medial cavernous wall, and how the dura is covering from the cavernous going into the sella and the pituitary arachnoid. So now coming to recurrence, the main factor associated with recurrence is residual tumor. So the basis of recurrence are inadequate initial surgery, inadequate exposure, small opening in the sella, small opening in the sphenoid. All right. So, and then it is the characteristic and invasiveness of the tumor. Sometimes the tumor is very invasive. It is very hard, fibrous, that we cannot remove it completely. Right. So like in this case, see, again, we are trying to do extracapsular dissection. But see, when we are trying to pull this fold of the tumor, this is the anterior cerebral artery. This probably this vessel that I am pointing out, this is coming down, and it is very risky to separate it from here. So it is getting pulled up, this vessel, right? So if we do it blindly, if we do it forcefully, so we are gonna lead to major complications. So it is better to leave such type of tumors back and subject the patient to the radiotherapy, and then again see this type of tumor. So this is the carotid artery, and the tumor is going all around the carotid artery, and it is very fibrous. You see, this is the cavernous sinus lateral to carotid artery, and so removing this tumor, you can see this is not coming in the suction. It is not easy to pluck it with the forceps. So I think here we should put our ego aside and leave this type of tumors back there and subject these tumors to radiotherapy if the patient still has some symptoms. Then again, the basis of recurrence is the fear of bleeding during pituitary surgery. We all have seen that the minor bleeds can be easily controlled, and then this is again the bleeding very common from the cavernous sinus. So here we are removing the tumor from the right cavernous wall, and while removing it from the cavernous wall, see the incidentally one of the suction gets entered inside the cavernous sinus. See, so that is the bleeding of the cavernous sinus. So again, this is nothing to worry. Dr. Pushari has shown how he controlled the sigmoid sinus bleeding. The same principles apply here. You use Surgicel or Surgiform, place a patty over there, wait for some time, and this bleeding will stop. All right. So then again, some cavernous sinus bleed. See, we are removing the tumor inside, so that is the optic chiasm here. So you can see the tumor. That's the residual tumor that is still there. That is the again the carotid cavernous carotid, and see the bleeding from the cavernous sinus. All right. So this will keep on bleeding if we don't have patience and do something about it. So again, the principles are same. You apply some gel form placed in Surgicel over it, place it for some time, pack it with a patty, give a good wash, and the bleeding stops. All right, so the bleeding stops over there. And sometimes we may encounter major arterial bleed, very few, either from the inferior hypophyseal artery, or this is the Karnal's capsular artery, which is present in around 20% of the cases. And when we give dural incision, this artery can bleed. And again, another major cause of bleeding is the carotid artery. Carotid artery is sometimes very close to the pituitary. There is no space between the pituitary and the carotid artery. And when the pituitary tumor grows, due to the pulsations of the carotid artery, the tumor invaginates superior and goes inferior to the carotid artery and starts involving it circumferentially. And injury to this artery during surgery is a potential complication. So in one of our cases, it was a revision case that we did, and we didn't have any landmarks, and we thought we are in the midline, and it was just the beginning of our surgery. We have done the exposure, and then our neurosurgeon took a nick thinking that this is a midline, and see, just at the time he thought he's taking a nick in the dura. So he took a nick in the dura, and there was a big spotter. See, so everything went red. So you don't have much to do when there is such a high volume bleed, and you need 4 hands to at least get a control of it. And you see the major arterial bleed in this, and see the spurter. So here you need a teamwork. It is not one person's job to get hold of this type of bleeding. So however, we tried to manage this case. So we saw the bleeder is coming. We tried to get hold of this bleeding, and we thought that we are not so lateral that we would injure the carotid. So maybe it is a revision surgery. Maybe it is the carotid was displaced. Maybe there was some neovascularization of the vessel, and we again took control of it and put cotton Surgicel soap gel form over it, placed over it, and placed a cotton patty over it. And get hold of the bleeding, remove all the residual blood in the cavity. See, then our neurosurgeon said the bleeding has been controlled. Let's go ahead with the tumor removal, and we'll see it in the end. And we did that. We placed it, and we went ahead with the tumor removal in the same case. So then we went ahead removing the tumor. So that's the incision we took again, and we went with normal procedure of tumor removal. We started removing it, we removed it, and at the end, when we were sure that we removed the cotton patty, so the cotton patty here is removed, gel form removed, and you see this is the Surgicel where we had placed. See the pulsations there, and we thought we got hold of the bleeding. We removed the Surgicel, and thank God we didn't get a bleeder this time. And so the patient was fine post-operatively. So we concluded that this was not a carotid artery bleed. So maybe in a revision case, this is some neovascularization that bled. But it was just like a carotid artery.
So now coming to the reconstruction in the pituitary gland, it requires nasoseptal flap, and in many a times in pituitary surgery, especially in revision cases, the nasoseptal pedicle may be compromised. So harvesting a head flap is a very easy thing. We can use simple knife or cautery. So we recently tried using the publication. So this is the MLW wand that we used for doing Kashimas, vocal cord cutting. So we used that to harvest the flap. So this is not a routine procedure, but just to show you that this sometimes gives a very avascular field. So we mark the incisions with this wand. That's the inferior incision being given. Coming anterior, and now we are giving the superior incision just below the sphenoid ostia. So that's a superior incision being taken forward. So when we come anterior, just anterior to the middle turbinate, we go superior. Then it is just like a basic periosteal elevation, like we do in the septoplasty. And once the flap is raised till from the sphenoid rostrum, it is placed in the nasopharynx. And this has been a workhorse in our reconstructive surgery. So the placement of the head flap, it covers all the defects. It can cover the whole of the skull-based defects from the cribriform plate, from the frontal sinus to the sphenoid to the clivus, and we can use this from both the sides. And we can reuse it in cases of revision surgeries. We can take it down in cases of revision surgeries, do our work, and then reposit it back. Now, in most pituitary surgery, an intraoperative leak is not expected but may be encountered. A rescue flap approach can be used, in which consists of partially harvesting the most superior and posterior aspect of the flap to protect this pedicle and provide access to the sphenoid during the approach. It can be fully harvested at the end of the operation if the defect is larger than expected and if there is unexpected CSF leak and the pedicle is not compromised for revision surgery. So these are the diagrams showing how to harvest the rescue flap. You can see the superior incision and the inferior incision just below, and in cases of head flap, where in cases of rescue flap, it is only the superior incision that is given and that is not taken back. So that is the difference between the rescue flap and the head flap. So you can see we are taking the rescue flap on the left side. So this is the incision that we have given, and we are just elevating the flap from the sphenoid rostrum here and exposing the head-on anterior wall of the sphenoid so that we can remove it. So we can do all our work preserving the pedicle. We can convert this into a proper head flap at the end of the surgery if required, and this does not compromise the pedicle if in case any revision surgery is required and the head flap is required. So with that, thank you so much. So these are the tips and pearl for the pituitary surgery. We ready with the reconstruction plan before the surgery. Get a wide exposure. Identify all the major landmarks first. Be gentle in removing the reconstructed material in cases of revision surgeries. Reconfirm ICAs with intraoperative Doppler. No blind curettage in the pituitary fossa. Severely adherent tumor to IC or pituitary can be left behind. And neuronavigation is always helpful in these cases. Thank you so much.
Hello. Hello.
Hello. Hello. Yes, Dr. Sanjay.
Yes, sir. Sir, we are starting with another case. This is thyroid surgery.
Yeah.
A patient is having history of right hemithyroidectomy 5 years ago, and now we are doing left side. So there is a thyroid enlargement of the left side. Okay. So Dr. Satish will be showing you the MRI scans. Over to Satish.
Okay.
Hello.
Hello. Yes, Dr. Satish.
Yes, sir. So actually, this is a young patient
who had undergone hemothyroidectomy a few years back and now has a solid cystic nodule. Solid cystic nodule in the left gland. FNAC is inconclusive, maybe Bethesda three, what I was told, and quite big, giving a deformity. So, a plan is left hemithyroidectomy. And, in thyroid, the initial imaging investigation of choice is sonography. Yes. Ultrasound is the investigation of choice for many reasons. And since this patient had MRI, so I can run through the MRI certain important information. See this, the most important thing in the MRI is solid cystic nodule. Solid cystic nodule is always something should be closely followed. This is the cystic part in the nodule and in the solid part in the nodule. See this? Yes. Though we don't have diffusion, we can't demarcate whether it is benign or malignant. But the cystic part is very well lined, uniformly lined cystic part. The rest of the nodule is the solid one. So plan is hemithyroidectomy, investigation of choice, initial investigation is always ultrasound, then FNA, and most of the time you don't need CT or MRI unless there is malignancy and you suspect the great vessel or airway involvement or retrosternal involvement, then only the MRI or CT scan is indicated. Otherwise, most of the time you can get away with ultrasound, FNAC and thyroid hormone testing. This patient has ultrasound or not? I don't know. What I have been given is this one. We will not be able to see microcalcification, etc. in this MRI. Yes, that's why ultrasound is the primary investigation of choice for many reasons. And having a good sonologist can tell you up to 95% accuracy if there is any suspicion of malignancy in ultrasound. For certain ultrasonic features, we can tell you about the possibility of malignancy. So here is the surgical exercise to demonstrate. Our colleagues have already raised the flap, and I'm going to, share you with the steps of the surgery. Thyroid surgery is always fascinating, which requires extreme diligence to preserve a lot of neurovascular structures and parathyroid glands. So the 3 or 4 structures which are more important to preserve are the recurrent laryngeal nerve, external branch of the superior laryngeal nerve, and most importantly, parathyroids. And here, the edge comes from the microscope. Microscopic surgery has definite edge in identifying and protecting these structures, which is I am going to show you again. What was the previous biopsy? Any idea? It was benign. Benign colloid gutter. Yeah. Okay.
Hello. Hello.
Yes, sir.
Yes.
Hello. Incision has been given and the flaps are being stitched.
Okay.
Satish will join in few minutes.
It's a top camera view or endoscopic microscopic?
This is the external camera.
Okay. You don't put Joul's retractor, which are specific
They don't.
surgery?
They don't do.
Okay. So anything about the incision while giving incision?
He will describe. Incision has been given already and that has been done by assistant.
Okay.
Just to save the time.
That's right.
So this is the microscopic picture.
Okay, good.
Hello.
Anji, hello.
Hello.
Yes, Dr. Satish.
Okay. Are you getting the microscopic picture?
Yes,
sir?
yes, we are getting.
So I told you this is a solid cystic nodule.
Yes.
This is the midline. The opposite, hemithyroidectomy has been done earlier.
Yes.
Yeah, can you slightly zoom out a bit?
Probably this is the lowest one in this microscope.
You can give the orientation, superior, inferior,
Okay.
lateral,
Okay.
medial.
It's too big a picture. See, this is superior, this is inferior, this is right side and I am here on the left side.
Right.
So this is superior.
Okay.
Okay. So I am elevating in the midline.
Okay.
Up and down. Since it was operated earlier, so you can imagine. How much is it done?
There will be a lot of fibrosis.
Yeah, expected. Normally, you have two layers of muscles.
Yes.
Strap muscles. The lateral one is the sternohyoid and the medial one is the sternothyroid. Here I am dividing the muscle, looking at the situation.
Okay.
We can re-feature it any point of time later. See, whenever we divide the muscle, always divide in the upper part.
Okay.
Because the nerve supply is always from below. By the lower division of ANSA. Lower loop of ANSA.
Yes.
See all this fibrosis in the
Yes.
muscles.
Yes.
So far I am elevating only the muscles. Can you see the cystic part of the nodule?
Yes.
See what I have reached
Yes.
underneath the strap muscle. Can you see?
Yes.
On my side. See this? I am reaching underneath the strap muscle, bipolar. To the pedal. You elevate the strap muscles, go underneath the strap muscle in the paratracheal plane. That is relatively avascular plane. The bipolar is not on. Okay. So now see this underneath the strap muscle.
Yes.
Open up the plane and elevate the gland out and reach in this paratracheal gutter. Can you see this?
Yes.
That is the most important part of the surgery, I believe, to get into the right plane. See this?
Yes.
See the big nodule coming out?
Yeah.
And see the plane. That is most important to reach into this plane. Once you reach into this plane, your life becomes easier to identify the important structures. See this?
Yes.
The first thing I intend to identify once I reach. Most of the time, if you are in the right plane, you don't need to look for structures. They come automatically, become prominent to you. That's the carotid artery you see.
Carotid artery, yeah.
This is the lateral plane part of the muscle cut.
Oh.
I'm opening little more, inferiorly, because my inferior dissection is always, important to start inferiorly. I'll tell you the reason behind that. Now, this is the paratracheal
Yes.
avascular plane. Most of the time, serious,
Yes.
that's a carotid artery deep to the carotid in a horizontal plane. See the vessel coming from deep to.
Yes.
That is the inferior thyroid artery. That's the first structure I always intend to see. First structure I intend to see is the inferior thyroid artery. That's the inferior thyroid artery. Yeah.
Dr. Satish,
Yes, sir.
is there any role of thyroglobulin in this case? Because the half thyroid is already removed.
That was not malignant, sir. Malignant would have been a different scenario. Now see, that's the, can you see the artery?
Yes, sir.
Now the advantage of microscopic is, the most important thing to identify are the parathyroids. And parathyroid are so uncertain in place, there is no fixed place for the parathyroids. Their embryonic descent can happen anywhere, right from the, tongue to the mediastinum. Particularly the inferior ones are more notorious. Superior ones are more consistent in their location, final location. But why I've seen the inferior thyroid first? For many reasons. Let me increase the magnification for you to show you something. Can you see the inferior thyroid very clear?
Yes.
In the vicinity of the inferior thyroid, this is inferior, this is superior. The first structure I intend to see, and that is automatically visible, is the recurrent laryngeal nerve. Can you see them now?
Yes, yes. Yes.
Let me open up this space. Yes. क्या कर रहे हो?
एक मशीन में चेंज करनी पड़ती है, अलग अलग प्रोब रहती है.
Can you see the recurrent laryngeal now very clear?
Yes, sir.
If you are in the right plane, you can identify easily on your own.
No conference.
Without even looking for it. See the recurrent laryngeal now?
Yes, very clear.
Why you need to look inferiorly? Because inferiorly you get into a common trunk, single trunk. Many a time this nerve bifurcates and is goods towards the thyroid. So always find out this nerve inferiorly. Okay?
Yeah.
Can you see this now?
Yes.
And there is a small branch coming out of it. See this?
Yes.
As this goes up, it may bifurcate. Now, the most important thing.
Artery.
This is the artery. And now we have to look for the parathyroids. The inferior parathyroids are by and large inferior to it. Superior parathyroids are superior to it. Superior to the inferior thyroid artery. This inferior thyroid artery is the landmark. Inferior parathyroid is mostly inferior to it and superior mostly superior to it. And you know, it is so difficult to identify the parathyroids by and large. And many times this microscopic surgery helps you to identify the vessel which is a branch of inferior thyroid artery going to the thyroid. This is an additional, help most of the time. That's what I'm looking at. Is somewhere if I see the gland. One more thing. Most of the time, see, this is the artery. The artery itself is very slender. See this? Artery is not very great, not a big one. I can see some of the branches, but I don't see anyone, going towards a gland. So still, I'm not sure where the inferior parathyroid is. Here, is it? No. Superior parathyroids are always more constant in location. See, this is trachea. This is cricoid cartilage. And yes, I can see the glimpse of superior parathyroids. See this recurrent laryngeal nerve going towards the larynx, the cricotracheal groove. Can you see this? Hello?
Yes.
See the recurrent laryngeal nerve?
Yes. Centralized picture.
That's the recurrent laryngeal nerve going up towards the larynx. That is the region of the cricotracheal groove. And here what I see, a very, very important anatomy. Because my goal is to preserve the parathyroids. We don't know what the previous surgeon has done in terms of preserving the parathyroid. Parathyroids are the most important structures and most difficult to identify kind of structures. See how this recurrent is going there?
Yes.
Inferior parathyroid I have not yet seen. It's not visible in the usual location. superior or superior to the inferior thyroid artery behind the level of the recurrent laryngeal nerve. And what I can see, what I am looking at in the microscope, where the vessels are heading to. See, all these vessels are heading here. And this parathyroid is embedded in the fat most of the time. Yes. Let me show you. Hello.
Yes, sir.
See the vessel going there?
Yes.
That is the fat tissue. And this is the parathyroid which is embedded in. This one is the parathyroid. You see this one? This one is a caramel colored structure. Can you see this one?
Yes. Yes.
I don't want to traumatize it. See, if this is traumatized, it will turn jet black. I don't want this to traumatize. If you preserve a parathyroid, this is the parathyroid.
Okay.
The color varies from caramel to brown to yellow from the age, depending upon the age. This is classical parathyroid with a microscope gives you confidence in identify because it has a network of vessels over the surface. See the network of vessels over the surface.
Yes. Yes.
And all these vessels are heading from here, heading towards it. And this is the usual location behind the recurrent in the cricotracheal joint. So this is definitely my superior parathyroid. This one is no doubt about it. So the location mostly is behind the recurrent laryngeal nerve in the cricotracheal groove, above the cricoid, below the trachea. This is trachea, this is cricoid. And see the number of vessels coming from it. Hello?
Yes, sir.
That is the beauty of microscope wherein you can see the vessels coming from the inferior thyroid artery. Inferior parathyroid I can't see yet. Inferior parathyroid can be anywhere from its usual location to, anywhere in the, up to the neck, up to the mediastinum. Yeah, it may be in the thyroid capsule, anywhere, you never know. And whenever you suppose you doubt on something like parathyroid may or may not be, this could be also the parathyroid. This could be the tissue. See fat tissue, and this looks like the parathyroid to me. Can you see? But because this is the fat, it is always embedded in the fat. Can you see something embedded in the fat?
Yes.
This one. Can you see the small gland?
Yes, yes.
This one. This could be parathyroid. Now there are difficulties in identifying the parathyroid. The reason being, it could be fat, it could be thyroid tissue itself, it could be lymph node. In case you doubt about the parathyroid and you want to really confirm a transplant, get a frozen section done. If it is parathyroid, mince in small pieces and inject in the muscle in the forearm. To me, most likely this should be from the look, it looks like the parathyroid. See this?
Yes.
Embedded in the fat. Not 100% sure, but this is the location. And this is classically, embedded in the fat. See this?
Yes.
This is a special, not a very, yellow fat. See, this fat is different. This fat, superficial fat is different. Here the fat is different. Even the fat is very, as compared to the other fat is vascular, more network. And this looks like the inferior parathyroid to me, but superior is confirmed, so I will not do anything to it. So we have seen inferior thyroid artery, recurrent laryngeal nerve, the superior parathyroid for sure, inferior parathyroid. This could be inferior parathyroid because I can see a lot of branching vessels over the surface. See the typical color. Can you see very clear or not?
Yes, sir. Centralize the picture. Yes.
This one. And it is still not turned jet black, so I don't want to disturb it anymore. Now, another important structure is the external branch of the superior laryngeal nerve. See, this is important to exploit this anatomy and preserve this. Sometimes patient, even if this nerve is injured, may get away without any problem, may not complain you. But for the professional voice users, it is very, very important. See what I have done? What I have done? This is the upper pole of the thyroid. See, this is the upper pole.
Yes.
This is superior, this is inferior. See the gland?
Yes, yes.
Now I am retracting the upper pole towards me. This is the midline airway.
Yes.
These are upper pole vessels. These are strap muscles I am opening. See this?
Yes.
This external laryngeal nerve, it comes from above along the upper pole vessels. These are upper pole vessels. This come along the upper pole vessels, and just before the thyroid, it turns medially to innervate the cortex. Cricothyroid muscle, and I can see the glimpse of it. We'll show you. Sermi has devised a classification. Sermi is a head neck surgeon from Brazil. He devised a classification regarding the. Can you see the nerve?
Yes.
See this? This nerve was coming along. See, these are upper pole vessels coming along the vessels, and before reaching the gland, it takes a medial turn to supply the cricothyroid. Can you see the slender nerve?
Yes, yes.
Now this is more than a centimeter above the upper pole. But this is most favorable, you can say. This is most favorable, you can say. If it is within 1 centimeter, it is difficult, and if it is below the level of the upper pole, then it is difficult to identify and preserve.
Yes.
So this is a more favorable condition, and it is because of this the traditional teaching was to clamp the upper pole as close to the gland as possible. Because if you cut the gland as close as possible,
there is a less likely chances to.
Yeah, see this now coming from above.
Yes.
It is a branch of superior laryngeal nerve. See this now. See this now.
Yes.
And it is taking a medial turn over here. See this now taking a medial turn. Very clear. Can you see it or not?
Yes, yes, very well seen.
So once we have seen this now, and this is going to the cricothyroid here. See this very clear, 100%, the external branch. The superior laryngeal nerve comes from the upper part of the neck, just below the jugular foramen from vagus. It runs behind the carotid, and here at the level of the thyroid membrane, it divides into external and internal branches. This is the external one, the internal goes through the thyroid membrane to supply the supraglottic bearing, that is sensory branch. And this is a motor nerve, the only tensor, it supplies the only tensor muscle in this region, that is cricothyroid. And see the nerve very clear. Can you see?
Yes, sir, very clearly.
So now once you have seen the nerve, we can ligate the upper pole away from the nerve. See this? See this? See, we have ligated the upper pole, preserving this nerve. See this nerve is there?
Yes.
Ligate. So we have seen the recurrent laryngeal nerve, you have seen?
The external branch of superior laryngeal nerve.
See, that's the recurrent laryngeal nerve. That's the external branch.
Yes.
And these two nerves have 135-degree angle from each other. See this. That is the external branch. That is the external branch, you can see very well. That's the external branch here. That's the recurrent. Both the nerves in one view. Can you see? This is the external branch above.
Yes, sir, yes.
This is the external branch going to the cricothyroid. This is cricothyroid muscle, and this is a recurrent laryngeal nerve.
Sir, for you, the landmark for the recurrent laryngeal nerve is then inferior thyroid artery.
Yes, it is in close proximity to the recurrent inferior thyroid artery once it courses towards the cricothyroid joint.
So you always start with the dissection of the inferior thyroid artery?
Yes, always. So once you see the inferior thyroid artery, you have two compartments now, inferior and superior. In the inferior compartment, once you see the inferior thyroid artery, look for the recurrent in the inferior compartment far below, where you find in a common trunk. And see this area where I look for the inferior thyroid artery generally. Once you are in the right paratracheal plane like today, you can see the recurrent laryngeal nerve so easily.
Yes, yes.
Otherwise, in the same triangle, see this triangle is Lorenz triangle formed by the inferior thyroid itself, the trachea in the midline, and the carotid laterally.
And the recurrent laryngeal nerve is the content of that.
Yes, it's part of this triangle.
Yeah.
Okay. So that is the recurrent. That is why possible,
inferior parathyroid.
I'm quite sure because it is too vascular a region in this region. See this? This is my inferior parathyroid. Superior parathyroid is confirmed here.
Sir, there is a branch from the inferior thyroid which supplies the parathyroid, inferior parathyroid.
Yes, so I don't see here directly. That's why I had a doubt because normally I should have found anterior to the recurrent laryngeal nerve here.
Yes, yes.
So that is the usual location, but I don't see.
So please tell the boundary George triangle on the superpole.
Yeah, George triangle is what? See this. We have found this nerve here. See this? We have found this nerve over here. So how to find the George triangle? What is George triangle? When you retract the gland towards you, the superior pole vessels on one side, the airway on other side, and it is roofed by the step muscles. You open up the step muscles and you are in the triangle. So that is for external branch. Yes.
Superior laryngeal.
So the best is retract the thyroid towards you. And now once you have seen all the structures, now you can take your, see this?
Sir, some say that use of cautery in close proximity to recurrent is should be avoided.
Yes, a monopolar can damage if you are very close to it. See, but I am not very close. You can
see the picture, please.
But I am not very close to it.
We are far away.
Yes, I am doing this under vision. Now I am looking for the paratracheal plane.
Yes.
Yes, sometimes this leading close to the trachea.
This is paratracheal plane. Sometimes you find the inferior thyroid veins here. Might be ligated during previous surgery. See all the structures here.
Yes, sir.
We are leaving behind all the structures. See the trachea?
Yes, sir. Yes.
That's the pretracheal fascia. This is the isthmus I am removing. The important thing in the thyroid is to preserve all these structures. See once again.
So the whole thyroid is out.
Can you see the recurrent very clear?
Yes.
Yes.
इसको करना. See, this is the recurrent laryngeal nerve. This is inferior thyroid artery, which is, taken close to the gland. Can you see?
Yes.
Here superiorly we have seen the external branch. And this is the superior parathyroid, this one. The inferior is a probable one, this one. And see this network of nerves, vessels, everything preserved. So the thyroid surgery involves preservation of these critical structures, particularly parathyroids. You never know how the parathyroid behaves sometime. But fortunately, out of all 4 parathyroids, even if one is fully functioning, the patient will not develop, permanent hypocalcemia. May have transient hypocalcemia, temporary hypocalcemia, but not the permanent one. But permanent hypocalcemia is disaster. Disaster is worse than the thyroid cancer itself. A patient has a crippling life, with the hypocalcemia for life. So the most important thing in thyroid surgery is to preserve all these functional structures. That is parathyroids, recurrent laryngeal nerve. In case any of these damaged, we should have a plan to restore the function. Like for example, if the parathyroids are gone, devascularize, we should have a frozen section facility to confirm it is parathyroid, devascularize, mince in small pieces and inject in the forearm muscle. Majority of the parathyroid start functioning, whatever implanted parathyroid within 3 weeks. And it has been studied by lots of, studies earlier that the serum level of the parathyroid starts building up in 3 weeks' time. If the external branch is injured, because that is a tensor muscle of the vocal cord. What you can do then, as the larynx is relaxed, what you can do, take a tough suture at the inferior part of the thyroid cartilage and pull it and suture to the cricoid cartilage, cricothyroid suture.
Can you show us where, sir? Because generally this nerve gets damaged.
I have let me show you. So pull the thyroid below to make it tense. So it will help you, to prevent the patient noticing such a deformity, the voice change. But for a professional voice user, if the external branch is gone, his career is gone. Because this is the most important muscle, external, this cricothyroid, to build up the tone of the voice, which is required for a singer. So what I can show here, let me show you. See, this is thyroid cartilage.
Yes, sir.
Hello?
Yes, sir.
Yes. Let me show you. This is cricoid cartilage.
Yes, sir.
Here is the beginning of the trachea.
Yes.
This is cricoid cartilage, this is thyroid cartilage. Take a suture from above the thyroid. Suture from above from the thyroid forceps. पगड़ी कर रखिए. Okay. See, take a suture at the thyroid cartilage and pull it below. See this?
Yes, sir.
And suture to the cricoid.
Okay.
Bring close to the cricoid to make the larynx little tense.
Tight.
So this is a tensor muscle.
Okay, sir.
To make the tense. Now, if the recurrent laryngeal nerve is injured, then you have many options according to the injury. If this nerve is transected, and you have opportunity to resuture because it has a relaxed nerve, you can gain a little bit of the length. See this?
Yes, sir.
Yes. If you can do a end-to-end suturing, nothing like it.
Sir, how, which suture?
Yeah, 90 proline.
90.
Now, if you have a gap, then you take the ansa hypoglossal. Ansa is here on the carotid sheath.
Yes, sir.
You can take the ansa hypoglossal to fill up the gap as a graft material to suture at both ends. Now, if it is completely transected and you really want to re-innervate it, you can re-innervate with the ANSA only. Bring the ANSA and suture to it, and that will maintain the tone of the muscle. It will, at least it will prevent the atrophy of the laryngeal muscles.
Now, there are a lot of studies done by fellow surgeon, Dr. Jayakumar was telling that ANSA new reinnervation is a miraculous thing.
Yes, it works very well. We have done in couple of cases and it works very well. And ANSA is so easy to identify. ANSA runs on the carotid sheet and one can easily identify the ANSA in the same vicinity.
Yes, sir.
And then you can do this. So these are the various ways by means of which, you know, you can re-innervate all the function lost.
Sir, ANSA को कैसे re-innervate करेंगे sir? If you can just describe it, what you have done.
Take the ANSA and suture it. See, here is the ANSA.
Centralize, please, sir. ANSA.
Can somebody come? Give me a pickup. Pickup forceps. Pickup forceps. ANSA is a useful now for re-innervation. We sometimes re-innervate, you know, this thing. Yes, come here, please. इधर पकड़ लो इसको. इधर आ जाओ. See the carotid sheet here?
Yes, sir.
Yes.
पकड़ना इसको. ये पकड़ लो. नहीं, ये मेरे को दो. इससे पकड़ लो. So ANSA runs on the surface of the carotid sheet, पकड़ लो. And ANSA has adequate length, you know. That is ANSA hypoglossi. See the ANSA?
Yes, sir. Nice.
Can you see this ANSA?
Yes.
So bring in the ANSA and you can suture the ANSA over here easily.
Okay.
You can take the length, whatever, and re-innervate. Just re-innervate. Because this is a motor fiber to supply a lot of muscles here in the lower part of the neck. This lower division. So bring in ANSA and suture, and both the recurrent and ANSA have almost a similar diameter. And it has enough motor potential.
So it can be done as a staged after 3 months also or something like that?
You can do immediately if it is done intraoperatively, you are sure. Otherwise, if you are not sure, you can do it later.
Okay.
But coming to the same field, in the operated field, after fibrosis, after months is very, very difficult. Rather, that will be more damaging to the patient than a benefit.
So the muscle nerve pedicle, they are telling that you can bring it to the vocal cord. Is there?
Yeah, there are many ways of re-innervation. Neuromuscular re-innervation, many ways of, you know.
Even sir, for old case, if you do the thyroplasty, results are very good.
Yes.
If recurrent is gone, then thyroplasty, if you do, results are good.
Yes. Thyroplasty with arytenoid reduction, you know, depending upon the glottic chink, posterior glottic chink, you have to plan whether thyroplasty itself is adequate or need
So
arytenoid.
bilateral abductor palsy in a post-thyroid case, only laser should be used for this removal of arytenoid, or you can do something else also?
Why to remove arytenoid? Nowadays, Kashima is the standard procedure.
Yes.
Cordotomy, Kashima, you can divide the vocal process from the rest of the vocal cord.
By cold instrument, or you want to
Laser is ideal, gold
And
standard.
laser is not there then?
Laser is ideal, gold standard without tissue loss.
Okay.
So you can make a cordotomy opening, bas here डालो.
Sir, if laser is not there, then laryngeal band of ablation can do?
Yes, but there is a lot of tissue loss.
Yes.
Lot of tissue loss, which we don't want. And laser gives the best results of a good posterior airway and a good anterior approximation to produce voice. So patients generally, you know, end up with a reasonably good voice, with a good airway as well.
Sir, if we can avoid the cutting of strap muscles, and we can, if we stretch it and do the procedure.
Yes, you can.
So if there is any advantage of it?
No, no. See, if you have a larger nodule,
then definitely you will not be able to do it.
yeah, that will require more stretch, more compromise, with the visualization, the more chances of complication, honestly stretching everything. You can cut the strap muscles from above and resuture them.
Resuture them, okay.
Sir, from upper 1/3, junction of 1/3 and lower 2/3.
Yes, because their innervation is coming from the lower loop of the ANSA.
Because most of the times sir, these are very much adherent to the thyroid gland also.
Yes.
So when you cut it, I mean, you have to meticulously separate it from the gland so that you can resuture it.
See, there is always a plane, you can pass your finger underneath.
See.
There is always a plane there. So it's
and sir, now the total thyroidectomy has been done. What investigation we have to do when and how to manage these patients post-operatively by ourselves or send it to endocrinologist?
See, thyroid malignancy is a different science. If it turns out to, suppose there is a case of malignancy.
Yes.
Majority of the thyroid malignancy are differentiated cancers, papillary, follicular, and they have extremely good prognosis measured in terms of decades. We have many of the patients of thyroid who have been living good life with good follow-up for almost 20 years.
Yes, sir.
The reason being, we have a marker to follow up. We have a treatment for the recurrence. There are very few cancers in the body which have all this. See, suppose you have done a hemithyroidectomy and turns out to be a cancer which was not revealed earlier by pre-operative investigations.
Sometimes it happens, sir, very routinely.
Yes, it can happen because the FNSE, USG, because this requires a very, very thorough, personalized workup by the sonologist, by the pathologist and the surgeon. Like we order these investigations in a row rather than as a blanket. Foremost investigation is the ultrasound.
Okay.
Ultrasound by a very, very experienced ultrasoundologist can tell you that whether it could be benign or malignant.
So if the calcification is only the criteria of finding out prognosis.
Microcalcification is one of.
Yes.
The outside, capsule, the halo, the calcification, irregularity, so many things, the lymph nodes, the architecture of the lymph nodes, so many things which can tell you it is malignant. So ultrasoundologist can tell you whether it is benign or could be malignant, or one of the nodule could be malignant. That should be biopsied.
Right.
Where you can put a selective needle under ultrasound guidance. Suppose you have a multinodular goiter. You put any blind needle anywhere and it turns out to be benign, in spite of removing a malignant nodule, is a disaster.
Right.
So ultrasound will tell you which nodule has a characteristic feature akin to malignancy, and that selectively should the FNSE be done. And then FNSE will tell you grading. The Bethesda grading system is amazing, which can tell you whether it is pure benign, doubtful, or pure malignant, suspicion of malignant, and accordingly you have to take a call or a repeat FNSE or close observation.
Right.
So, if it is a malignant, gold standard is total thyroidectomy.
Total thyroidectomy.
It's gold standard. Not
whether they have completed the family or not, depend.
Whatever gold standard is total thyroidectomy, less than gold is all monkey business. Whatever for malignancy, subtotal, near total, whatever is nothing is gold standard. So if you have done a hemi, turned out to be malignancy, you have to do a completion like had you been having a previous diagnosis of malignancy, same thing you have to do now.
Sir, there is a situation like hemithyroidectomy is being done, subsequently turned out to be papillary carcinoma. Patient was female, ordered thyroglobulin that was within the limit.
See,
age is 40.
No value. After a hemithyroidectomy, you have an adequate amount of thyroid tissue to produce thyroglobulin. That's what I'm coming to. It is of no use Once you do a total thyroidectomy, once you remove the entire thyroid producing tissue, you get a radioiodine scan. It will pick up any thyroid tissue in the body, not only in the gland base, not only in the lymph nodes, but anywhere in the body. Because these differentiated thyroid cancers are radioiodine avid. So the radioiodine scan will pick up if any residual thyroid tissue there. If it is, you can ablate.
Yes.
With radioactive iodine.
Radioactive iodine. My hundreds, maybe 1,000 patients are being, ablated by, I consider the one person who is a master for this field. He can ablate the entire gland. He's like that Dr. C.S. Bal in AIIMS, Delhi.
Dr.
C.S. Bal.
Nuclear medicine.
Nuclear medicine, Delhi.
Okay.
Amazing. I have no words less than this for him. He has been to our center earlier for the thyroid workshop, and I have sent hundreds of patients to him, and he has ablated whatever residual thyroid tissue. If it is, he will pick up, he will call me and say there is no thyroid tissue. What a kind of surgery you have done. This much of thyroid tissue was there, and they calculate the radioiodine to ablate the remaining thyroid tissue.
So all those patients in which we have done the hemi-thyroidectomy turned out to be malignant, patient doesn't want to undergo again surgery, we can send him.
You can send him, but that will require large doses of radioiodine. You have to think that. So, better is to do a completion thyroidectomy.
Then send him.
Get the radioiodine scan that will tell you what exactly is the amount and what exactly is the amount of how many millicuries of radioiodine to be given. Then radioiodine therapy. Once you have ablated after the scan everything, there should be no thyroid producing tissue in the body.
Yes.
Now you get the serum thyroglobulin level done. Now it has a value.
Yes.
It will serve as a marker. If you have a negligible thyroglobulin level and you monitor it periodically, only with the thyroglobulin, if the cancer recurs, the thyroid producing tissue comes back, the thyroglobulin will start rising.
Okay, then we have to...
Then only you have to look for again start a search for the metastasis or recurrence. You can do a ultrasound. If not fine, you can do a scan, or you can, the best is do a radioiodine scan again. That will pick up.
That scan has no value in this.
That scan is reserved for certain situations. All these radioiodine avid thyroid, differentiated thyroid cancers are not picked up by the PET.
Okay.
PET is reserved for those unfortunate patients who are differentiated thyroid cancers but not radioiodine avid.
Sir, in this case, you will wait for the biopsy report.
Yes.
And then if it is malignant, then go for the radioiodine scan.
100%.
Yes.
So, after a total thyroidectomy, radioiodine ablation, scanning, whatever, no thyroid tissue, you monitor with the thyroglobulin. And you make the thyroglobulin more sensitive by making the patient, with a TSH challenge. So, thyroglobulin assay is most important. If in any given situation, your thyroglobulin, level is rising, that should give you a suspicion of a recurrence. And then start the search with all the investigation for differentiated ultrasound and radioiodine scan. If you locate, you are able to locate. If it is excisable, remove it.
Okay.
If not, again radioiodine, you can ablate again. Again, you can follow with the thyroglobulin like this, and after the thyroglobulin, everything comes back. Just follow these patients, put them on thyroxine suppression therapy, depending upon the kind of cancer the patient had, the risk features. High risk features have to be kept on high doses of thyroxine to keep the TSH below 0.1. So depending upon the grading of the cancer, there are so many grading systems.
So why to keep below 0.1, sir?
So if you have a high risk features of cancer who are high likelihood to come back,
okay,
you have to suppress with more thyroxine.
Okay.
Low risk cancers with low risk features, then you can suppress with the less thyroxine, and you can keep reasonably good TSH level depending upon the need. So all these patients requires and meticulous lifelong follow-up. And these thyroid cancers patients do very well, for decades and decades if they are properly managed, properly followed up, and under care.
And sir, your comment about the patients of hyperthyroidism, given new mercazole become the norm.
Hyperthyroidism is a medical disease. It's two types, the Graves and non-Graves disease.
Thyrotoxicosis. Whether is there any indication for surgery in those patients?
Yes. So nowadays, see, it should be in a consultation with the endocrinologist. To be in a endocrinologist should always be pitched in the treatment. So many of the patients, are cured with the radioiodine. Radioiodine is the standard treatment. Those patients who have side effects of radioiodine can't tolerate, don't want to, ladies who want to become pregnant, so many issues.
Yes.
Then surgery is the answer.
Otherwise, it is well managed.
Radioiodine works very well in thyrotoxicosis, Graves' disease. Surgery in selected patients, not always, not that every patient of Graves' disease will require surgery.
Okay. And sir, depending upon size of the gland, I mean the doctor.
Radioiodine is the answer.
Okay. Even patient has received new mercazole, now he is a euthyroid.
Yes.
Presently.
Yes. You mean to say it is in resectable position?
Yes. He is now,
why you want to push in surgery?
Okay, no need for these patients.
Not
because
all
ultimately you see, whenever you stop this, again they will have.
May not. Radioiodine cures a number of patients.
Okay. Right. So even if the gland is bigger, size is bigger.
Size is no criteria.
Aesthetic purpose.
Unless there are compressive symptoms. Patient wants for cosmetic reasons. So many other things.
So patient wants for cosmetic reasons that the bulge is very big at the neck.
Then you can think of
you want to get rid of it.
But primarily radioiodine.
Okay, sir. I think, sir, we will request you to give one theoretical lecture on thyroid also, because there is a lot of, you already popularized the microscopic thyroidectomy and thyroidectomy, but as far as thyroid disease itself is concerned,
you must practice and know the intricacies of thyroid cancer management. This is one of the best cancers in the body, where the patient enjoys the best prognosis.
Right.
So we must, all otolaryngologists must practice thyroid cancer surgery, provided the intricacies of the management protocols, and it is not difficult. Thyroid has more difficult cancers like medullary cancers, anaplastic cancers, poorly differentiated cancers, who have poor prognosis, and they require a lot of genetic studies like medullary cancer and all. There are more complex cancer, but all those are less than 10%.
Okay.
Majority are differentiated cancers with good prognosis, and they are very much treatment sensitive. They do well.
So I think in the next Explore ENT, you prepare a lecture for algorithm of thyroid disease.
I can anytime.
The 1 hour lecture like you prepare for allergic rhinosinusitis.
Yes.
Right, sir?
Yes, 100%. And those who really want to know the standard care of management for the thyroid cancers, differentiated.
Because a lot of patients are coming to the ENT surgeons and they are writing altroxin by seeing the report of T3, T4, TSH without understanding the things.
And the gold standard, which majority follow, are the ATA guidelines, American Thyroid Association guidelines. You can go to Google, type ATA guidelines, pick up the differentiated thyroid cancer management, download, and go through. It is quite good. Majority of the centers in the world follow ETA guidelines. So you can follow the thyroid right from the investigation, workup, till the last follow-up. It has a protocol. It has a very clear guidelines from the American Thyroid Association, and that is quite popular and extensively followed.
Thank you, sir.
And you can download free from the Google ATA guidelines.
Okay.
Thank you so much, sir.
What is the next case?
The next case is CI, is almost ready. I think induced, prepared, and क्या स्टेटस भाई?
A complex one, the patient having CS1 cholesteatoma and a profound deafness, and we are going to do a same stage subtotal petrojectomy and CI tomorrow. And the JNA case is also going to be done tomorrow. So today, CI and probably some more polyp and thyroglossal fistula and something like other cases.
Okay.
So the subtotal petrojectomy and CI and the JNA will be tomorrow morning, and rest of the cases will follow today. Parotid also will be tomorrow.
The one parotid, JNA and one.
Yeah, tomorrow's first case will be subtotal petrojectomy CI.
Okay, okay.
Second probably will be JNA.
निकालनी पड़ती बार बार. हाँ जी, क्या सीन है? हाँ, क्या सीन है? पसंद में किसका? वो तो है नहीं. Dhruvas, you have pen drive with you? Also, the pen drive. I think we can carry on. In the mastoid surgery, I think many pieces are here. We do mastoid, we do modified radical, we do radical mastoid, but few issues are here. Few very minor points are there, and these are very major issues. We open the mastoid, we make a good cavity, but on major is, check कर लो. Check कर लो, check कर लिया. So one major issue that we never try, always try to make a slanting margin of the mesothelial cavity. Do proper socialization and trip removal to make the cavity, yes. That point is good. That point is coming up. If you are even if you are obliterating the cavity, again it is a major point because that flap will come in a better way, and otherwise flap will hang on the border. So do proper socialization and trip removal for the small cavity later on. That is, I think, the very important point. And suppose in revision cases, and 2 or 3, 4 revision cases, and if you do not have any graft for repair and do not have anything, then you have very important thing over there, that is the periosteal layer, temporal periosteal layer, and which has a very good innervation by the middle supplied by the middle temporal branch, and it has just you have to take out the muscle flap, temporal muscle flap, elevate it, and after proper elevation, without damaging the blood supply, because the blood supply is more on the, and you can see a rail, like a blood vessel, like a railroad on the temporal flap. Take it out, and that is a choice. Because if you want to take a 3 centimeter, 4 centimeter, even you can take up to 4.5 centimeter flap. Do not use cautery over here. Try to avoid cautery over here because it can damage, it can shrink the flap, and elevate it and just rotate it in your cavity. But that flap, it is a well vascularized flap. You can use it as a graft also. You can cover it in a mid cavity, radical or cavity, or you can use it after obliteration over the, you can cover the muscle flap once you obliterate. It is 100% guarantee of that you will get a good vascularization of this area. So if you do not have anything, then you can have. Yeah, there's so many. Sometimes you get after 2 months of 6 weeks or 2 months, your blood supply is not, the graft is there, but it is not vascularized. So there are so many causes of that delayed vascularization. And if you have done a perfect means tucking everything, then your graft will stay for a long time. But you have to find out what exactly, why it is getting delayed. And the causes are so many, that thick graft, poor graft wet, dry canaloplasty, because sometimes you try to do canaloplasty and without doing proper wash, so there is a dry canaloplasty, your blood supply get means damaged by this thing, and you can get a delayed vascularization. And you sometimes just cauterize that bleeding in the initial part, so the vascular tissue damage, or age factor is also there, improper tucking, and the most important part is the infection in the canal wall. That is the one more reason for the delayed vascularization. Just keep in mind, and if you find any focus of infection in the canal, then correct it, give a proper antibiotic, and you get a, and once your graft is there for 6 weeks or 2 months, chances of rejection are very less. Just find out the cause, why it is getting delayed. Tympanic sclerosis, and I think is very important point, and never neglect it. Do a proper assessment before taking the patient for the surgery. Explain the relatives that chances of your results are not up to the mark, may not be up to the mark. Chances of recurrence of the loss of hearing would be there because of and chances of graft survival are also very less because of the poor blood supply. So you have to explain everything before. You should explain everything before taking the patient in for these cases. And sometimes using the endoscope, 70-degree endoscope is, I think, a good option. You can use in these cases. Like this again in the face, there are almost 30-40 videos are there. Sir, video? So let Dr. Devesa to have something on the after, because before this CI case, he has his own technique and he is the mentor of so many mentors now in India. I think he revived the CI surgery in this part of country that everybody accepted. So where's that? Ready? क्या हुआ? Problem नहीं? जाओ सर. आइए सर. Because निकाल दो सर. यहाँ से निकालना है इसमें. अच्छा सर को.
So thank you, Rajiv and Sanjay Khanna for giving me opportunity to show my work in front of you. I am going to present you cochlear implant made easy by Bhopal Technique. As you know, I have started my career in 2014 as a cochlear implant surgeon, and previously I was trained under Dr. Ravi Ramalingam, who has taught me posterior tympanotomy. Then subsequently I saw Dr. Hans. He was doing Varia technique and find it very easy. But there are so many friends of posterior tympanotomy, they have got lot of objections that it's a blind technique. You do something. Then subsequently I made some modification in the Varia technique. Basically Varia or Bhopal all are transcanal technique. And as you know that the posterior tympanotomy is the gold standard, and which is started in 1946 at William House Place. But subsequently there are very few surgeons, and because of the nerve to the facial nerve injury, and sometimes they are not able to see the target area properly, there was a aberrant placement of the electrode. There is a search for alternative method so that procedure becomes little easy. And because of that, there are so many surgeons from Europe who had tried the alternative method, and subsequently the Varia technique, which was coined by Professor Trifon Keragidis from Greece. And subsequently there are so many modifications are followed, and there are more than 30,000 surgeries up till now done by the transcanal technique. And now it's a time proven technique, and in India also there are so many followers of this technique. And when I learned this technique, it was easy to perform, and subsequently it was very easy to treat. And I am proud to say that I have mentored more than 30 centers in India, and there are more than 8 surgeons who have done more than 100 surgeries, including Dr. Rajiv Pachuri, who has concluded 200 surgeries last week. So I am sharing you my experience and my technique and what modification we have brought about in Bhopal technique. So I am belonging to Bhopal, which is a place for gas disaster in 1984. So these are the living legends. Professor Keragidis, who is here with white beard. ये जलेगा, इसमें लाइट कैसे आएगी बेटा? इसमें पॉइंटर है क्या? And Professor Hans, who is my mentor, and Dr. Vishwakarma, who has also done more than 1,500 surgeries. He is Graham Clark, who is the inventor of multi-channel electrode, and he is from Australia. Next. I have a fortune to meet him in one of the World Congress in Australia. Next. He is Professor Trifon Keragidis, and he has done more than 5,000 surgeries by Varia technique, and he has invented a special perforator by which we are making the transcanal tunnel. You will see in the video. Next. Professor Ravi Ramalingam, who has taught me posterior tympanotomy, and he was kind enough to give his own patients to operate me, and it was really in his hand. The even the posterior tympanotomy technique looks very easy, and he finishes those surgeries in 40 minutes, and he's a very good and delegate friendly surgeon. Professor Hans, definitely he has done more than 3,000 surgeries by transcanal technique. Next. So these are the few slides which I have downloaded from the net. In this, you see the electrodes are there in the nasopharynx. Next. In this, the electrodes are there in the carotid canal. Next. Electrode is there in the internal auditory canal. Next. Electrode array extending into the vestibules. These are the places where electrode should not go. Electrode ideally should go into the scala tympani. And tomorrow you will see how Satish does it to make it sure that it should go into the scala tympani. Because of this, the problem with the surgeon, though they may not be experienced surgeon or they are novice surgeon, but they are not able to look the target completely where they want to send the electrode. An electrode was not gone into the right place, it has went somewhere else. Because in small children, sometimes when you do the posterior temporadomy, it's really become very difficult to visualize the target area, especially with new surgeons. Next. So the transcanal technique is a non-mastectomy technique in which we make a transcanal tunnel. We make a suprameatal well in this, but now in Bhopal technique we have changed several things. I will show you with the video. Next. This CT scan is very important in which you can see the active electrode going just behind the D is the electrode, it is just behind the posterior canal wall, and facial nerve is A, which is lying much away from the electrode array. So there is no chance of any injury to the facial nerve when we are making the transcanal tunnel. Next. This is the special instrument which is called perforator. In this you can have, this is the special drill which is 1.2 mm drill. Any electrode can go because the thickness of the maximum thickness of the electrode is only 8 mm, and this is the guard by which we make the transcanal tunnel. Next. This is the another view. Next. So the steps of operation in this, we will do the endoral approach. After doing endoral approach, we will make one flap, anterior flap and the posterior flap. Then subsequently we expose the bony area where we make the bony well. Then we make the suprameatal well, but now we are doing the cortical mastectomy to make it a landmark based technique. And then we use the perforator, and by the perforator, then we make the transcanal tunnel, put the electrode. Next. So I will show you, explain you steps in video. Next. So advantage of transcanal tunnel, it's a easy to learn technique, less bony dissection, small incision, no need for mastectomy. But now in Bhopal technique, we are doing the mastectomy. We are seeing the short process of the incus. We are seeing the fossa incudis. From where our posterior temporadomy colleague is making the facial recess, from that place we are making the transcanal tunnel. So now it's a landmark based technique. So the best for children because very less bony dissection, easy to do. It takes less time, less anesthesia. All anatomic variations of the cochlea can be handled with this technique. No foreign body material, excess electrode left in the mastoid. But now we are doing the cortical mastoidectomy and we are keeping excess electrode there because few excess electrodes are very big, and our posterior temporadomy colleagues are already putting excess electrode there with no complication. So there is no question. Next. You can see we are giving incision into the canal from 6 o'clock to 12 o'clock. Then we make this, bring this incision up to the incisura terminalis. We are making the two flaps, anterior and the posterior flap. We expose the temporalis fascia. These two flaps are made, anterior and posterior. Then we are not using any sutures. We are not using any retractors. We are using foot suture technique to retract it. We have given the incision, vertical incision. Now elevating the temporomeatal flap, keeping there. After doing the all drill work, we will enter into the middle ear. This is a straightening of the canal wall. Then parallel to the posterior canal wall, we are making a cut. Then there is a C-shaped cut to make the cortical mastoidectomy. This is the previous one in which you are not seeing any landmark because we have only make the suprameatal well in this, not doing the regular cortical mastectomy. Now we will raise the temporomeatal flap, enter into the middle ear after doing the all bony work. You can see the panoramic view of the middle ear. You can see the round, this is the perforator by which we have made the transcanal tunnel just behind the posterior canal wall. You can see I am doing the cochleostomy now. Irrigation from the transcanal tunnel. This is the Neuralec implant which was supplied by the EDIP. We are screwing this implant, putting the ground electrode there, and through the transcanal tunnel, we are just entering into the cochlea. So if you make your cochleostomy in tandem with the transcanal tunnel, you can see how easily it will go there. And as soon as you enter into the transcanal tunnel, your electrode gets stabilized. So even for a new surgeon, there is no bobbling of the head. There is a ring in the implant which gets fixed there. And because this implant has got the very short electrode array, so this much of transmeatal well is enough for accommodating this excess electrode. After putting this, we can close the wound in 2 layers and bring back the temporomeatal flap. In this, all those steps are there which every ENT surgeon is doing every day while they are doing the tympanoplasty. The only 2 things you have to learn: number 1, how to use the perforator, and number 2, how to put the implant. So wound is stitched and packing is done. Next, sometimes if you have make your cochleostomy in tandem with the transcanal tunnel, your implant will go easily, like you have seen in the slide. चला ना, डबल क्लिक करो तो चलेगा ये, इसको प्ले कर दो. हाँ, yes. You see, it is going directly into the, so it's a smooth insertion. Sometimes even if you don't have this kind of a smooth insertion, your electrode array is going somewhere else. With the help of claw, you can direct to the cochleostomy. Next. In this, you can guide, like this implant is going there. It is not coming, you are not able to see it. So with the help of claw, it is going above. You can bring down with the help of claw. This is the instrument which is known as claw, and direct towards the cochleostomy and push it like this. It will go again. Next. Sometimes there is a complication also, injury to the chorda tympani nerve when you are making the transcanal tunnel. It has got the little learning curve because sometimes you can puncture the posterior canal wall also. So whenever you do the mastectomy, you will preserve the bone dust. You can cover this defect with the bone dust and ultimately bring back the temporomeatal flap again. Next. You see there is a injury to the tunnel while we are making the transcanal tunnel. So there is a big rent you can see, but the annulus is intact there. So all this rent can be covered with bone dust and you can bring back your temporomeatal flap. This case I have done in 2014. Still he is in follow-up, doing well. There is no formation of any cholesteatoma or bony pearl. So this can happen if you don't straighten your canal wall properly, because usually the concavity is there in the posterior canal wall. So there is a big rent. We will take the bone dust. First you put the implant there, then subsequently you are going to take the bone dust and cover it with temporomeatal flap. So because these are the initial cases, you see, after placing the implant into the suprameatal well, we have covered it with the bone dust and we will bring back the temporomeatal flap. Next. The Bhopal technique, what we do, we make the transcanal tunnel after doing the cortical mastodectomy. Now, cortical mastodectomy is being done in this case. You can see the short process of incus there above. So the mainly objection, you can see the short process. There is a fluid is going from the tunnel, I mean editus. So after putting implant, what we do next in each and every case, we put one temporalis fascia graft also to re-strengthen the tympanic membrane. You see the excess electrode is accommodated here, and this excess electrode is covered with the gel foam so that it should not come accidentally into the suture. And now in each and every case we will put the tympanomeatal flap, even the perforation is there or not, because if you put the tympanomeatal flap, it will give strength to your tympanomeatal flap. If in case you have to do the revision, then also elevation of the flap becomes very easy. We will bring back the tympanomeatal flap and put compressed gel foam over there, which will soak blood and keep this tympanomeatal flap in place. Next. Now this is the another addition in our armamentorium. Piezotome we are using. The piezotome is used by our spinal surgeon and dental surgeon. Piezotome, when you do the spinal surgery, piezotome, what it will do, it will, whenever nerve is there, it will stops. In few cases, what we have seen, if the proper irrigation is not there when we are making the transcanal tunnel, because of the heat dissipation, there is a cases of facial paralysis. But in this, that remote chances is also gone. So next, in piezotome, this kind of, we have ordered them to make this kind of probe for us by which we are making the transcanal tunnel. So absolutely protecting the or avoiding the any chances of injury to the chorda tympani. After making the tunnel, they are modifying it so that it can become like a perforator. One Chinese company is there who is working with us. It's not very costly instrument. It's costing only 1.5 lakh rupees, and it will be used in cases of rhinoplasty also. When you want to do the internal osteotomy very clearly, this piezotome is being used. It will take little more time than the drill because the bone cutting is little slow in this. But irrigation channel is there in this instrument. So after making it, we'll put a suction and see that it is coming into the middle ear. Next. So up till now we have done more than 1500. This is the tally little behind. I think it has crossed already 1800 cases, and even we have done few cases of congenital anomaly, Mondi's deformity, cystic apex, and all cases can be done very easily. Even the gushers are very easy to control with transcanal technique, because as soon as you elevate the tympanomeatal flap, you have ample of space to see and work. Next, we have published our Bhopal technique, and one of the center in Amritsar, Guru Ramdas Medical College, they have also done more than 50 cases with this technique, and they have also completed the 100 implants. Next, this is the surgical review of Amritsar. Next, and this is the piezotome. We have published a paper for this also, and it is being used in one of the place in Rajasthan. Also, one surgeon is using this piezotome for making the transcanal tunnel. Next, these are the different center where I mentored. Next, these are few patients of mine. I am thankful to them because they have shown faith in me. Thank you very much for your patient listening. If any questions, I will be happy to answer. Yes, sir. Definitely, sir. That is how, because we always respect our posterior tympanotomy colleague, because of them, we are getting today implant. And senior professor like Kirtan sir told me several times that Dubai is a blind technique. But subsequently, I thought what should be done. And ultimately, we followed their steps only. We do the cortical mastectomy, we see the fossa inquiris, and from where they are doing the starting the facial recess, making of facial recess. From where we are making the transcanal tunnel. So I can tell them that now this is not the blind technique; it's a landmark based technique. Yes, yes, same area, because ultimately we have to make a tunnel of a size through which we can put our implant in. That's all. And even the another thing which was told by me that whether the round window approach can be done by this method or not. Though I have not tried because I am getting consistently good results with this. But the Kranti Bhavna from Patna, she has done I think more than 100 cases with Varia technique only, with facial, extended facial, extended round window approach only. It's a basically, sir, I have to give credit to all the Varia technique people. It's a basically modification of the Varia technique, because the objections which were raised against the Varia technique, I try to solve those problems, address those problems. And another addition is 4 things which we are doing is the extra things, like we are using now pisotome, number 1. Second, we have made it landmark based doing cortical mastectomy. Third, we are putting a tympanometer everywhere, temporalis fascia graft to re-strengthen the tympanic membrane. Fourth, we are not using any retractor. We are using 4 suture technique to retract the flap so that there should not be any cramping of the space. But the whole idea is from there only. So it's a variant of the transcanal technique. Before Varia, there are so many people who have made so many efforts to make the transcanal technique. Few people have made the trough into the canal wall and subsequently put an electrode there directly and put a cartilage there. But it has been seen that there is some wetting there, some short circuit is there. The idea is that there should be all around bony covering should be there around the electrode. The both techniques, posterior tympanotomy and Varia, follow this principle to put all around bone around the electrode. Ultimately, see, absolutely right. You see, when Trifon has started making this transcanal tunnel, he has made this tunnel only with the drill only. Then subsequently, to make it more easy, he has introduced the guard. And you see, when I have made, after doing a lot of Varia operations, when I was using the pisotome, I have not enjoyed the canal wall. So, I mean, it has got some learning curve, but ultimately you learn to, I mean, face that trajectory to where you have to go. I requested that company also that you should make like this only. So it will be more popular in our country and people will buy more. In place, you should have a provision of guard also. I think they will make. Thank you, sir. Thank you, sir. Sir, thank you, sir. Because of the advent of the so many state government programs, there is a need for the locally available surgeon, and there should be a method which can easily be followed. That is what the idea behind it. Thank you. This perforator cost 14,000 rupees, made by this Bell company of Delhi. Implant तो सर सरकार 6.5 लाख रुपए देती है और इम्प्लांट जो है वो 5,25,000 से 5,85,000 तक का आता है. Just
so I think wonderful approach is very as Dr. Dubey sir. Now next we are going for the posterior tympanotomy, and their groups are there, I think, but I think we all are together. So whether you are posterior tympanotomy surgeon, whether you're a varia surgeon. So if you are a varia surgeon and or you're a posterior tympanotomy surgeon and you get such sclerotic mastoid and you have to do, you don't want to use the this andoral approach, then what you have to do? So this was a case just for this. It was a, so we have started doing this modified varia, you can say, or you can say post-oral varia. And this was a case did I think last year. So I was planning to do posterior tympanotomy with the posterior tympanotomy approach. Somehow I found that the zero was with anterior. So on table I changed my program, explain this way. And I do both the techniques, post-oral varia, which is this normal varia plus posterior tympanotomy. So on table just decided to go along with the post-oral varia, in which you have to do nothing. The issue with the endoral varia is that you open the middle ear and the outer atmosphere this you can say exposed to the cochlear tunnel. So in this you can preserve this, just you have to elevate the posterior canal wall easily. That you can do, just have patience. It takes hardly 3 to 4 minutes extra. Elevate it and you preserve the chorda like you do in the Satish case. Elevate the flap and it is clear. Okay. So just 3 to 4 minutes, it is a time of patience. Try to maintain the wall as well as the membrane. And the canal wall is filled with betadine, so you can check, suppose any betadine leak is there, then you can find out on table. So it was well intact, the middle ear was well exposed. The canal wall was just made straight to maintain the guide, or you can say guide, and just have a look at IS joint. Just this drilling and curate was just to make it straight. Small well was made to hold the electrodes, and the site for cochleostomy was just point was made, because if you make a pointer for the cochleostomy, then you use your burr in that direction. It was just to stabilize your drill. Same guide wire, same drill as used by Dr. Dubey sir, and we are using since long time. And it takes hardly 30 seconds to make it. Lot of drilling, lot of water should be there, proper irrigation should be there. The angle of the whole the canal should be towards the future cochleostomy. The bed was created for it was a metal implant, so nothing specific. Cochleostomy, just enter inferior to the round window. Now we are doing round window insertion in most of the cases, since I think 40-50 cases been done by round window. It was a load case, and straightforward. Implant, insertion, electrodes, everything was perfect. So this is one more way you can do implant. So because issue has been discussed, though it has effect on outcome or not, that in the endoral approach they say that you are exposing the middle ear to the outside end, because you are opening the canal wall. So here you can correct it with the post-oral. approach. This is one more, this is just a one more approach, it is in between approach between two things. So we all, whatever if you're doing implant, you should know all the techniques. You should know if you're doing, you're a various surgeon, even you should know how to do a posterior tympanotomy. If you're a posterior surgeon, then you should know also vary also, because in some cases like this contracted method, if you in contracted method, you have to drill that part, and it took almost half an hour extra to make that area. So with the area, I saved my time. It was simple, straightforward. And few cases, I think, and always I place a small Miss Craft over there, as suggested by Dr. Dubey sir, just to make it more strong, because it is a foreign body. So that was one more approach which we have done in few cases. That's just after seeing your report, I just
You can
thought-
name it Agra technique.
No, no, sir. Sir,
Dr. Pachori, actually there are so many surgeons doing, like you told you did a round window insertion after cochleostomy. So your personal experience, what is that? What was the benefit of it?
No issue with running Miss
Round window insertion.
No, the round window is very again now, since I am started doing with the posterior panel also, and now electrodes are very good. This small electrodes 422, and if you are using round windows, it takes hardly 3 minutes to open it. Make a small burrow, use a small burrow over there, and it's very straightforward.
So you extend it in anterior inferior. That you have to do.
Yeah, that they have to do.
Acha, I want such a big audience is there. Any case in which after 10 years the implant need to be replaced?
Yeah, there are I have done two explantation because of the heart failure.
Hardware failure. But as such, there is some life of this implant because we are implanting a small child. So does it occur that after 15, 20 years, we have to put again an implant? Because this issue many parents ask.
No, definitely. You see, when there was a meeting in Mumbai,
Yes,
Dr.
sir.
Mohan Kameshwaran has given a statement that every implant you have to revise if you live longer. Otherwise, your junior will revise.
Okay, so that is having 40, 50 years.
No, warranty which company has given is 10 years.
10 years.
10 years. But there are patients who are surviving after 25 years. With that
Implant lasts for 25 years
25
also.
years. But definitely we have to revise all our implant in their life. Either we should revise or our younger children will revise.
Technology may be upgraded, so that time also we may live.
Yeah, very blunt but real statement by Dr. Kameswaran, because you have to do this. If you are doing an implant in 5-year-old child, 100%. If this child is going up to 90 years, that child will need a replacement, or it is 100%. Because maybe failure, maybe some modification.
This is a very important thing, no? Once they require it. Thank you, sir. Thank you, Dubey, sir.
Sir, one more question. Have you seen any cholestotoma after putting posterior tympanotomy route? Electrode through posterior tympanotomy?
Very small experience. Only since 8 years I am doing, but because till date I have not seen any case. But Dr. Dubey is doing since long time. I don't know.
I have an experience of having infection in the ear. I have explanted. In few cases, I have got the flap surgery done also, but that flap surgery also failed. We definitely have failures.
One failure because of wax. Bone waxes should not be used in implant. That one failure we have.
I have done around 20 cases till now. I have seen one case who was a child. After about three months, he started with acute otitis media, medically managed. Then later he started developing retraction, and after that he developed full-fledged cholestotoma. Then I was worried that while I will explore the method,
Tomorrow we are going to show the case.
This tomorrow's implant case with petrosectomy. One side is cholestotoma, other side this child is having ASO, recurrent ASOM. So just for prophylaxis, we are doing with petrosectomy, because I suppose I had done this case on the left side. In future again, maybe after a few months, maybe a few years, I had to repeat this case. That's why we are doing prophylactically. This tomorrow cases I brought from Agra. So it is a typical ideal case for petrosectomy. Sir.
So after listening Dr. Dubey sir and have seen the wonderful surgery by Dr. Satish Sharma, so we are here to discuss the one more most rewarding ENT surgery is the stepidotomy, which gives wonderful results. At our setup, we are doing this surgery under general anesthesia, and after infiltration of canal wall and post-oral incision with 1 in 60 lakh xylocaine with adrenaline. Post-oral incision is given and posterior canal wall is thinned out before opening the middle ear. And here you can see that the middle ear is open. Then this thinned out canal wall is removed by using the curette, and chorda is retracted anteriorly. Diagnosis is confirmed before starting the surgery. Here stipage is fixed, incus and malleus is mobile. Chorda is retracted anteriorly. IS joint is dislocated by using the right angle pick. Then the iris, the stapedius tendon is cut by iris seizure. And this posterior crura is cut by using crurotom, and the stapes superstructure is removed. Now you can see the foot plate, and the skeeter is used to make a hole in the foot plate. You can see a hole in the foot plate, and piston is measured and placed. Initially, I was using the piston of 0.6 mm shaft thickness, but now I am using the piston which the shaft thickness is 0.4 mm. Free inside out movement of the piston is checked. Once I move the handle of the malleus, you can see the free movement of the malleus. Then fat is used to seal the fenestra, and this will reduce the post-operative dizziness and vertigo significantly. Then chorda is placed lateral to the piston and tympanomeatal flap is reposited back. Most of the patients are discharged in the evening. This is the daycare surgery. This is the final outcome, and 2-3 sutures are used to repair the post-oral wound. This is another case. Same post-oral incision under general anesthesia. Axial thinning of the posterior canal wall is done before opening the middle ear. Then middle ear is opened by using the sickle knife. Stapedial joint is identified. Plaster is used to further elevate the flap. Pseudostapedial joint is exposed. Posterior canal wall is drilled out, and you can remove the canal wall till you see the tip of the pyramid. Safely you can remove the canal wall. For good successful surgery, you should have an adequate exposure. Again, diagnosis is confirmed. Incus and malleus is mobile, stapes is fixed. Then the hole is made in the foot plate by using the 0.5 mm bar on skeeter. Posterior crura is cut, is drilled out by using the drill and crurotom. Here I am trying to preserve the stapedius tendon. Anterior crura is now fractured. So the superstructure is freed from the foot plate, but tendon is preserved. This is the cell phone placed over the foot plate. The hole is made in the foot plate. You can see now under magnification. And most of the time, the length of the piston is 4.25 into 0.4 mm. You should be able to see the distal length of the piston. That is, and sometimes this eye of the piston is crimped by using the crimping forceps. Again, the free movement of the piston is checked, and fat is used to seal the fenister. So most of the time we are able to preserve the stapedius tendon in stapes surgery. Tympanometal flap is reposited back. Another case, same technique, post-oral incision, general anesthesia, thinning of the posterior canal wall, diagnosis is confirmed, malleus incus is mobile, stapes is fixed, IS joint is cut, then this stapedius tendon is cut, and suprastructure is removed. Here you can see that the facial nerve was lying exposed at the second genu, and very narrow oval window niche. Very narrow oval window niche. Hole is made in the foot plate and the piston is placed. So you have to be very gentle. Suction, once you open the vestibule, suction should be avoided. And if you have to do suction, you suck away from the foot plate area. Don't suck directly over the foot plate once you have made the hole in the foot plate. Then the movement, free inside out movement of the piston, once you move the handle of the malleus. Again, fat is used to seal the fenister. Most of our patients are discharged in the evening. Tympanometal flap. Sometimes this patient has a very thin tympanic membrane due to recurrent Valsalva maneuver. And there are inadvertently some minor perforation in the tympanic membrane in spite of all precautions. So temporary fascia should be used to repair the perforation immediately. Another case, egg cell thinning of the posterior canal wall before opening the middle ear. After egg cell thinning, tympanometal, this middle ear is open. The thin canal wall is removed by using the curette. Diagnosis is confirmed. Malleus and incus mobile, stapes is fixed. Then again the posterior crura is drilled out and the stapedius tendon is preserved. Hole is made in the foot plate by using skeeter. And eye of the piston is crimped by using the crimping forceps. The purpose of showing this video is that postural approach is a good one for beginner. Give wide exposure. Your both hand are free and it is very easy to do. Later on, you can shift to the endometer once you are experienced one. But for the beginner, it is a good idea because you have a very wide exposure. Your both hand are free. You can manipulate your instrument much more easily. Another case. Two-millimeter diamond burr is used for thinning the posterior canal wall before opening the middle ear. Again, this thin bone is removed. Chord are retracted anteriorly. You can see the bluish foot plate. This scrutiny saw is used to cut the posterior crura, which is usually very thick. Then hole is made in the foot plate. And this 0.4 mm thickness piston is placed. The usual length, as I told you, it is 4.25 in most of the cases, but sometimes I have to use 3.75 and 4.5 also, depending on the situation. But the commonly used length is 4.25. Fat is used to seal the fenestra to avoid the postoperative dizziness and vertigo. Another case. The idea of presenting this presentation is to encourage the younger one to take up this surgery. And this thin bone is removed very easily. Chorda, you should try to preserve the chorda as much as possible. IS joint is dislocated, and here you see the position of the incus sliding down. And in this case, I use 3.75 mm length of the piston. Because the direction of the incus is sliding one. The hole is made in the foot plate and 3.75 mm piston was used in this case. Due to the position of the long process of incus. I am not happy with the position of the piston. Again, little bit maneuver. Here you can see the exposed facial nerve is covering the upper two-thirds of the oval window. but still there is a space between facial nerve. I can see the foot plate, and carefully the hole was made in the inferior part of the foot plate posteriorly, and this is the facial nerve exposed, divide of bone, posterior crura area. Care is taken while using the skeeter, don't without touching the facial nerve. So we were able to put the piston, even the facial nerve was covering the part of the foot plate. In one or two cases, I have to abandon the procedure where the foot plate was completely covered with facial nerve. One or two cases, I still remember. And in one case, accidentally we fractured the part of the long process of incus. So that was a very interesting idea. I just placed the coda over the remaining part of the handle of the long process of incus, and I hang the piston with coda, and there was a free transmission of the movement, and that patient is still under follow-up, is having good hearing for last 2 years. Only complain of some change in the taste, but as far as the hearing is concerned, she is doing well. So all these idea comes when you are in the problem. Again,
Sir, have you got any case in mania diseases also there? Patient having tinnitus and all?
no, tinnitus, most of these otosclerotic
No,
patients has a
like
tinnitus.
pre-existing mania syndrome with otosclerosis.
I cannot diagnose that case as a Meniere's, but with conductive hearing loss, I have seen many patients with tinnitus. And when we do surgery, we just say that we will improve the hearing. We never say that tinnitus will go. But I am telling you with my experience, with the time, 3 to 4 months, most of the patients say that their tinnitus has gone. But when you are giving prognosis in preoperative counseling, I always say I am doing surgery for hearing. Tinnitus may persist or even may worse or may go. But believe me, most of the patient, the tinnitus will disappear within 3 to 4 months after surgery. I have seen personally, means that disappears. For this surgery, you need a good instrument. Every step for you have a specific instrument. Suprastructure removed, skeeter, hole is made in the posterior part of the foot plate. Sometimes the position of the long process of incus have in such a way that it become difficult to put the piston, but you have to modify accordingly. Thank you very much for kind listening. as for to do, yeah, no. Actually, posterior crura is very thick. If you want, if you fracture it, sometime accidentally the foot plate will come out. So to avoid that complication, it's better to drill or cut the posterior crura with either with the burr or with crurotomy saw. Initially, when we were postgraduate, we were taught in PGI that you just by the movement, side to side movement of the right angle pick, we used to fracture the crura. But once in a while, with crura, either whole of the foot plate or part of the foot plate will come out. So just to avoid that complication, it is better to cut the posterior crura. Anterior crura is thin one, that will be fractured without any problem. But posterior crura, either you have to cut it or with this. Oh yes, either you have to thin with multiple movement of this right angle needle, or some has a crurotomy forceps by this some. No, that I have never seen. Only as I told you, once I was removed the posterior canal wall. Accidentally, there was a fracture of the long process of incus. Then I was in a soup. What to do? I tried to find out to put the piston in the neck of the malleus, but I was not, means I did not have a proper instrument and proper piston to place there. Then that patient has a very thick chorda. I just retracted anteriorly and placed it over the remaining part of the this long process of incus, and anchored the piston with this chorda. And once I move the handle of malleus, that remaining part of the incus move, and with that chorda is moved, and the piston movement were transmitted. I kept my finger crossed, but that patient has a good hearing, and now 2 years is a follow-up. Last week she came to me for, means another complaint, URTI. When she comes to my OPD, I always fear that the thing has gone. So I always ask what happened. She said, नहीं मुझे खास जुकाम है, मेरी सुनाई ठीक है. But she, no, I have seen in one case, that piston was extruded rather. And when I re-explore it, there was a necrosis of long process and piston was in the canal wall rather. And that case, I don't know what happened to that case. That case was done at a workshop at my center by my friend, my close friend, and he is the best otologist at present in the India. I don't know what happened. So sometimes you don't know. That surgery was done so meticulously by one of the best otologists of the India. And after 6 months, the patient has a piston in external aortic canal subcutaneously. When we explore, we found that the long process of incus was necrosed, piston was out. Thank you very much.
नहीं 20 दे दे 20 दे दे इतना दे दे वो तो हाँ और क्या हेलो फिर चेक पानी दे हेलो ऑडियंस यहाँ से है नहीं यार आवाज आ गई अब आ गई हेलो
Hello, we are getting the image, sir, and voice also clearly.
Okay, okay.
And can you brief us of the progress, sir?
So what we have done till now is a routine incision for cochlear implant. This is the superior base flap. This flap was like this. We have given an incision from this here to this, and going posteriorly, a U-shaped incision for the flap, and we have raised the flap to the superiormost area. So we have already done the welling of this for CI. So we are creating a well. We will be using the nucleus implant. So we have reached the dura.
I think that is more than enough now, I think.
Suddenly,
Picture is clear?
Suddenly image became very nice. I think now again gone. This
Okay.
is better. Like since morning, this is the first time the image is being so good.
Okay. So to control the bleeding, I am using the diamond burr here. This will be the posterior tympanotomy approach, and shortly Satish will join here. We have already drilled the minute holes for the thread to hold the implant. Picture is clear?
Yes, so out of focus little bit.
Okay, okay. So line there.
Now the picture is better.
Okay, okay.
Let it continue in same mode, whichever mode it is.
I am doing the homework for Satish.
The homework is the main thing.
Picture abhi baki hai.
You have to go posteriorly. I think.
Yeah, yeah. So hope people are enjoying the academic.
Many good lectures being done since morning. Dr. Dubey sir, Dr. Umbir Singh, Dr. Kapila.
सतीश को पूछना आ रहा है क्या?
And the child is 4 years?
8. This is a post-lingual case.
Okay, it is. He is a
post-lingual case, and was using hearing aid initially, but speech was not much developed.
Do you do some evaluation for this post-lingual patient why they developed it, like syndrome?
Actually, the AVT is the main problem, and after hearing aid, the speech therapy is the main problem. So they are not coming regularly for speech therapy after using hearing aid. So this is the main problem, but they were convinced about the cochlear implant, and now the child is having bilateral profound deafness.
या फिर यहाँ पे फोन जो नंबर का है वो भी उसमें देखो उधर कितना ऐसे करते हैं ट्रेनिंग सही नहीं थी करो ना आप
बोलो ना सर्जी से एक छोटा टुकड़ा सर्जी से छोटा सा ड्यूरा हो गया ना Hello. Yes, yes. So what I have learned till now, I am using all the three approaches for doing CI, all the three techniques. Maybe varia, posterior tympanotomy, or modify varia, as Dr. Dubey told us.
We had a long discussion about.
Yeah. So we have already discussed everything. Just polishing the well area with the polishing burr.
It's, I think, more than enough. Shining.
So for the information of the audience, there is a small information. We will be having a small inauguration session, and this is just we are having a member from the Haryana Medical Council, and we have been accredited with 4 credit hours till now. We are fighting for further hours, and if they are increased, then we will change the certificate also. But till now, we are having 4 credit hours with us. So
it
we
takes
are
a lot of homework to get all this.
Yeah.
Yeah, really great work done by you.
So we are having Dr. Pankaj Mutneja from Panipat. He is the member of Haryana Medical Council, and he will be the witness for this. We have already shared the YouTube links, and he will be there in the inaugural section. It will be around 7:30, and all are requested to be there.
7:30.
Yeah.
You will be here or not?
Me?
So face it or fast. You have opened the asteroid?
No, we are going to
do that part.
Yeah. वो देना जरा कोड हो गया. हाँ गड्ढा भी हो गया. डिटेक्टर लगा यार. हाँ साइजर हो गया सारा. ले देखो. छेद ही बन गया. बना दिए. ये बना दिए ये.
Zoom out a little bit.
So Dr. Satish will be joining, and I will start the drilling part, opening the mastoid area. ये डाल देता हूँ. So the most difficult part of CI is putting a thread in small holes and tying the implant. So this is the most difficult part here.
You are still putting the suture?
Yeah. I am saying I have already told you that I am doing the homework for Satish. नहीं वो दो hook दो. Fine hook. So ये वाली के So this is the difficult part for me. हाँ वो ना राइट एंगल चाहिए. ये हटान रिट्रैक्ट सेक्शन कर दो. वो देना फोर्स बड़ा. पिक क्या पिक चलो निकल गया रहने दो, हो गया. So this was the most difficult part. एक आर्टरी दे दो. Picture is clear for you?
Yes, it's very clear. This is microscopic picture, huh?
Yeah, this is a microscopic picture. We are using.
Now it's not good. What exactly is going on? Means is
Nothing is going on. We are tying the thread with the artery and.
No, picture quality.
Picture quality. Picture quality क्या हो गया? यहाँ पे ठीक आ रही है.
Now it is better.
आगे सर. अब ठीक है?
That's okay.
Okay, okay. वो देना है ना. इस पे कुछ रख दो, वो रख दो सर्जिकल के पीसेस ना, इस पे थोड़ा सा वो कम हो जाएगा. चल रिट्रैक्टर लगाना है यहाँ, बड़ा लगी हुई है यहाँ रिट्रैक्टर लगाना. So opening the mastoid. कटिंग कर दो एक. चलो ज्यादा चलें डालो. Routine approach like we are doing in cortical mastoidectomy. The spine. This is a cellular mastoid, so no problem with drilling part.
अब जाने की बोल रहे हैं कि राजस्थान चलेंगे नंदू हो रहा
Sir, picture quality again deteriorated.
क्या हो गया?
It was now it's okay. What is this exactly?
Sir, ये कुछ फोकस का हो रहा है, फिर से खराब.
Focus issue.
No. Now just change it to the previous mode.
No. नहीं सर, मोड चेंज हो गया फिर से.
मोड चेंज हो गया.
No.
एक मिनट. अब ठीक है?
That's okay. Okay. चल जाएगा.
ये चलाओ नहीं काम बढ़िया.
That's okay.
बढ़िया चलो यार.
So
नेचुरल दिखता ही है.
ब्लॉक हो गया. Yeah. We are having super assistants from the assistants of the Dr. Satish. They are expert and we are thankful to them. They are also our teachers, basically.
Hello, yes. So now what are the landmark you will go for, right?
So this is, you have been able to see the short process, the incurs.
Which drill are you using?
This is a Smith Nephew drill, Spiegel.
Okay.
So over to Satish now. वो जो एंट्रोप्रेन्योर हाँ हाँ सर जस्ट मिनट माइक देते हैं
Hello.
Yes, yes.
Yes, boss. So you have seen this super work from
ultimate
boss. So I'll just finish off. Now most of the job has been done. किधर है किधर ये किधर चल तो रही नहीं ड्रिल क्या हुआ
ये वाला था नहीं नहीं आपका पीला वाला दबाओ पहले अब चलो
Hello.
Yes, yes.
See, let me see what has been done. Show you. He's already made the. हाँ कोई बात नहीं. Well for the implant.
Yes, yes.
ये बस कितना स्पीड कैसे कम है?
Zoom out little bit.
ठीक है रख दो कुछ. ये डायमंड दे दो. Give me a diamond. See some bony use. I can always use a diamond. For bony bleeding, you can use either a dry diamond or bone wax.
Bone wax, I think you recommend here in this, I think.
अरे इतना मोटा कमाल करता है यार. For soft tissue bleeding, you can use either Surgicel or bipolar.
Yes.
Now this is the getter for to carry the cable. थोड़ा छोटे देना कटी. And see, you need a crude cortical mastectomy, which has already been done. So next is the what we had discussed yesterday in the cadaver dissection. A posterior tympanotomy.
Yes.
See, this is to complete this gutter. So all the cable and everything remains hidden. And here I will make a little bit overhanging edges to tuck the cable in case required. Because this cable length is always, in children, the mastoid side is not that big and the cable length is something which expands with time as the size of the mastoid expands. Okay? Now, cutting the body. In the mastoid, you can see the lateral semicircular canal and incus. Can you see?
So can you centralize the picture?
Now?
Yes, sir. So can you show the lateral semicircular canal once again?
Alright?
Lateral semicircular canal.
Yeah, let me show you.
This one.
That is the lateral semicircular canal. See that?
Yes, yes, sir.
This is the posterior canal wall. The lateral part I am thinning more and more. The same landmarks we discussed yesterday for the posterior tympanotomy. Remember?
Yes, sir.
That is incus. Short process of incus is one of the best landmarks.
Drill along the short process of
Yes, the facial nerve is always deeper to the short process of the incus. See this? I am parallel to the short process of the incus. एक side छोटी. See the short process of the incus in view?
Yes, sir.
In order to enter into the facial recess on a safer note, we are supposed to see the facial nerve medially, and to avoid entry into the canal, extraordinary canal, or injuring the annulus, to stay on the safer side, the best landmark is caudal temporary. These are the two landmarks. If you follow and find, our facial recess is always between this. See the incus, always keep the reference of incus. Can you see?
Yes. No, sir.
But now visible.
Now visible.
Yes. One minute. I can see some landmarks to show you.
Cell just below the
Cell of the facial recess, yes, is one of the landmarks. Then I can see both the nerves in view now.
Yes.
Let me show you. I can see the color change, the area of the facial nerve. Can you see the reddish hue below?
Yes, sir.
Can you?
Yes, sir.
That is facial nerve. See that?
Yes, yes.
And see that is caudal tympani. Can you see both the nerves?
Yes, sir.
Use the largest possible burr for the region, wherever you are working. That's the basic principle of drilling. For whatever region, wherever you are working.
So you are using the cutting board
so far. See now, I can see the cell of the facial recess now.
Yes, sir. Yes, sir.
इसको diamond दे. See, एक side छोटी diamond है. Now we'll change to the diamond and show you for the landmarks. This will give us a backdoor entry into the tympanic cavity, retrotympanum. See this?
Yes, sir.
This is a great guide, one of the cell opening is a great guide here. Big side chota.
Just,
Can you see the quad and facial both?
Yes, sir.
yes, sir.
Very clear?
Very clear.
And see this facial recess. So clear?
Yes, sir.
And now,
Even we can see the glimpse of starting of the round window niche.
big side choti.
Wow, the whole round window.
Now, yeah, I am removing this bone anterior to the facial now. Anterior thinning of the facial ridge. See this? The glimpse of the round window visible. See the tendon of stapedius. See this?
Yes, sir.
Very
Yes.
clear.
The same anatomy we saw yesterday. For junior colleagues, practice more and more on caliber. And see the round window.
Yes.
Yes.
Round window membrane is also visible.
Yeah, little glimpse of it.
Yes.
The niche is there. Let me extend it. Make the use of the entire facial recess. See this? As I am going further, reducing the size of the burr. Can you see?
Yes.
And this is more important, anterior thinning. Deep to the facial now. See this burr you were asking yesterday. See the long tapering burr. Can you see?
Yes.
This is my special, cochlear implant burrs.
So that accidentally your rotating bar should not hurt
Yeah.
to the facial.
Yes. Now this is your round window niche. धीरे धीरे यार ये मत डालो मत डाल See, I am removing the round window mesh.
Yes. Yes.
And now see the round window membrane.
Yes, very clearly.
See more time. See the complete membrane. Can you see that?
Yes, sir, clearly.
Now I told you yesterday we discussed in detail. If I open up the round window and push my implant, see the direction of the membrane. It is the implant is first going to go and hit the
Modulus.
Modulus. You saw the modulus yesterday, the entire anatomy. What I want to push my implant in a tunnel. Straight antero-inferior tunnel. Inferior means in the inferior tunnel. You saw a lot of tunnels yesterday. Remember?
Yes, sir.
So what I am removing?
Inferior part of round.
Yeah, the inferior bone adjacent to the round window, that is known as crista. I will not remove the anterior bone. See, remember you saw yesterday what is there anteriorly? That's what membrane.
Scala media.
Never ever try to go anterior.
Scala media.
You'll end up damaging the basilar membrane, and that is the intracochlear trauma which you don't want. So now, right angle chota. Okay. करना था है ले लिया ऊपर लिया सामान किसी को ले जाओ साथ आ गया ग्रेट 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 है आ गया आइडिया लग रहा था आपका हेलो
यस सर
मत डाल पानी मत डाल धीरे see what I'm be careful not to go in the medial wall, not to go anteriorly, just inferior widening. See, only inferior widening I am trying to. Steroid. Now, give me the right angle. उसमें लगवा दो ये सामान जो लेके आया ना हाँ क्या हाँ लेके आया ना ये लिया है ना अब तो कनेक्टर का चक्कर नहीं रहेगा ना Can you see after removal of the round window? Hello?
Yes, yes, very clearly seen. Even the blood vessels of the stellar tempora is seen.
I will further little bit widen it.
चला जाएगा.
Which electrode it is?
पतला दे पतला दे See, further widening only inferiorly. बंद है यार. Hello?
Yes, sir.
Now see the tunnel. Can you see?
Yes.
Yes, sir.
Straight tunnel.
Straight three-dimensional tunnel. I am washing with the steroid solution. That is flush away. That will flush away any bone dust or anything. See this? Never ever damage the medial wall. And see now, this is inferior trajectory.
Yes.
Inferior trajectory means?
Scalar tympani.
Scalar tympani. See this?
Yes.
So clear.
Right.
Wash. Wash. You know? This is steroid wash again. And this is amazing inferior tunnel. See this? Now, if I push my implant, see my modulus is left on the left side. See that? See the modulus is on the left side.
Yes, yes.
Can you see?
Yes, sir.
Here is the modulus. See here. And my direction of the implant would be this. Can you see straight tunnel?
Yes, we can see.
So my modulus is now left behind on the left side. And now I have the implant insertion will be a child's play. It will go in the straight tunnel, nowhere else. Got my point?
Yes.
It will not hit modulus, it will inferiorly directed, it will not hit the spiral lamella. That is what the message I wanted to convey to understand the inner ear anatomy. We have seen inner ear anatomy yesterday, how the cochlea is, made up of how the cochlea is oriented. I have pushed the gel form, soaked in steroid, leave it for a while until I fix the implant. Okay? Hello?
Yes, sir.
Now I will harvest two things. Cutting the bonus league. Already harvested or periosteum? Give me something to harvest for you. You have already harvested bone dust. Now I need to harvest some periosteum. So either this is periosteum. See this? This is a tough tissue which we want. That's it. Do you see?
Yes.
Now before I insert my implant, I will thoroughly wash, irrigate, see if any
bone dust,
see if any bleeding or anything there. Before I open the implant, I have to achieve the hemostasis so I can switch off the cautery. Though it doesn't affect much, but still we have to follow the manufacturer's instructions. It can affect the electrode's integrity, the electrical field generated by the cautery. Bipolar. इधर ये क्या चलो 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 डन see you have to achieve complete hemostasis. Watch with it.
Excuse me, sir. Can we use the bipolar cautery after we put in the implant?
Yes, you can. Even the monopolar doesn't affect much. So many studies done. But since, see, anything goes wrong, you don't follow the manufacturer's instruction, they may not reimburse.
Okay, sir.
Why to take chance? Spend 1 minute extra, achieve hemostasis, and then go. Yeah, wash. मेरे को दे wash. I will flush away all bone. Implant. See the field?
Excuse me, sir.
Yes,
Let's
please.
say, sir, in a cochlear implant patient in future requires another surgery like an abdominal surgery. And
Yes.
if they use bipolar cautery over there.
Yeah, can use. See,
or
the
monopolar.
cautery has been considered safe to use, even the monopolar.
Okay, sir.
Has been, but you have to respect the manufacturers, you know. But generally, it doesn't affect.
Okay, sir.
अभी है ठीक मैं कैसा हूँ केस ले रहे ना उसके बाद थारा हुआ नहीं मेरे को कोई दिक्कत नहीं see this the tie down holes made by Dr. Khanna. See, this is the best way of fixation. I would say most certain way. You can make a periosteal pocket also. But see, implant migration is a disaster. One should never take a chance of implant migration. Everything, whatever good work you have done can be ruined. So implant migration should not happen. You should rigidly fix it onto the bone. See this?
Yes.
So this
is proline?
Yes, most likely proline, you know. This is ethylene. What I will do, I will invert the edges of the ethylene. See this?
Yes.
They should not come in contact with the skin, otherwise they may perforate and invite infection. See this? These are completely fixed. This Sagicel will invite fibrosis over here and the proline edges will not come out. See this?
Yes.
Now, over the now, periosteum elevator.
It's a delicate implant.
This is the ground electrode for sitting. You will perceive. This is the ground electrode, which is going to go underneath the temporalis. See this? See this?
Yes.
And now finally, the electrode insertion, and believe me, that is the simplest of the entire steps. Once you have created this tunnel, wash. The electrode insertion is the simplest of all the steps. See, the last thing is electrode insertion. And that will be child's play because now you have to insert in a straight tunnel without any hindrance. I am removing this gel form. वो तो दूसरे वाला हाँ हाँ आराम से see we'll flush it again. See the tunnel?
Yes.
See the tunnel, and now direction of implantation is in the direction of the tunnel. See this?
Yes.
What are the forces? Oh. No, no, yaar. What's the first set? And the last part now is the implant insertion. See the implant?
Yes.
See the electrode array? There's a straight one.
Yes.
See the direction? See, it has to go along the floor. Can you see the direction?
Yes, yes.
Inferiorly directed in the lower tunnel. In the lower tunnel. Without any resistance at all, you can feel. See this?
Yes.
I can see no resistance there.
We can also feel.
Yes. This feeling is very important, you know. Once you feel the resistance, my all electrodes are in. See this?
Yes.
Give me the
tissue seal.
Yes. Tissue seal. Once you feel the resistance, you are supposed to stop over there.
Sir, is there any time period like for 1 or 2 minutes required for insertion of the
It has always been, advocated to insert slowly, so that you don't damage anything.
Okay, sir.
You don't push on the obstruction. That is the whole idea.
Okay, sir.
The whole idea is straight.
Don't push when you feel resistance.
Yeah, it's straight, yeah, right angle.
Should be smooth insertion.
And now I will see my periosteum coming all around. Can you see snugly fitting?
Yes.
Gentlemen.
And the excess electrode is also, you have made enough space for them. It will be accommodated immediately.
Yes. So see this fixation. Sealing of the round window, this round window and the cochlear is very, very important. Because that is otherwise the avenue for infection to go inside. Otherwise,
What he is giving you?
This is gel form.
Gel form, okay.
Gel form swells up more than its volume and keeps the things in place.
So this implant is fitting, going inside the bone of this length only, not more like the processor unit.
Pardon?
So जो वेल आपने ड्रिल की है उसमें जो फिट हुआ है इंस्ट्रूमेंट तो उसकी और डेप्थ में जाइए इसमें इतना ही रहता है लाइक सम आर गोइंग इनसाइड.
No. See, the length of the implant is 24 millimeter.
I'm not talking. So implant का ठीक है. ये जो वेल बनाया है इससे protruding ज्यादा लग रहा है actually.
This is not protruding. See this one?
Yes, sir.
Yeah. So the implant base is inside that.
Okay.
This is the small protrusion which is going to remain. This is less than 4 millimeter.
Okay.
The punched out thing which is there below the implant, it was into the bone.
Can you see now everything fixed?
Yes.
Cochleus will fix. See, this implant is fixed. Now, see, the study is very interesting. When the mastoid expands, you know, when electrode array is going to expand. What's my point?
Yes.
But it has been proven that the distance between the round window and this facial recess edge never expands.
Wow.
Again, what I'm trying to say, the distance between round window and the facial recess edge
not change.
Never expands in life. Whatever the mastoid size can grow, your electrode can uncurl whatever it is placed in the mastoid.
But not the electrode area which is inside the cochlea.
Inside the cochlea and outside the cochlea till
facial recess.
Yes. So I don't want that to be my electrode to come out after that, so putting some bone dust there. See this?
Okay.
This is so important to prevent electrode mobilization. Got my point?
Yes.
See, so tightly packed and it will become a bone. Now, I told you to keep this little overhanging to keep my electrode array curled. Can you see?
But suppose you have to do any revision in future, then this bone dust
you can drill away. You can drill away.
So, was in the revision surgeries due to this bone dust, the electrode will not come out of it on itself.
Why you are doing revision surgery to remove the electrode only?
So we don't know. There can be any reason, but
yeah. So then you need to remove the electrode. And see, my part of the facial recess is visible. Can you see?
Yes.
I will make it little more visible because there I don't need a bone dust. There I don't. I need bone dust here only. See this?
Ultimate.
And it works so well. This we now do in almost every case. It works very well. See now, my electrode is, the implant is in place. This is the ground electrode curl, and the entire electrode array inside the cochlea. You see? So smooth insertion in the inferior tunnel, directing right inferiorly into the tunnel towards the modulus. So that removal of the crista, the inferior edge of the round window, has changed the entire game. Otherwise, had I pushed the implant, it would first go and hit the modulus, then it would curl inside, and see how thin the osseous spiral lamella is, you have seen yesterday. So flimsy, so thin bone.
even this is the most common cause of tip rollover, boss.
Yes,
in
yes.
electrode.
If you go and hit some wall, what is going to happen? Now we have our audiologist, we can move on. Madam, can you give? Gloves on. So we'll check the impedance and MRT and all that. Any questions regarding this? Any suggestions or any different method of,
No, I think most of us are using same way and wonderful. NRT is done?
No, they're doing.
I think the most important part is to send the electrode into the scala tympani, and for which you have taught us sure and short method.
Good. So the impedance is good. We have checked all electrodes.
Very good.
So would like to see the flap, U-shaped flap, how much it is covering.
Pardon?
So the flap, mucoperiostal flap you have retracted.
That will cover everything because once we raise the flap that time, the tissue retracts. So it is always our policy to do some sort of undermining of the tissues.
So you have already done that.
In the beginning of the surgery, so that it doesn't fall short. Because now after implanting, we don't want to do any undermining, any bleeding or anything.
Very low impedance, it means very smooth insertion. Super.
So it was a smooth insertion because it was in the straight, tunnel.
Yes.
It was a child's play. Simple removal of the crista has changed the entire scenario. Just remove the crista because now you have a straight short tunnel, straight short insertion. It is not blind insertion. The movement first 8 to 10 millimeters, which you see directly in the tunnel, if it goes along the floor, straight under vision, it is going to curl inside the cochlea on its own automatically. The moment it starts hitting in the beginning, it is going to hit again and again.
Right.
And osseous spiral lamella is so flimsy, so fragile, the moment it hits, it fractures, and that is the highest level of cochlear trauma. Because the moment osseous spiral lamella is injured, the implant goes inside the scala vestibuli. It disrupts the scala media. Then the entire, endolimb, perilimb mix-up occurs, and that is the highest level of trauma. बीच में लगा है, कौन बड़ा है? So, anything? We have an implantation, the most experienced person with us today, Dr. Dubey sir.
Yes, yes.
Who has mentored hundreds of surgeons, I believe, and done many hundreds, probably in thousands now.
He is mentor of mentors.
Mentor of mentors.
No, but let me say very frankly that Satish is a phenomenal name in ENT, and apart from doing all difficult surgeries like teaching us mucormycosis, acoustic neuroma, all big surgeries which is surrounded by the big vessels, and ultimately he has shown us with endoscope several times, with Sial endoscope inside the cochlea also. He took a lot of effort to show us into the scala tympani, one of his workshop only. So thanks to you for teaching us and teaching us in a big way, and you take a lot of pain. We know that you have taken the antibiotic, anti-inflammatory, everything, and your voice has also changed, but still you are teaching us. Thanks a lot. Big applause to you.
Thank you, sir.
Still we have one case.
Yeah. So that is, I think, polyposis.
AC polyp.
Yeah, I have not seen the findings, but let's see the CT scan. It is induced. Already intubated.
Intubated, I think. I told Sanjay to start it, I think. I think it started, must have started.
Yes.
Finish it fast and then come, we'll wait for you.
Yes. So we'll go quickly. We have already discussed a lot of things in sinus surgery. बीच होना पाएगा. Naresh?
Sir, There is one question.
Yes, please.
Sir, some people advocate like 3 or 4 layer flap to cover the receiver stimulator. What is your take on that?
3 or 4 layers, the number of layers doesn't matter. Whatever layer, it should not be very thick. Otherwise, your magnet will not be efficiently able to transmit. So it should not be, first of all, very thick. Number two, whatever layer it is, it should be vascularized to prevent, necrosis and infection. And we have a good vascularized superiorly based flap.
Right, sir.
This is adequately thick to cover it. There is no issues.
Okay, sir.
साइड बनी ना अच्छा जो बनती जाती है अलमत होगा है इसका नेक्स्ट जो वेबिनार कीजिए ना वेबिनार तो करना पड़ेगा ना तो कुछ मैं मैंने जो टेस्ट करके दिया पिलर खड़े होने रात के समय भी कैमरा देखा था रोड पे गाड़ी चल रही है गाड़ी चल रही है रोड पे तो पूरा टाइम सर है डॉक्टर संजय 42 सर करंट नहीं करंट सर 22 channels that's current वो 22 channel एक और एसी वाले पे वो उसके बाद पता नहीं कौन निकला है लैपटॉप उठा दिया हैं
मैं इनसे पकड़ के
रानी लक्ष्मीबाई
नहीं, रानी लक्ष्मीबाई नहीं है, आपके साथ रह जाए बस।
We have been interacting so well since yesterday.
अते कब सीनियर हो गए ना। आज सुबह से मुझे थोड़ा टाइम वेस्ट हुआ ना, अब तो फिर से आ गई है स्पीड, अब अच्छा लग रहा है। अब देखो सामने वाले की भी तो तबीयत देखो, बेचारा इसमें भी काम कर रहा है ना। वो तो खड़े होते तो उनको तो उनको सडनली एड्रेनालिन
Question answer तो discussion तो जितनी मर्जी करा ले.
क्या होता है, सडनली ही doesn't keep track of time also. घुसते जाते that is good. I think the narratology में सतीश जाना मैं हो रहा है, टाइम आप फिक्स कर दो।
Jabalpur is a beautiful place. So I have been there once when I was doing my MBBS. We went to Jabalpur. It has got a beautiful lake.
You gave it to him, no? Time over.
Who belongs to the
Yes.
बेस्ट कैसी पॉलिप है, थोड़ा है तो अच्छा।
natural.
नर्मदा रिवर है, हॉल है, करेंगे तो इसको खोलेंगे। मैंने हर साल कुछ ना कुछ करती है, इस बार मैं तो ध्यान
टेटुआ नाम है इसका, सरनेम ही टेटुआ है, सरनेम इसका टेटुआ है, टेटुआ के नाम। मेरा पीजी में, मैं पीजी में सिलेक्शन जबलपुर ही हो रहा था पीजी में। ऑल इंडिया में क्या होता है, ऑल इंडिया से मिल लेते हैं पैथोलॉजी में, ऑल इंडिया से पैथोलॉजी में लेते हैं जबलपुर में। फिर ये इसका रिजल्ट आ गया,
कहाँ ज्वाइन किया? नहीं कहाँ पे आ गया?
नहीं ये वाले आगरा में नहीं है, कानपुर जो उस समय कानपुर तो टोटल 6 सीट थी।
अपन लोग के टाइम पे बहुत कम सीट्स थी, हमारे 70 गवर्नमेंट 70 सीट्स थी पीजी की,
670 तो
पूरे स्टेट में।
मैडम के यहाँ पे
किस्मत कहाँ किसको ले जाती है यार, मैं तो ये देखती हूँ डेस्टिनी के आगे आदमी छुपा है, मेहनत बस करो।
वो बड़ी सिंगल था,
मनीष सिंगल, हाँ उस समय डिपार्टमेंट में पॉलिटिक्स पीक पे थी,
इसलिए वो ऐसा ही है।
तो मनीष एक ग्रुप में था और एक मतलब जो प्रोफेसर और एसोसिएट के बीच में पॉलिटिक्स में एकदम पीक पे थी, और वो सब मैंने न्यूट्रलाइज कर दिया।
अभी हमने किसी को एमएस, हाँ बस
कितनी सीट्स है मैम? 12 residents.
Yes, 12 at a time. अच्छा
Senior residents.
क्या है जो भी है इन सब वर्कशॉप अटेंड कर सकते हैं, सब आगे बढ़े। encourage कर सकते हैं।
उस जगह सोच रहे हैं ना जैसे प्रेयर
तुम
करने
सब उठा रहे हो, आज जागो जा रहे हो, तो एनएमसी हेड ऑब्जर्वर कुछ लोग बैठे
हो
हुए
ही नहीं रहा।
Okay, hello.
लगता है इतनी शायद कीजिए कि आप नहीं कर पाएंगे। अबे क्या थोड़ा सा वहाँ भी थोड़ा सा ना सब छोड़ दिया था वैसे तो वो भी छोड़ दिया भोपाल में कभी भी नहीं काशी में केवल मैंने बियर ली थी बस और वो झांसी में 3 महीने बाद पहली बार ली थी। हेलो खाना खाओ खाना बहुत टाइम देते हैं बहुत टाइम वेस्ट करो तो अपने स्टॉल किसकी काली कर की है और देखिए क्या रखा है जिसको ना देखिए बताओ क्या क्या रखा है इंस्ट्रूमेंट काली कर जो और इंस्ट्रूमेंट बाकी मेडिकल एक पहले अरे फाइन में हरिद्वार होता अभी मैं वहाँ गया था ना राजा प्लास्टिक में नागपुर वहाँ में 2 सर्टिफिकेट मिले थे अच्छा अच्छी हुई तो बहुत अच्छी हुई और मैंने तो कैटेगरी सिलेक्शन किया था कितने कैटेगरी था उसके ऊपर थे मैं मालूम है मैं रात को पहुंचा 4 बजे मुझे नागपुर की ट्रेन भोपाल से जाती है ना क्या था 4 बजे पहुंचा और 4 बजे पहुंच के मैं रेडिसन होटल गया वहाँ पर मैं तैयार हुआ 5 बजे की बस में बैठ के मैं अमरावती गया डिसेक्शन करने कैटेगरी अमरावती था डिसेक्शन अमरावती मेडिकल कॉलेज था ना वहाँ 20 बॉडी थी वहाँ से 150 किलोमीटर तो गजानन काशिद नहीं अपना वो एक वन ऑफ द इंस्ट्रक्टर था खड़ा हो मेरे पास तो मेरे को फिर बताया उसने हॉस्पिटल मैं गुरुश यहाँ रह के आया था 15 दिन एक डॉक्टर इम्प्लांट डाल के तो छोड़ दिया था मैंने पूरा अपना रिवाइज किया तो हम उधर only 2 तारीख from head to hand patient लिखिए सब तो दोनों के ऊपर रखा इसको मोटे में कौन होगा कौन सा वाला वाइट वाला सुपर ब्लू वाला कौन मतलब सर पब्लिशिंग कौन
Hello, Satish.
Satish?
Yes,
Yes,
sir.
sir.
So
सतीश सर अभी कॉल पे हैं, अभी बात कर लो।
it is a pure. It looks like a pure AC polyp.
कंसोल था ना कौन सा अपना वाइट वाला कि ये ग्रे वाला ग्रे वाला
हेलो डॉक्टर पचौड़ी सर। हेलो
Hello. Yes.
यस सर।
Hello. Hello. Yes, yes. Yes, boss. So this is a 12-year-old patient. Okay. Most likely enterocoinal polyp.
Yeah, it looks like.
See, the CT scan is also tilted one. But what we can see is opacity in the maxillary sinus and continuing in the nasal cavity and going behind completely occupying the choana, and probably it has gone beyond and below the choana as well.
Yes.
So it should be enterocoinal polyp in a 12-year-old child. See this?
Yeah.
See, this is how it is from the maxillary sinus going into the choana, classical of enterocoinal polyp.
Yeah.
Though the CT doesn't differentiate into soft tissues, and MRI can definitely add on to the diagnosis if it is something else. Most likely it should be enterocoinal polyp. Unilateral disease coming out of the maxillary sinus, widening of the, osteometal region, and then going down in the, with no bone destruction anywhere. Can you see?
Yes.
No bone destruction anywhere, so it should be most likely enterocoinal polyp. The sphenoids are good. See, the ethmoids are good. Frontal is not hardly any pneumatized, the ethmoids are good. Opposite side is normal, and no bone destruction. So all findings are in favor of an enterocoinal polyp. Should be a straightforward situation. So enterocoinal polyp generally arise from somewhere in the antrum and going all the way into the choana, coming out of the accessory ostium. They always come out of the accessory ostium. So let's see. So it is mostly a job of microdebrider, I suppose, to remove this.
Main point we would like to ask is whatever means how to prevent the recurrence. That is the main point in this case.
Yes. So always communicate with the natural ostium, number one.
Yes.
Go to the site of origin. There are so many theories proposed, lymphedema, this, that, but whatever, the steroid irrigation works to prevent recurrence. And whatever additionally what we do to the site of attachment, we cauterize that completely to prevent that, negative pressure, lymphedema, all those phenomena.
Yes.
Maybe that is working or not, but steroid irrigation is something following in all cases and it works. So rarely you will find recurrence if you follow all these principles. Let's go to the surgical part.
Yes.
We can continue discussion.
Any role of allergy in these cases?
Hello?
Yeah. Any role of allergy in these cases?
Not really. These are non-allergic, polypoidal entity.
So it looks like it is the main etiology. I mean, suppose if you ask what exactly the etiology cause of.
So allergy is rarely unlikely to be the cause of AC polyp. Allergy is a generalized disease.
Yes.
Systemic disease. It's not going to affect a single sinus and present classically like enterocoinal polyp.
Previously, Dr. Satish. Hello?
Hello.
Hello?
Take one, sir.
Yes, sir.
Sir, previously we have seen in several anatomical museum, they used to put that this is the antral part, this is the choanal part.
They pull the entire one piece.
One piece, and that was, in the initial workshops of Dr. Kirtane, we used to see that they try to preserve everything and remove in toto. But the main cystic part, which is in the antrum, and which leads to the recurrence if incomplete removal is there. And I have seen that surgeons are drilling over there, the part, apart from cauterizing it.
So we will make sure that this doesn't happen in the antrum. We'll show you.
And the
See, the attachment is only in the antrum, rest is all luminal part.
Okay.
लो बॉस। अरे बाप रे बाप, मेरे को तो लो ना। हाँ तो अच्छा 2 मिनट पकड़ो, मैं इंस्ट्रूमेंट लेके आता हूँ। मेरे को पता है, पक्का सब पक्का लेके आता हूँ। या वही यहाँ बैठ
Eye exposed.
दोनों तरफ जो है वो आप करते हैं पेरिकॉन्ड्रियम दोनों साइड रखने से सर्वाइव करता है। ना तो करते ही मसल डालो, करो ना करो इसको। पीछे सपोर्ट नहीं रखती चेन को, पीछे रिच बनाया लोगों ने, ऊपर लोअर और अपर रिच बनाया। पीछे से भी खुला है, सामने से भी खुला है। Bipolar only in men. It is so.
Hello,
Sir, good evening.
yes, boss.
Sir.
Hello,
Hello, sir.
yes, how's the picture now?
Wonderful, sir. Very good.
Better than before?
Yes.
So now it's a different camera system.
Oh, okay.
Having known this as a polyp,
Sir.
this is a micro divider show. That's it.
Okay.
See the above sinuses all clear?
Yes, sir. Patent.
Simply dividing the luminal component.
Satish, recently I did an AC polyp and I divided it completely and I came out very happy from the OT, told patient's relative that I've removed the polyp. Patient said, where is the biopsy? Where is the specimen?
Yes, so you have to tell everything before.
Yeah.
What's up? Section.
Take it out and to show that and
Good brother, 40. 40. So I'm trying to break the luminant component from the antral component. See, it is free.
Yes.
Yes, boss.
Since it is a big component, probably we have to push in the oropharynx. And this is the antral component.
Okay.
Back. Section. Watch back there. This is a very funny disease. Nothing much is known about this.
But it's one of the most rewarding ENT surgeries. You know?
Yeah,
It takes very less time and it pays as equally as ethmoidal polyps.
Some repair, sir. ये check कर उसको palette को. See this component?
Yes, it's looking like an angiofibroma from here, boss.
Oh my God. Section. Section का. Retract the palette now. So big. Some attachment somewhere. Section. Looks like it is not free so far. So funny. Hello?
Yeah. Yes.
Hello.
Sir, previously we used to rotate the whole of this tumor.
Yeah.
And then we pull it.
Okay.
And it comes out from the root.
Yeah. That's what the sir was telling. What's your mistake? Just have patience for a while. So it will wash. पतला गया. Not so big. पतला section.
Some of the tumors are relatively soft and some of these polyps are relatively harder. What is the cause?
Yeah, so that's why I told you, nothing much is known about this anthracoinal polyp entity. See another attachment there.
Yes. This is the attachment.
Blood divider.
Hello.
Yes.
Just an announcement. So by 8:30 we will be having the inaugural function. That is a very small function with the felicitation program. And I will request the delegates and those who are not here, convey them please that they should be here so that we are worried that the audience will have to be full house. Because we are having HMC member over here, Haryana Medical Council member will be here and will witness how many members are here. Then only certificate will be issued. So they are very stringent in this session. So my request has to be accepted by all. Please. लिख दे हाँ ये लिख दे लिख दे प्लीज क्योंकि ये हम लोग कहें कि हाँ भाई हम लोग 250 बंदे थे और हम 250 सर्टिफिकेट उनसे साइन करा लेंगे बिकॉज ही इज वन ऑफ द सिग्नेटरीज इन द सर्टिफिकेट तो वो पॉसिबल नहीं होगा मेरे लिए एम आई राइट
या
सब मत डाल
नहीं मैं जस्ट कह रहा हूँ कि जो पीजी स्टूडेंट्स हैं हम जो कन्वे कर सकते हैं कोई नहीं थक गए हम लोग भी थक गए सब लोग थक गए आई नो दैट बट दिस इज एसेंशियल प्रोग्राम ऑफ दिस वर्कशॉप मेरे ख्याल मैं सर डॉक्टर सिंगल इज विटनेस टू व्हाट हैड हैपेंड अर्लियर विद एचएमसी वी हैड लॉट्स ऑफ प्रॉब्लम रिगार्डिंग दिस क्रेडिट पॉइंट्स Satish, you can continue, please.
Yes, boss. See now that's the component free now. Back. बड़ी फोर्स सेक्शन नीचे बेटा या बड़ा सेक्शन खींचता है So now this is free from this side. Wash, no wash. Yes, now we can pull from behind. Tell me. Section go. See this?
Yes.
This was hanging down in the
nasopharynx.
तो रस्सी चाहिए रस्सी Just wash. So we remove the luminal component completely. Come later. Could you see the luminal component out?
Yes, sir.
चल रहा है क्या कम लेटर? सेक्शन नहीं चल रहा है, क्या नहीं चल रहा? बताओ. Okay. Action. Sir? Should. Section. Wash. So now the field is good. Wash kar. Really. So this?
Yes, sir.
That is the throat pack. And that was the component which is out. Now focusing on the antral part.
Antral.
Give me 70. 60 is a blade. So our job is to thoroughly see the mucosal attachment. So this the antral part?
Yes, sir.
With the 70 degree now. How do they? See, attached on the posterior wall there.
Yes, sir.
One put. Is such a broad attachment into the antral cavity.
Yes, sir.
What I am removing is the underlying periosteum.
Yes, sir.
Give me a mop. Bada wala. Mop.
Sir, one more announcement. State IMA President Dr. Punita Hasija from Faridabad, she will be also here. One of the guests. And our civil surgeon will also be here.
So this is just a sort of mopping inside the sinus. Backbiting. That's the part of the uncinate. Can you see?
Yes, sir.
This is important to prevent the recurrence
Yes.
of later. Read. See, this always comes out of the accessory ostium. If I don't remove the uncinate, this will never communicate. अंदर मांगा अंदर पकड़ Yes, wash. इसको करते पूरा नहीं ये था ये लगा. So this is irrigation inside the sinus. Let me show you. Yes. Look. Yeah. See now the irrigation formed within the sinus. Yes. What else? See, this mucosa is good everywhere. Here where it was attached, I remove the periosteum. Hello? Yes, sir. Over there, provider. And that is something work very well to prevent the so-called recurrence. Remove the underlying periosteum alone.
Packing for a day is good or not?
Pardon?
Packing for a day will be good or not?
Yeah,
For the patient.
yes, for a day.
Yeah.
Marocel. Just I will give it a Marocel map and I don't think anything extra is needed. See the wide medium middle enterostomy, remove the uncinate and communicate it with the natural ostium. That is the most important step. Had I not removed the uncinate, it could come back again. Because that is an accessory ostium. See, I can mop very well now. Now this is the natural ostium which is vibrant. Can you see?
Yes, sir.
Nothing is going to happen. Now we'll irrigate for some time and then follow up. That's it. Cobbletter. So it is done. Doesn't need anything to be done.
Dr. Satish,
Yes.
do you see the polypoidal mucosa and the anterior part and along the floor of the
Anterior part of the
of the maxillary antrum, anterior inferiorly?
I don't see where it is.
Acha, acha. There's some mucosa.
No, no, it looks fine.
Maybe normal. This.
Yeah, it is all normal. See, this is periosteum. See, this is periosteum. Mucosa I have removed here. This is just periosteum now.
Okay.
So there is no question of leaving behind anything.
Sir, kindly demonstrate the sublabial enterostomy in this patient.
Okay, you want how is this to be done?
Yes, sir.
Okay, let me show you the simplest way and trocar way. Okay, no? See this. Stay in the mid pupillary line.
Okay.
Let me show you. This is 70 degrees. Stay in the mid pupillary line here. ये क्यों हाथ कर रहे हो? See here.
Okay.
A centimeter above the gingival sulcus and I am in. See this? Leave it. Leave it, throw it. And I am in. See this?
Yes.
Now what you can do, उठा, sit down there. I will remove this trocar and cannula both.
Okay.
And pass my debrider. See this. This is red 40.
Yes.
Red 40 had a liberty to somersault inside.
Yes.
See, it can go to any nook and corner of this sinus.
Yes.
It has a full freedom now.
So this remnant mucosa also debride.
Yeah. See this? It has a full liberty to go anywhere in the sinus. See this?
Yes.
And now I remove that wound will heal in no time. See, this is just a puncture.
Okay.
It heals in no time.
No need to repair.
No, nothing, never. Never ever. Never ever any need to repair. Wash it. Give me a marrow cell. See this?
And sir, I would like to put steroid antibiotic cream to this marrow cell also.
Yeah, steroid.
Yeah, steroid with antibiotic.
Yeah, you can add on antibiotic as well. There is no harm.
Yes.
Body ball flow. And see, this marrow cell can be used as a mop anywhere into the sinus. See this?
Yes, sir.
Now completely cleared at places where the periosteum is also removed.
Sir, what about the prognosis to be told to the parents?
Yeah. They enjoy good prognosis. They really enjoy good prognosis. But follow them with a close follow-up, yes. Regarding recurrence. Yeah, regarding keep them under close follow-up, steroid irrigation. Generally doesn't recur. But if you do and forget some mucosal left, can again balloon out.
But the most of the children are not cooperative for irrigation even.
So don't just keep them under follow-up and steroid irrigation. See this?
Yes.
This is done. Nothing else is required now. Wash karo. Irrigation. This?
Yes, sir.
Just we'll leave a pack and we have a good, access for the topical to go inside the maxillary sinus and it works well.
Thank you, sir.
Thank you. Thank you for your attention.
Thank you.
Disconnect.
Thank you, Dr. Satish.
Welcome to Disconnect. Yes, sir. Thank you.
You have to be here, take some rest, and we are inaugurating our function at around 8:30.
Continue. Thank you very much for everything.
So please be here after taking a break.
Sir.
By 8:30. Yeah, we will start with the inauguration around 15-20 minutes. अगर सब कुछ सुचारू रूप से चलता है तो So tomorrow we are having a few cases, juvenile angiofibroma, nasopharyngeal angiofibroma, and then we will have thyroglossus cyst, parotid, ear case, ear surgery, JNA. JNA क्योंकि जिनके थ्रू आया है उनको दोपहर में जाना है तो he wish कि भाई he should be there. तो उसके बाद हमारे पास पैरोटिड है और एक पेट्रोसेक्टमी विथ कॉक्लियर इम्प्लांट, सब टोटल पेट्रोसेक्टमी विथ कॉक्लियर इम्प्लांट. तो अभी और भी एक दो और केसेस है, मेरे को खुद नहीं पता. स्लीप कोशिश करूंगा, वी विल स्टार्ट विद स्लीप एंडोस्कोपी, बट इट इज अ पोस्ट ऑपरेटिव केस जस्ट टू शो दैट हाउ वी आर डूइंग.